Yes, Prof, we can see.
Okay. Okay. So based on our agreed schedule, I have actually 6 components, right? First is concept and applications. Second is synthesize determination in interventional studies, mainly in the clinical and community trials. Number 3, um, synthesize determination in observational descriptive studies like prevalence incidence studies, and then synthesize determination in the uh, observational analytical studies, for example, like cross-sectional, case control, cohort, and so and so. And other tools are actually, I added actually, where one is the synthesize determination by using risk assessment, right? For example, relative risk, odds ratio, how are you going to calculate synthesize? The last one is tips and tricks and also the do's and don'ts. Because as I'm given like one morning, I'm thinking like this, I will go first 4 lectures, right? Other 2, I will cooperate into it. The risk assessment, let's say in the observational analytical studies, I will put it together, right? And also tips and tricks, do's and don'ts. Each and every session, I will tell you these are the tips. These are the do's and don'ts. Because in synthesized calculation, like Dr. Chu just now mentioned rightly, uh, uh, some things that you need to look into it. For example, effect size, for example. This kind of thing, you need to really have kind of understanding plus how to go for it, right? So these 2 topics, last 2 topics, I'll put in incorporate into this, right? Into all four of them, 4 lectures. I put it. Don't worry. Everywhere I will tell you these are the do's and don'ts, right? These are the tips, and also how to measure, how to calculate some stuff by using risk assessment, right? What I want to add is I want to have an assessment session. My habit is whenever I give lectures, even in regular courses or like workshop like this, I have assessment. But the reason why I do assessment is whether my teaching the participants can follow or not, students can follow or not, they understand or not. So by putting these 6 into 4, right, and I add the assessment, right, then I will know that how much you can digest my the what my explanation is, how much you understand, and so on. Is it okay? Right? Is it okay? So that's the flow of my discussion, and of course, if I change to 4, maybe one session I may go around, let's say 45 minutes, right? And then I give you a break because the human brain cannot absorb more than 45 minutes, right? So 45 minutes, I stop, right? Let's have a kind of fresh and well-motivated kind of discussion. You can stop me anytime. You can ask me questions, but ask short to the point, right? Because we have limited time, right? As I mentioned, I will open also the chat box. Whatever you want to ask me, you can ask me by chat box also. Okay, okay, okay. So uh, let's start. First, I want to explain is concept and applications, right? Why do we need synthesize determination? How are we going to apply it, right? Okay, okay. When we determine synthesize, all our researchers, starting from undergraduate till PhD level, right? We ask ourselves, why do we need it, right? Synthesize is just a guide, right? You come from different disciplines, according to Dr. Azifa. Some are medical based and some are other health related and others, right? So we have to start thinking about why do we need it, right? Remember, statistics is a tool, right? When you drive a car, right? When you drive a car, what do you have to do? You need to think about your direction. You need to think about your tools. What are the tools? You have your gear, you have your steering, you have your brake, and so and so. Same thing in research, right? Like study design, where you are going to go for it. Are you going prospectively? Are you going retrospectively? Are you going cross-sectionally? These things actually, when you think about it, That is our direction, right? By study designs a direction like driving a car, and you need to apply tools. The one of the tools is actually the major tool actually is statistics, right? Under statistics, like Dr. Chu just now mentioned, when you start a study, what is the number of sample I need to answer a research question? Is there any significant difference of mean blood pressure between drug A and drug B? Is there any association between smoking and heart disease? When you want to answer your particular research question with hypothesis, of course, testable hypothesis, then you need to have minimum required sample size. I use the word minimum required sample size. It is minimum. It is required, right? So we are not really fussy, right, about the numbers, but as we are in a as we are researchers, we need to have statistically sound, scientifically right, what you call ethically right, scientifically right sample size. If you have sample size which is inadequate, right, you have flaws in study, your sampling method is not right, not applied, your proposal, sampling method is not included, and sample size is actually haywire. Some people say that I want to do clinical studies, clinical trial, 50 per group, enough. I want to do observational study, 100 per group, enough. What is the basis, right? So just rule of thumb without any scientific and statistical background, then if there are flaws in your methodology, you will not be granted the ethics approval, right? These days, ethics is very important, right? So, like people like in Dr. Chu and some of you in clinical setting, community setting, you know very well that if you cannot answer such question with that particular number of sample, which is under power, which is inadequate, then how can you get ethics approval? Without ethics, you're gonna conduct study, you're gonna publish, and so on. For postgraduate students, very serious, right? You're gonna start the research, right? You're gonna submit your thesis and so, right? So minimum required sample size, right? When I started joining as a junior lecturer in the research and ethics committee, I gave the committee a simple kind of guide. There are three categories I give, very simple. First category is the research, the people ask, do I need to calculate sample size for my study? So my answer is very simple, three categories. Number one, first category is compulsory. You need to calculate sample size, compulsory. Which kind of situation? Whenever there is a testable hypothesis, right? Looking for the difference of mean weight between what you call the mean BMI between active and inactive group. Looking for the association between what you call the lifestyle and the obesity. Whenever there's a testable hypothesis, you need to calculate sample size, right? Like Dr. Chicha mentioned, people publish, you can get the information. If people do not have, people haven't published, you can claim that my study is the first in the world, first in Asia, first in Malaysia. No problem, you can claim. Then you need to have some kind of preliminary work and you calculate sample size back, or you may have to predict some situation. Predictions, of course, last, right? So these are the things that we need to be aware of, right? So first category is compulsory. You need to calculate. Second category I put as unnecessary, right? What do you mean by unnecessary? For example, some animal-based studies, for example, a lot of guidelines available already. Some what you call bioequivalent studies, guidelines already based on the particular expert bodies and they have done it, right? Then we can follow the guidelines. However, if there are still possible information and testable hypothesis, you may still calculate it. For example, in number of I'm not talking about human research ethics committee. Human research committee normally, most of them, they ask for some size calculation. Whereas the animal-based committees, animal-based research ethics committee, some may ask, right? Of course, like people, we always discuss about it, right? Human talks, but animal doesn't talk, right? But anyway, you need to have you need to fulfill the animal-based research ethics. You need to fulfill the guide because the requirements, right? So if you can calculate, but normally animal-based studies, right? their sample size is relatively smaller because of many reasons. You can go to website, there are guidelines, right? So they can see. So sometimes unnecessary, but if there are information and the testable hypothesis, you may go back to the first one. It may become a compulsory kind of thing. So that is in the middle kind of thing, right? The last one is no clue. You have no clue to calculate sample size. For example, people work a lot on cell line based studies, right? These days, clinicians are now going very far ahead. Clinicians, they do not only clinical research, they combine with basic medical sciences research, combined with public health research, right? Some leading clinicians in the world, in Malaysia, right, in Asia, you can see it. They have a combination of either clinical and public health or clinical and laboratory-based medicine, and they are really good. Those people, they understand very well, right? They do a lot of teaching, self-taught, right? I know some people in Malaysia, right? My good friends, they are very good in the what you call both, right? What you call not only clinical but also basic medical science together with the research methodology statistics as well, right? So that kind of cell line based studies, how are we going to create some cell line, millions of cell line, right? Uh, so there is no clue, no way to calculate, right? Example, right? There are many more, right? Because of time, I will not go very much detail about it. So these three categories, but majority of us fall in first category, majority, right? And so you need to ask yourself, right, which category you falls on it, right? But unless you develop something, right? Maybe you may escape from sample-size determination. However, remember, even you develop, after developing something, you need evaluation. When you do evaluation, you need to have number of samples. You need to collect sample to evaluate. For example, very simple. You develop a test kit, like even COVID-19, right? Was a test kit, or you need something you develop, right? Even a questionnaire, right? After that, you need a validation. You develop and you don't validate. Who will use your what you call the measurement tool, right? Very simple, common sense, right? Statistics is common sense, right? So uh, these are the things that I want to highlight, right? I'm giving you some concept and then coming to application. So whenever you calculate sample size, these are important things where you need to know about study designs, you need to know about statistical application, and of course, information from literature, right? From literature, that is very important. If there is no information on literature, you maybe do the preliminary study, pilot study, and so on. You calculate. Just for information, some studies are very rare studies, right? You cannot find in literature. You may do a pilot study. In your proposal, you can write that the sample size will be redetermined after obtaining the result from pilot study. You do it, you recalculate the sample size. Trust me, hundreds of students graduated already. Uh, Hundreds of researchers published their findings already by doing that way. You need to be honest. You mentioned honestly say, I cannot determine sample size during this proposal stage. However, uh, after a pilot study, I will redetermine the sample size. By that way, many ethics committee, many research committee, they give what's called green light, and researcher must do back, right? So especially like MED program, right? Master of Medical we call Science and MED program. I found many, right? They have to do like that. They don't have information, right? Okay. So very important, quality of strength of statistical inference depends largely on the size of the sample selected, right? If you remember, I cannot go very detailed about because of time, but if you remember, what you call the, if you want to estimate your population parameter by using sample statistics, where you do the confidence interval, I will come to that in a short while, right? Then sample size is very important. Why? Because of standard error, right? Standard error equals standard deviation divided by square root of n. If you all remember, standard error equal standard deviation divided by square root of n. If the sample size is very small, your standard error is very big. Standard error is involved in calculating confidence interval. For those who are new to statistics, right? Confidence interval, you are estimating the population parameter. Confidence interval. Confidence interval wide is no good. Precision is very poor. Sample size, confidence interval narrow is good. So just for information, if everybody wants the narrow confidence interval because you are the good precision. If your sample size is small, your standard error is very big, your confidence level is very wide, then even sometimes some postgraduate students, some researchers, some lecturers cannot publish their papers because confidence level is so wide. I'll come to that after this, right? So for that, sample size is one of the parameters, right? Not only sample size, there's standard deviation, right? So I will touch on it. So please bear in mind that back to basic, right? When you talk about the estimating the population parameter, where standard error is the most important parameter in our statistics, right? These days, standard error is represented by confidence interval. So if confidence interval is very narrow, very good, the precision is very good, right? So to get the confidence interval narrow, you need to have a small standard error. To get a small standard error, you need to have an adequate sample size and other factors. I'll come later, right? So to get some idea, concept, right? Why do we need to calculate sample size, right? Don't follow what other people say. I need to calculate sample size. You have to ask yourself, right? Why? That is the way that you improve yourself, right? And look for the solution. Approach those who understand, right? Okay, so as I mentioned, when we talk about sample size calculation, first thing you need to revise back yourself is study design. You need to understand about study design. Without understanding study design in our medical and health science research, you have difficulty to understand about how to calculate sample size. So I'm going to divide into two parts. First part is I need to revise, I need to revisit together with you. Many of you have learned before, right? Many in this, including Dr. Chu and Dr. Azifa and others. I don't know who are joining this workshop, but I believe that many of you have learned before. Many of you are new. So let's unlearn, learn, relearn, right? If you are unlearn, learn. If you have learned, relearn, right? So let's revise. So I'm going to revise for you two parts. First part is I'm going to revisit together with you study design. Must understand, right? Number two, statistical concept, right? The statistical theories. So I will touch on these two. If you understand it, grab it within this half an hour, 45 minutes, right? Then we go for some calculation by all hands on. I forgot to mention, actually, you need to download two software. Okay, well, when you have break time, then can you download two software only? I will use today, many software available. One is Power and Sample Size. Power and Sample Size. Just type in the, just type in the Google, Power and Sample Size. You will see the list. Go to the University of Vanderbilt. University of Vanderbilt, there's a Power and Sample Size. Just click it, within 5 minutes you can download already. Another software is very classical old software, but very good software for medical studies. That is the EpiInfo software. Again, go to EpiInfo, type EPI-IFO info, EpiInfo, EPI-info, info.
I share a link to our website, Prof. Syed Hatip, with all these three software. I just put it in the chat box. Yeah.
Very good. So, Dr. Chu, how many PS software and
we have PS software, EpiInfo, and also G-Power. So you may get all three on the same website.
Okay. Another very good one of the best is actually Starter software. But Starter software is maybe if Dr. Chu and Dr. Azifa conduct one more workshop, I will introduce you Starter software. Starter software is everything inside there, some site calculation. But you need to have a Starter software. So most of our leading universities and the CRC all are using Starter software. In Starter software, sample size calculation is so many things. So of course, we don't have enough time. So one day you can one day workshop kind of sample size using Starter software. So I can guide you how to do it. Thank you, W. 3 more than enough. Thanks very much. So now let's start with study design. After that, go to statistical tools. This is a very good pyramid for you to understand, right? So this pyramid I will come later, right? Here I'm going to just touch and go because as I mentioned, concept and application with limited time, I have to touch and go, right? So what are the study design in medical and health science research? Number one is systematic review and meta-analysis. I think all of us, especially young generation like you cannot run away from systematic review and meta-analysis. 20 years ago, 25 years ago, right, when I started becoming a lecturer in this particular area, this is not there yet. Systematic review and meta-analysis is not there yet. Maybe around 15, 20 years ago, it came in, right? So that is now considered as by hierarchy is the top. I will explain a bit, right? Second one is interventional study. Some people call experimental study, but maybe better is interventional study. That is clinical and community trials. This is considered as gold standard. In clinical trials, as clinicians like Dr. Chu and others, they know very well, randomized control trial, double-blind, randomized. If I have to tell exactly, double-blind, randomized control trial is the gold standard. Even though system review and meta-analysis, they are by hierarchy higher, but still gold standard is double-blind RCT, right? Of course, don't forget when you do clinical trials, you don't forget community trials, right? People always think about community trials, actually something like you tend to forget. Actually, both trials are very important. Community trials is also very challenging, right? Third one is observational analytical studies, 3C. Very simple, 3C, cohort, case control, cross-sectional. Cohort is highest, especially prospective cohort, it is next to RCT. If you cannot conduct RCT, next to do is prospective cohort, followed by case control, followed by cross-sectional. So because of time, I cannot go in all detail, but I will touch and go. Cohort study, you must know at least three. That is prospective, retrospective, and historical cohort. In this workshop, because of time, I can only introduce you prospective cohort. Case control, another three again, matched, unmatched, and nested case control, right? If the case and controls are matched based on criteria, that is matched case control. If it is not matched, unmatched case control. These days, we are not worried much about matching, right? We unmatched also no problem. In old days, softwares were not strong. Computers were not fast, so we have to do kind of match study to eliminate confounding. Age and sex match, clinical stage match, so and so and so and so. These days, clinicians also they don't worry much about anymore, right? The people like Dr. Chu and others, you may know it, right? Last time, Mendel-Hansel is very popular, right? These days less, but still some clinicians really what you call the like it. Mendel-Hansel, one of them, there they are going to stratification analysis where some criteria, right? So my point is, case control study, these days we don't worry much about what you call matching, right? Last time, even case control studies, this kind of textbook, right, talk about match and match case control study. You can find it in the 80s, right? Maybe at the time some of you not born yet, right? I used to read, right? So match and match, right? And nested case control, very interesting study, but study design, but maybe I cannot introduce here. You have to go very detailed about it. And then the last one is cross-sectional study. Very interesting. Cross-sectional studies are, even though the hierarchy is the last of observational analytical studies, right? However, cross-sectional studies are actually very common, right? Classical cross-sectional study, comparative cross-sectional study, in textbook, in website, some people call retrieved studies. They call it comparative cross-sectional, but never mind, just call comparative cross-sectional studies. And many people ask about diagnostic tests. I think many of you are familiar. Diagnostic tests mean like sensitivity, specificity, positive and negative predictive value, accuracy, LR positive, LR negative, so and so. Last time, where to put this design? Right? But the epidemiologists, statisticians have come to the agreement that diagnostic tests are under cross-sectional studies. The last one, questionnaire-based studies. Majority of questionnaire-based studies, either validation study or the implementation study and so on, they are under cross-sectional studies. So these are the common ones we pick up, right? So just to clarify, observational analytical mean observe, more analysis with testable hypothesis, right? Interventional mean intervene. You intervene something. right? Either by clinically or by community, right? Maybe giving the drug and placebo, or in a community, giving the, let's say, different kind of what you call the community-based input, and look for the difference. For example, obesity, you may give the one group is diet control, another one is diet control plus health education, another one is diet control plus something, maybe pills and so, right? And the last one is control, right? So that kind of thing, big community trials. There are many community trials in the world, like starting from Framingham and what you call Mr. Fit and all these what you call trial. You can go and see it, right? These years also there are a lot of community trials, right? So interventional, observational, analytical. The last one is observational descriptive, right? There can be two areas. One is population, one is individual, right? Individual is case group and case series. People ask, case group and case series, is it research? Of course, it's not a peer review research, but they are very important for hypothesis generation. Without clinicians discover the case of what you call the vague viral illness like that, with a loss of appetite, what is a fever, right, cough, and other symptoms in 1981 started, if I'm not mistaken. 83, they found out that there was a human immunodeficiency virus. Without clinicians writing case report and case series, how can we do today HIV research? How can the clinicians treat HIV patients and so on? Case report and case series are not the peer review full-fledged research, but they are very, very important for hypothesis generation, treatment, and so on. So among all of you, if you want to write case report series, never ever hesitate. Please write, right? You don't need to have an ethics approval by presenting. Just apply to ethics committee, right? Just your case report case series, submit it. If they ask, you present. Otherwise, no need presentation, right? Of course, I am chairing UNISA Human Research Ethics Committee for around 4 years, right? And case report case series, no need to present. Just submit, right? We encourage a lot of clinicians to write case report case series, right? And the next is population-based. You need to understand very well prevalence incidence studies. That here, sample size calculation is extremely important, right? So if you have prevalence incidence studies are morbidity studies, right? If you know, they're morbidity and mortality. In morbidity, there are 4 measures. You need to know about epidemiology also, right? 4 measures. What are the prevalence, incidence, primary attack rate, secondary attack rate? These are very 4 important morbidity measures, right? Among them, right, the prevalence incidence studies are very common among our medical sciences researchers, right? So how to calculate prevalence incidence study? So my hierarchy here, I forgot, the interventional, observational, the analytical, and observational descriptive. Over the years, people realized that, right? Over the decades, people realized that when you do the interventional study again, right, reinvent the wheel again, it is very costly. Why don't we look in the literature, right? Publish articles in the world, similar input, similar approach, and so on. Why don't we go into literature systematically, right? Systematically go into it with a checklist, proper checklist, and we review it. And after that, we do the statistical analysis to come up with that drug is better than B, or drug B is better than A, or drug is better than placebo, or diet control is better than the exercise, and so on, right? That is called systematic review and meta-analysis. I explained you last, right? So systematic review and meta-analysis are these days, you cannot run away, right? You know that your generation, you need to know about it. If you want to do something, try so something, don't start it first. Go to Cochrane Center and look at it, right? The Cochrane Center is the one that I think in Oxford, right? Oxford, they how to call it? They do all these systematic meta-analysis, especially for trials, right? If it is people have done already and so on, you may not need to do it. So you can write a concept paper, right, to them, and within 48, 72 hours they will reply you, right? And then your proposal is rejected, or people have done. Your proposal accepted. Your proposal is partially done, and so and so. So these days, system review and meta-analysis, of course, have hierarchy is the highest based on the evidence, right? So we all must know here how to calculate sample size, right? Observation, I start from the bottom. Observational descriptive studies, right? I forgot to mention, by hierarchy, top is the best, system review and meta-analysis, lowest is the least, right? It doesn't mean that there's no scientific merit, but it is actually what you call by hierarchy, right? So how are you going to calculate sample size for observational, descriptive, analytical? How are you going to calculate sample size for interventional studies? Of course, I cannot cover in this workshop for system review and meta-analysis. Rule of thumb, people always ask, how many studies do you need for system review and meta-analysis? There is no hard and fast rule. People, some even very experienced reviewers mention that even 2 is enough. Even 2 is enough for system review meta-analysis. Of course, there are arguments, right? Okay, so I will go back to the what you call the pyramid. The pyramid is actually this pyramid is very nice to understand, right? If you look at it here, the one that I mentioned, it has a 2 level. One level is called filtered information. Another one is called unfiltered information. What do you mean by filtered information, right? That is actually already published already. There you are going to go into it, and you filter by your checklist, right? And this information, and then you are going to do the what you call the systematic meta-analysis. This is by quality of evidence is the top, right? If you look at here, critically appraised individual articles, right? Evidence synthesis. Synthesis mean statistical synthesis mean meta-analysis, right? So meta-analysis and the systematic review is the top. It is the highest, right? Hierarchy, right? For these days, right? For information, I'm going to give a talk on the meta-analysis and systematic review next month, right? 23rd or 24th next month. If you want to join, one day only, 2 speakers. My colleague will talk about systematic review. I will talk about meta-analysis, just to grab how you understand, right? For especially, we aim for especially the new, beginners. We have done once already. Many attended. It's the second time, right? Okay. If you are interested, you can go to website of UNISA, and inside there, what you call that advertised already, right? Okay, and then down there is unfiltered. Unfiltered means you are doing the new studies, right? Where starting from even the expert opinion, going to case control, case series, the cohort, and so till RCTs, right? But remember, RCT is still the gold standard. So I finished my first component of introducing you study design, right? This is a design. Any question you want to ask? My tab is I just don't want to talk alone. I want you to talk also if you want to ask, but short to the point you can ask. Anything you want to ask? Participants, are you clear so far?
There are a couple of questions. Yeah. Sorry, go ahead. Go ahead if you have something to ask directly. Go ahead, please.
Assalamualaikum, Prof. Said and everyone.
Yes.
I'm Dr. Malini from UNISA.
Dr. Malini, yes. Okay.
Yes. Can you explain about case control study? What is different between unmatched and nested?
Okay. In that case, Dr. Malini, I will come to that one by one. Here at the back, I will come to that. Can you wait for a while?
Okay. Thank you, Prof.
Okay. I don't know that Dr. Malini joined. Okay. So now, why do we need to know about this study design? Why? Now, because our topic is sample size determination, right? So I will explain you. This flowchart is very easy to understand. This is my own flowchart, right? For teaching, especially for postgraduate students, right? So study design, you have just now I mentioned about intervention. I take out the what you call systematic review meta-analysis, right? So here we have an interventional study, observational, descriptive, analytical, right? So when we talk about here, we need to talk about, I forgot to put the slide actually. You can jot down 5 points, 5 tips. Remember, I told you tips and tricks I will tell you on the way, right? So please jot down 5 points. I forgot to put the slides, right? 5 points is your 5 tips. Number 1, whenever you talk about calculation of sample size, number 1, you ask yourself, what is the research question? Number 2, what is the study design? Number 1, what is the research question? Number 2, what is the study design? Number 3, is it mean or proportion? Mean or proportion? Number 4, if it is mean, how many means? If it is proportion, how many proportions? Number 5, is it an independent or dependent sample? That's all, only 5. This is my tips. If you understand these 5 tips, you can answer sample size, no problem. I repeat, number 1, what is the research question? Number 2, what is the study design? Number 3, is it a mean or proportion that you are interested under your study? Number 4, if it is mean, how many means? If it is proportion, how many proportions? Number 5, is it an independent or dependent sample? Okay. Got it? Okay. So here I'm going to apply, right? So first thing, I start from very simple, the bottom, observational descriptive, right? In observational descriptive study, right? Okay, wait, no. Maybe I better come to this table after I explaining about the study design. Can I come back after this? Right? You keep that five tips for a while, right? Okay. So I will come back to this what you call this flow chart, right? Okay. So I'm going to touch one by one, touch and go. Number 1 is RCT, right? Remember interventional, observational, descriptive, analytical, observational, descriptive. So RCT, I'm going to explain you what is RCT. RCT means randomized control trial. You randomize the patients, control, that is a control group, right? It means that drug A and drug B, A is control to B, B is control to A. Or drug and placebo, drug and the placebo is a control group, for example, right? Trial means you have a trial, randomized control trial. That is RCT. As is the gold standard, particularly if I have to say, what do you call it? Is the double-blind randomized control trial. Blinding is very important, right? Okay. So whenever we talk about the research design and research question. Research question is effectiveness of new antihypertensive drug, RD, research design and randomized control trial. Let's see here, right? It has 2 major study designs under RCT. There are many more, but these are 2 major ones. First, parallel. What is parallel? 2 groups are parallel. You got the eligible subjects, right? You got to do the randomization, right? And you got this 2 arms. Start from 2 and more arms, right? You have your test and control. You have a pre and post test assessment, treatment assessment. Here also pre and post treatment assessment. In other words, here, for example, you have a new drug and usual drug, right? Drug A is a new drug, drug B is the old drug, right? You compare between pre and post, right? So your research question is, coming to the research question, is there any significant difference of blood pressure reduction between new drug and old drug? That is a research question, right? So you are going to apply here, basically within group is, if you know, is the PET test or Wilcoxon sign rank test. If it is between group, you may do the independent T test or MEFID test if it is some size small, or you may run the repeated Mason ANOVA. For example, I'm talking about statistical analysis, but you need to calculate sample size for that, right? So you have to calculate sample size. Within group, you can sample size, you got the calculate sample size. Between group, what is the significant difference between 2 groups? Blood pressure reduction. This is the basic of understanding about how to calculate sample size. So your research question is any significant difference of mean blood pressure reduction between 2 groups? Study design, randomized control trial. Mean or what you call the mean proportion is the mean, right? Mean difference. How many mean? 2 means, right? Blood pressure reduction, mean blood pressure reduction in new drug, mean blood pressure reduction in the usual drug, right? The 2 means. What is the what you call the independent or dependent sample? If it is within group is of course dependent sample, related sample together, but between group is independent sample. So these 5 points will lead you. So basically, you are going to calculate sample size based on the 2 independent means difference, right, between new drug and usual drug, the blood pressure reduction. Another study design is actually very popular also, parallel design. The previous one is more popular, because it is a choice of the very what do you call the favor study design of clinicians. Very simple parallel design, right? What do you call you don't need even help from statistician. The clinician can analyze by themselves. But remember, if you have more than two measurement, right? Let's say you have a new drug post-treatment 1, post-treatment 2, post-treatment 3, many times repeated measure, then you have to get help from statistician because it become more complicated, right? Repeated measure, ANOVA and mixed model, all many things, right? Okay, so coming to this another design called crossover design. Crossover. Why crossover? Crossover, right? Why crossover? First round, test and control. Second round, control and test. Right? The first round, the participant from arm A, right, will get the test drug. Second round, control drug. The other arm, control first, followed by test. Right? It is more complicated, but it is very good if you have problem with sample size. If there are sample sizes not adequate, you cannot get many patients, then you may opt for crossover design. That is the advantage of using crossover design compared to parallel design, right? Okay, but whenever advantage, there is a disadvantage also, right? Crossover design is much more complicated in doing, especially many people know about it. First round drug inside the body still there. Go for second round, right? First round drug and second round drug. If body still maintain the first round drug because of the plasma half-life, right? Because of the, how to call it, MIC, minimum inhibitory concentration. I think pharmacists know better than us, right? In that case, there are some element of first round drug still in the body, right? Then going to second round drug coming in that case, it may interact and it is high risk for the patient. If we call it carryover effect, If carryover effect is suspicious, which got discovered by pharmacists, pharmacologists, then you may have to impose washout period. Washout period is, I think, to my understanding, I think around 2 weeks to 2 months. Some may be more than that. I think pharmacists know better, pharmacologists know better than us, right? Washout period is given, right? You need to have a pharmacologist or pharmacist in your team, right? And determined by them. And after washout period, you can start the second round. So the carryover effect is there, suspicious. Solution is you have to impose washout period. Then do it, right? So crossover design studies are actually if you do very well, scientific very, very good, right? But you need a experienced statistician because analysis is not easy. I used to do 4 arms. You can imagine, 4 arms, right? I used to teach one student from Pakistan doing the 4 arms, ABCD. And remember ABCD crossover and repeated measure, 4 measure, 4 repeated measure, 4 arms. Very complicated analysis, right? Alhamdulillah, we could do it. I taught her how to do, right? What you call crossover, repeated measure. Very heavy analysis, right? Software we can find and we can do it, right? So statistical analysis is very, very complicated, right? If there are more arms, more complicated. So you need a statistician in your experienced medical statistician in your team, right? And then we can publish for crossover design studies. The one that I got involved, all published in high impact journal, right? So these are actually for the new generation like you. I'm trying to motivate you, right? If you can really want to learn. So this is actually parallel design, crossover design. So sample size calculation, parallel design is quite simple, but crossover design is more complicated, right? Because crossover design, there are some dependent sample involved. Remember, in parallel design is clear, independent sample here comparing to. In crossover design is actually same participants will get a test drug first and control later. So crossover design I will not introduce in this workshop, right? because you need to understand more. For those who are doing crossover design, you can directly contact me. I can explain you, right? Okay, these are the RCTs, interventional studies, two of them, right? Okay, there may some more, but I have to limit it only two, right? Coming to observational studies, right? Observation analytical study. First one is prospective cohort, right? For those who have forgotten this, these are very important for you to remember, right? So design of the prospective cohort study, actually, right? Actually, you start from, okay, you start from a exposure, right? And a non-exposure, going, but sometimes you got the disease and no disease. It's observational. Difference between observational and interventional is interventional, you intervene something. Observational is just observe. We don't intervene anything, right? So from exposure to disease and no disease, unexposed to disease and no disease, right? The researcher is right in the middle, right? Directional inquiry to the future, right? Researcher is very important, the position where researcher is, right? So to say that it is the prospective cohort, exposure happened already, disease not happened yet, right? So what are you interested? What you are interested is that the incidence of disease or occurrence of disease among exposed group divided by disease, the proportion of we use the word proportion of development of disease among exposed group divided by proportion of disease, occurrence of disease among unexposed group, right? So that proportion of disease among exposed group divided by proportion of disease among non-exposed group is known as relative risk. Relative risk equal to 1, disease exposed and non-exposed, right? The occurrence of disease is the same, right? Smoking and heart disease, for example, very classical example. Smoking and heart disease, the proportion of heart disease among smoker divided by proportion of heart disease among non-smoker is known as relative risk. Relative risk equal to 1. What does it mean? You smoke or you don't smoke, there is no significant difference of occurrence of or development of heart disease among smokers and non-smokers. No difference. If it is more than 1, smokers are at higher risk or higher chance of developing heart disease compared to non-smokers. If it is less than 1, smokers are having lesser chance of developing heart disease compared to non-smokers. Smoking is good. Please, everybody buy Marlboro. That is called relative risk. Right? Equal to 1, no difference. More than 1, there is a risk. Less than 1, we call it protective factor. Right? Protective factor. For example, exercise and let's say heart disease. Right? Exercise and heart disease, if our relative risk is equal to 1, no difference. Relative risk is more than 1, exercise is not good. You stop doing exercise. If it is less than 1, exercise can protect heart disease. Very simple, right? Epidemiology statistics is a very simple common sense, right? So that is prospective cohort. Among all study designs and under observational descriptive observational analytical studies, prospective cohort is the best, right? Because the PhD students, master students are asked in the Viva, why prospective cohort study is the best? How would you answer? Anybody wants to answer? Why prospective cohort study is the best among all observational analytical study? Anybody wants to answer? Okay, because of that, I'll give you answer.
Control the confounding factors.
Okay, confounding factor can be controlled through because you are, when you do the multivariable analysis or multivariate analysis, you can put in the variables, right, together, you can, right? But my question is, why it is the best? The concept.
Because we can see the progression of the disease.
Sorry, we can see that?
We can see the progression of the disease because it has element of follow-up.
Your voice is not very clear. You can see the proportion.
Progression of the disease.
Okay, progression of disease means, in other words, can you use the epidemiological term? In other words, you're on the right track. Can you try some more? Who is answering?
Fatin, because we follow up the patient
Yes.
From the exposure until the patient develop the disease in a
Yes,
period
correct.
of time.
Correct. Your answer is correct. But can you make it more precise? If you look at the follow-up, what you get it?
Prof, you can establish the causal relationship.
Okay, causal relation is that is causal relationship. How do you call it? I mentioned already.
Temporal causal relationship, is it, Prof?
Yes, I give you a hint. Proportion of disease among exposed group, proportion of disease among non-exposed group.
The relative risk.
Sorry?
We can determine the relative risk of the relative
Yes.
risk.
True. Relative risk is the true relative risk,
The
right?
true relative
True relative risk in what you call prospective cohort study. Why true relative risk? Why? I'm giving you a hint. Proportion of disease among exposed group divided by proportion
among
of
the
disease.
unexposed, the disease
Yeah.
among the
How do you got that? How do you got that proportion? Start with I. I.
Incidence.
Incidence. Incidence of disease
Disease.
Incidence of disease among exposed group divided by incidence of disease among non-exposed group. Incidence of heart disease among smokers divided by incidence of heart disease among non-smokers is relative risk, right? So prospective cohort study is the only study which can produce incidence. Because of incidence, you can get the relative risk. That's why prospective cohort studies are the stronger study design compared to other observational studies, right? Because of incidence. And from that incident, you can get the true relative risk. So this question was asked in the Viva for PhD candidate could not answer, right? Answer is very simple, incidence. Because of incidence, you can get the true relative risk, and it's the strongest, right? Okay. I will come to that. If I talk about study design, I talk about 1-2 days minimum. So now I have to control. Another study design came out that is called retrospective cohort. Prospective cohort studies are good, true relative risk, true risk you can get, but costly, time consuming. So people started around, I must say, 20 years ago, started producing this study design. When this study design came out, many people could not understand, right? I tried my best at the time, and I also gave a workshop on this, right? We call it retrospective cohort study. Retrospective cohort studies are actually trying to mimic the prospective cohort studies, right? Look at here, exposure to disease, unexposed to disease. Direction and encourage to the teacher, same. However, the difference is like researchers here already. What does it mean? Exposure and disease both happen already. You cannot get incidence, right? Incidence means sudden disease not happened yet. Here it's happened already. So retrospective cohort studies are actually less time consuming, very fast, and also less costly. However, it cannot compete prospective cohort, right? But these days, retrospective cohort studies are very popular because of these two constraints and a lot of publications. I myself published many papers. I think maybe around 60, 70 papers I published already for this. So by right, you should get incidence and what you call the relative risk, but you cannot get because disease happened already, exposure happened already. So you have to satisfy with only odds ratio, and also you may use the incidence risk ratio or relative risk ratio. Sorry, relative risk ratio cannot, incidence risk ratio, IRR, right? So for those who know about statistics well, they will know it. So retrospective cohort studies are trying to mimic, but you cannot, right? So that is the concept, right? Okay. And the other one is case control. Case control studies are cases and control, right? Cases are those with disease, controls are without disease. So case control studies must be very clearly defined. Some people put as cases are those with some condition, controls are with some condition, cannot. Cases must be cases, disease. Control must be without disease, right? So, sorry, where is the, oh, here. Okay, the title came earlier, a little bit, you change the, what you call, the sequence, right? So this is a case control study. In case control studies, cases are those with disease, controls are without disease, right? Look at the exposure. So difference between cohort and case control is cohort is direction into the future, whereas case control is to the past, right? And the researcher is here, right? case exposure disease happened already. So you may ask me, what is the difference between retrospective cohort and case control? Very clear, right? Retrospective cohort is interested in outcome, disease, right? Case control is interested in exposure, right? So case control studies are actually proportion of exposure among cases, proportion of exposure among control, right? Bad case control studies are meant for rare outcome, right? If it is rare, case control studies are recommended, right? If it is common, 3 are recommended. What are they? Prospective cohort, retrospective cohort, and cross-sectional, right? I repeat, if it is common outcome, prospective cohort, retrospective cohort, cross-sectional. If it is rare outcome, case control. Are you clear? Right? So cases and control, you look at it and then look at it. You've got to pass. For example, I always use the example of retinoblastoma. It's a rare retina cancer, right? So retina cancer, there, those with retinoblastoma, those without retinoblastoma, right? And then you look at the exposure. For example, exposure is, for example, genetic history, right? Genetic history. So let's say odds ratio is 5, for example. What does it mean? For those with retinoblastoma are at 5 times higher odds of having what you call family history compared to those without retinoblastoma, right? If you use case control odds ratio, right, cannot use relative risk because in case control you cannot get incidence, right? So if you interpret your prospective cohort, you interpret as risk. If you interpret for case control, interpret as odds. Right? What is the difference? Because you are estimating the risk, right? Risk of relative risk by using odds ratio, right? You cannot get incidence, you cannot get relative risk in case control study, but you use the odds, right? Odds is the best estimate of relative risk, right? So the point is very interesting actually. If the outcome is common, right? You are not supposed to use odds ratio. You relative risk. However, problem is you can get incidence only in prospective cohort. So you have no choice, like retrospective cohort and cross section. You have to do odds ratio. Right? Odds ratio is mainly meant for estimating the relative risk by using odds ratio, like in the case control studies. Right? So if the outcome is rare, odds ratio is much bigger than relative risk. If outcome is common, odds ratio and relative risk are more or less the same. I'm just sharing with the experience, right? Many studies, many analysis we do, right? If the outcome is rare, odds ratio is bigger than relative risk. That is nothing surprising. If outcome is common, then odds ratio and relative risk are more or less the same. Right? So interpretation, be careful, especially postgraduate students, right? When you defend your thesis, right? You have to defend in such a way, if it is odds ratio, use the word odds, right? So for those with retinoblastoma with 5 times the higher odds of having genetic history compared to those without retinoblastoma. You can interpret other way around also. For those with family history are 5 times higher odds of developing retinoblastoma compared to those without family history. You can interpret also, right? So interpretation is very important, right? Okay, so that is the case control. And Dr. Malini requested, Dr. Malini, you want to know about match and match, no? How do you say match and matched? You match them with particular criteria, right? Age, sex, match, then that is called match case control. If they are not matched, unmatched case control. Why do you match? You want to eliminate the confounding effect. But these days, as I mentioned, we have a strong software, strong computer with a high, very fast RAM. Then you don't need to match, no problem, right? Nested case control. Dr. Malini, you requested nested case control, right? Dr. Malini?
Yes. Thank you. Yes.
If you want nested case control, I will go a little bit fast. Just a minute. I have to share another file.
Is everything okay, Prof. Sahatip?
Sorry?
Is
Just,
everything okay?
yeah, I'm looking for 5. I have so many 5. Just a minute.
Oh, okay.
Prof. Said, when you mentioned the case control, can you elaborate? I'm Dr. Ching. I want to ask about the genetic study because genetic study also they prefer to have case control, even though the disease may not be rare. So usually when you match, you only match with gender only, right?
Okay. In genetic studies, yes, yeah, you use the word some case and control. So am I right? Right.
Yeah.
So, yeah, it is also used. Only thing is, the case control mean cases are real with disease, control are without disease. So in genetic studies, I'm not sure how you define it, case and control. Right?
We define it based on the epigenetic I mean based on the genetic component. Yeah.
Yeah. So how do you define it? What you call in genetic studies?
So because the epigenetic they have the component, for example, major, minor. So you just define it.
Yeah. So normally is case
Sorry,
control here
I
is,
have to refresh again. Sorry. They also define the outcome as disease-free or present or absent of disease. Then only we look at the genetic component.
yeah. So then similar concept lah. Because disease free
Yeah.
and disease with the similar concept, right?
Yeah.
Okay. Dr. Malini, I need to look for it, the 5. Maybe later after break, I will look for it for necessary case control in another file. I don't know where I kept it.
It's okay, Prof. It's okay. Never mind. Thank you.
Okay. I will answer it. I have a flow chart, a very nice flow chart. I will answer it. Okay. So that is the case control, right? Actually, I'm supposed to give you a break already. And then the last one is cross-sectional study, right? So cross-sectional study, can you see my slide? You see, no? Right?
Okay.
Okay, it's cross-sectional study as cross-sectional, right? It's cross-sectional. Cross is the exposure and disease. If you look at it here, you can see the line in the middle. What do you mean by cross-sectional study? In cross-sectional study, you are exposure and disease, you are looking for the association. In cross-sectional studies, the feature is cross-sectional studies are not meant for determining risk, right? Not meant for determining risk. It is just association, right? From the particular population, draw a sample. For example, you are going to look into, let's say, in the primary school children. You are looking for the association between the contributing factors and obesity among primary school children, right? So you are going to do the observational study, go into the school, right? Get the right sample size, sampling method, and then you are going to come up with the association, right? Association, what's called between factors and obesity. For example, what are the factors? Maternal factor, paternal factor, education of the parents, way of what's called the cooking of we call meals, the frequency of eating, what you call the sweetened food, exercise, and all these things, either sedentary or active, and so and so. And you are doing the associated factor analysis, looking for the association only, not cause-effect relationship. If you want to do the cause-effect relationship or cause, what you call the outcome relationship, you do longitudinal studies. What are longitudinal studies? Prospective cohort, retrospective cohort, case control. They are called longitudinal studies. Longitudinal studies can give you risk assessment, whereas in cross-sectional studies, no risk assessment. So if you want to do cross-sectional studies, then make sure that you are not determining risk. Many journals, with due respect, many researchers publish cross-sectional study with risk assessment. That is not right. Right? Epidemiologists, statisticians have reminded many times, right? Cross-sectional studies are not meant for measuring risk. They are association only. Yet, many researchers, right, interpret as risk during cross-sectional study. You can still use odds ratio, no problem, but interpretation should not be as risk. How many times higher risk of developing, so cannot interpret like longitudinal studies. So other people do mistake, never mind. We have to avoid, right? Okay. So this is the what you call the cross-sectional study. There is another comparative cross-sectional studies. You are having a population 1 and population 2, sample 1 and sample 2. For example, just now I mentioned about obesity among primary school children in Malaysia. You may compare with Singapore, for example. So population 1 is Malaysia, population 2 is Singapore. You got a sample, right sample with the sampling method, and you look for the common associated factors. Outcome is obesity, yes or no. Do the comparative cross-sectional study. What is the comparative cross-sectional study? Malaysia and Singapore, right? Two operational areas, right? Different geographical areas, and you are going to do what you call comparative cross-sectional studies, right? Okay, so this one finished. We got the study design part. I just want to add one slide here that I forgot to in this one. How are we going to differentiate, or how are we going to have clues to clues to decide which study design? Because in sample size calculation, without deciding study design, you cannot conclude, right? Okay, so edit another 5. If you can see, let me know. I have to share again. Yeah, can you see the slide here? Can you see the big chart? Can you see?
Can see 4 small square slide.
Small square slide.
Design of a prospective cohort, design of a case control study, design of retrospective. Yeah.
Is this very small?
It's okay.
Okay. So prospective cohort, retrospective cohort, case control, cross-section. This is my own chart for teaching, right? I produce it. So in the prospective cohort study, you have what you call the interest is outcome, right? And you can do relative risk. Whereas in retrospective cohort study, they try to mimic prospective cohort, but you cannot get relative risk. You do the incidence ratio or odds ratio. In case control study, is reverse. You are interested in exposure odds ratio. Remember, case control studies are meant for rare outcome. If it is rare outcome, method of choice is case control. The last one, cross-sectional study, not meant for measuring risk. It is just for association. So this is my another flow chart. This flow chart is actually very useful for what's called the researchers. I produce on my own. I give the present to you, right? Outcome, a guide to select appropriate observation study design. Please use this one. Very useful for you, and you won't do mistake. Outcome is rare, straight go to case control. No choice. Outcome is rare, close your eyes, case control. Outcome is common. Of course, remember, outcome is rare, case control, but you want to determine risk, right? You want to determine risk, case control. Outcome is common.
Perhaps I can stop you for a while. How do you define rare?
Okay, good question. Rare is very subjective, right? In our epidemiological definition of rare mean based on the population of 1,000 or 100,000, right? How rare based on the population statistics, right? It is very difficult to mention is rare or common. For example, out of 1,000, for example, the 100,000, for example, you have some few of 100 only, for example. That of course rare already, right? Out of 1,000, maybe you have less than 10, right? Less than 10, for example, rare already, for example. So the choose question is very, very, very valid. How rare? That is actually thinking about for clinicians, we call the public health people. So rare is subjective, but of course, based on the either population parameter of 1,000 to 100,000, we determine as rare. There are some definition in the some textbook, they mention about how rare is it. So for the time in Harvard, I can answer Dr. Chu, rare is just kind of a bit subjective assessment, right? But there are some more what you call particular defined, what you call the definition, but still arguable. Still arguable. Have I answered your question, Dr. Chu?
Yeah, I think what I understood from other epidemiologists, usually conventionally, as you say, is subjective, but for ease of discussions, I think many actually take it as less than 10%. But I think you, as a statistician and statistical strategy, you want to also double check whether that is considered as rare in certain health conditions or situations. I think that because it's not absolute. But conventionally, I think people take it as less than 10%.
Yes, 10% is what I used to read also, but still people argue, right? 10% is really rare kind of thing. But of course, if you talk about out of 100 people, less than 10, I mean, so it is reasonable, reasonable. So you can take that as what you call 10%, not bad, right? But some statisticians still argue, right? That's why I carefully say about how rare, right? Okay, thanks for that, Dr. Chu. Yeah, okay. So rare, if it is rare, you want to determine risk, go for case control, right? If it is common, then you need to ask yourself, are you interested in determining risk or not? I'm not interested in determining risk, close your eyes, cross-sectional. If you are interested in determining risk, then don't close your eyes. You need to talk about your money and time, right? There is no constraint about time and budget. We have no problem. We have time, we have budget, then go for prospective cohort. Otherwise, if you have constraint about time and budget, go for retrospective cohort. So rare is control. Common, ask yourself, risk, you want to determine risk or not. I'm not interested in risk, just cross-sectional. I'm interested in risk, then if there are constraints of time and budget, then retrospective cohort. No constraint, then prospective cohort. So that is the one that we've been using this principle and are doing quite well, all right? But you want to ask or you want to argue anything about this? This is my own flow chart, right? For teaching and for application, for the application. Any questions so far? As I mentioned, I have two components. I finished only one component, that is the study design. But no problem because I combine into 6 into 4, so I'm still okay. Second part is statistical part. The one I have to give you after break, right? Any questions so far?
Prof?
Yeah. Sorry, go ahead.
Prof, I'm Nomala. I'm from psychiatry, Prof. Nurjan Sekali.
Oh, from Nomala. Yeah. Oh, very, very happy to see you join.
Okay. Yes. All right.
She's our deputy director of the hospital.
Okay.
No, I'm participating as a lecturer from psychiatry lah. Okay. I think it's quite
Yeah.
Okay. I think in our clinical studies usually when we want to do I'm just asking lah. Sometimes we want to see some rare conditions in certain disease, correct? And then how whether case control is applicable or not. Meaning that when you say case control, then control must not be having this the outcome, the disease. Yeah. So if let's say, for example, if let's say I want to look at certain rare conditions in diabetes, so I choose the case with the condition and control without the condition, but both are actually diabetic lah. Is that correct?
Okay, very, very relevant and very good question. I used to have this experience many years ago. Okay, I don't want to mention one by name, but one university in KL called me up. They were in the ethics committee meeting. So what happened was, related to what Prof. Nomala mentioned, cases were depression. Controls were, I cannot remember the disease, but something psychiatric disorder. So they were in the meeting and they called me up. And is it correct? For cases cases where depression with depression, control with other type of psychiatric disorder. For me personally, what I understand case control mean, cases are that particular disease that you are interested, control should be free of that particular what you call the condition. If you put as another psychiatric disorder, then your control is not the clean control, right? To be able to measure risk, you may have to have a clean control. For example, patient come for particular disease in a hospital. If you want to select from hospital setting, control should be, for example, coming from URTI, for example, kind of thing. That's possible. URTI patient who is away from that kind of particular disease. So come back to Prof. Nawala's question, diabetic patients, if you are interested to determine risk for something major thing, but with the diabetes, in that case, my opinion is both are diabetic patients may be a bit difficult to say that your control will be a clean control, right? What we want to see is that what you call that particular condition where you want to determine risk, that control should be a clean control as long as you can screen, right? So some situation actually quite difficult. Right, quite difficult to determine what's called get the control. So I always tell the students, getting a case is not difficult. Getting a right control is quite difficult, right? If you match a worse, even you match it. So to answer Prof. Nawala's question, both are diabetic patients, and you want to determine what kind of risk, Prof. Nawala? You want to determine risk of?
Certain rare condition lah. I can't give you an example. Maybe diabetes is quite difficult. For example, if I give you psychiatric example, so I would want to look at whether major depressive disorder have some neuropsychological impairment, for example, cognitive impairment.
Okay.
Right, correct. So because because when I refer to a lot of studies, what they do is in a case control, they have case with major depression with cognitive impairment, and then the control is major depression without cognitive impairment.
Okay.
Okay,
in that case, can I ask back, Prof. Nawala, if that without cognitive or major
major depression.
Depression. So in that case, this cognitive, do you think that the depression and cognitive, is there any interaction where it can develop? For example, if you put as depression with and without cognitive impairment, will it be pathologically, will it be the interaction where the patient can anytime develop that cognitive impairment? Is it possible?
Yes, it's actually possible.
Okay, in that case, Prof. Nawala, in my opinion, by right should be a bit worried about being whether it is a clean control or not. A bit worrying. Maybe you look for other where they not really related, right? Related for getting impairment or not. That may be better, right? So getting a right clean control is very important. Otherwise, your estimating risk can be either underestimating or overestimating if there is interaction. If I use statistical term, if there is interaction, it can be a what you call the additive, or it can be a synergistic, or what you call antagonistic. So that's possible. So for cause of that, we try to avoid, right? Avoid and get the as best as possible the clean control, right?
All right. Okay.
Your question is actually very important question. We need to educate.
Yeah, because we have seen a few, and some people are confused about that. So.
Yes. And another thing is, I used to receive some proposal. Cases are smokers, controls are non-smokers. Again, that is not appropriate because smokers are not, as long as they don't have any pathology, you cannot say it's a disease, right? Unless they, of course, they have addiction, but organic kind of what you call lesion kind of thing, not yet. So some epidemiologists, statisticians, we don't agree that the smokers are cases. Control are not we call control. That is again not appropriate. So if you go back to basic, cases are those with disease, control are without disease. But
Oh.
your point, very important. We have to educate people. Educate people.
Yeah. Okay. Okay. Thanks, Prof.
Okay. Thanks.
Okay.
Okay. Any more questions?
Sai Hakim, there are couples of questions in the chat box.
Oh, sorry. I
It
was
was posted, I think, earlier.
sorry.
If the participant would like to clarify, also can. But I will read out the question for you.
Okay, please.
There's one from Izati Inani. Hi, Prof. I would like to ask, I'm doing a research in cat. Sample is done by convenience sampling. The sample is taken from DBKL and animal vet. So basically, the sample is taken based on the availability of the sample. How do I determine the sample size? Currently, the plan is to do 30 cats.
Currently, the
plan is to do 30 cats.
Oh, 30 cats. Okay. There's animal-based studies, right? So 30 cats is total or per group? Is that Tika? Total or per group? Total. So how many groups you have? How many groups do you have?
I don't have any groups. It's just that total cats for total sampling.
Oh, okay. So your point is you take the available sample, right? Wherever you get it. So from there you take it. Is it right? Right. So animal-based studies, of course, you got a sample. You not like I mean, a human being also actually you should have an inclusion and exclusion criteria and so, right? And then you take the number of cats. But as I mentioned, if you can follow guidelines, right? Whenever there's a guideline, especially animal-based studies, you can follow. Some they need, let's say, as far as I know, is 6, 12, 18, 24, 30, something like that. They have guidelines, right? If you are doing the bioequivalent studies, right, in that case, you may what you call follow them, right? Normally, animal-based studies are smaller number, right? If you don't have a particular guidelines, you have to calculate sample size. Of course, if you have a sample size small per group, small, less than 30 per group, you may have to do the non-parametric test. If it's more than 100 per group, parametric, between 30 and 100, you have to test the assumption fulfilled, parametric, assumption not fulfilled, non-parametric. These are actually all the guidelines you can follow, right? So generally speaking, if you don't have guidelines, then you may have to redetermine the sample size, right? Otherwise, if you have follow the guidelines, then you can take it. 30 cats is actually not bad. It's a total, right? Okay. Does that answer your question?
Yes, Prof. Thank you.
Okay. Do you see any more? For those.
There's another one earlier. For pilot study, what's the minimum sample size?
Okay, another good question. So far, pilot studies, if you really do a pilot study, right? Pilot study, you don't need to determine sample size. You don't need, right? However, based on central limit theorem, if you are doing the like continuous variable and so, we follow central limit theorem that the sample size is recommended by theorem is 30 per group, right? So then you should what you call follow. Otherwise, if you cannot get a sample size, particular sample size also, no problem. Pilot study, there is no need for determining sample size, but must be a real pilot study. People must be very clear about what is the difference between pilot study and pre-test, actual study. These must be very, very careful, right? What it means by pilot study. It must fulfill the criteria, right? Then, okay, no need to get this sample size. Okay. If I look at others.
Hello, Prof.
Yeah.
Saya Fatin. Can you explain a little bit on quasi-experimental design?
Sorry?
Quasi-experimental design.
Quasi-experimental design. Okay. Quasi-experimental study is actually QASI, right? Some people call quasi, some people call quasi, and so and so. Quasi-experimental studies actually, they are non-randomized controlled trials, right? It is actually, as we all know, we always want to go for randomized controlled trial, either clinical or community trial. In clinical trial, quasi is very rare because in clinical trials, normally we are doing the randomized controlled trial. Is it right? In the community-based studies, we have some problems where sometimes randomization is not possible, right? You have only 2 or 3 operational areas, right? For example, 2, for example, only. You have an intervention and control operational area, right? In that case, it is very redundant, right, to do the randomization because it is what you call the community A and community B, for example. In that case, you have to go purposely, sometimes because of the cooperation by the authority from the community, you have to go purposely. The community A is very cooperative, we take as intervention. Community B is not really cooperative, we take as control, for example. If you do purposely, you don't have randomization. Then becomes a non-randomized community trial or non-randomized control trial. Nothing wrong, right? Nothing wrong because you have valid reasons to do it as long as your interventional strategies are good, right? It's interventional strategies are appropriate and validated or everything. You have methodologically done very well. Then in community trials, randomization is not the key. You can go to website, you can read, right? Randomization is not the key. But in clinical trials, yes. People in clinical field, preferably they must do randomized control trial. In community trials, you may not be able to do randomization. For example, another example is we do the HARCH research, right? HARCH and Umrah research. We in a one flight going to Mecca or Medina, right? Going there, inside one flight, how can you get the intervention and control? You intervene some people, control some people, right? It is again redundant and methodologically very difficult. In that kind of situation, you may have to do flight by flight. This flight is intervention, another flight is control, for example. Then we have to do it. That kind of study design is called quasi-experimental study or known as non-randomized community trial or non-randomized community or control trial. That is called quasi-experimental studies. There are many more examples, right? Have I answered your question? You understand?
Yes, Prof.
Okay. Any more? Any more for those who join?
Sorry.
Yeah. Yes.
Prof, Nomala again.
Okay.
Okay, Prof. Okay, this is some situation that we usually face. Okay. In sample size calculation,
Okay.
when you say it's based on the 5 question, whether we use mean or proportion,
Okay.
and some people, some researchers, they use, they use other parameters. They use sample size using regression and all that, right? And some of when you refer back to the objective research question, in fact, in the study they actually will not use any regression analysis, but the sample size is calculated based on the regression.
Okay.
So is this correct or not?
Okay. You got quite a good experience with wrongdoings, right? that is very good actually. Okay, your point
It is from the ethics committee, bro.
Yes. When you say the ethics only, we can see it. Very good point especially for postgraduate students, researchers, right? What from Nomala mentioned. When we do our research proposal must answer each other. For example, title. After that, you have a research so going to conceptual framework. After conceptual framework, you come up with your research question, hypothesis, and objective. Like Prof. Nomala mentioned just now, the research question is regression. Regression means continuous variable predicting. You have the regression coefficient and so, right? So what are the associated factors of BMI? For example, BMI is an outcome variable, continuous variable. Your independent variables are many, right? Age, sex, race, and exercise, yes or no, many things, right? So objective is associated factors of BMI. Sample size calculation should be based on regression. Some people calculate based on mean or proportion. Two mean difference. We'll come to it later. Two difference of means. This is under do's and don'ts, right? What you call the difference of mean, difference of proportion. after the calculation sample size and analysis, go back to regression. So objective is apple, sample size calculation is orange, and going to analysis is apple again. That kind of proposal cannot accept. Right, so Prof. Normala's experience in ethics committee, definitely this kind of thing need to point out. By right should be, if it is regression, what you call the objective, calculation of sample size should be based on regression, right? And then the analysis should be regression. If it is difference of means, then objective should be difference of means. Analysis, sample size calculation should be difference of means, let's say 2 means or more. And then analysis should be, let's say, independent details or one-way ANOVA or repeated measure, so and so, so and so. Right, so in my 5 points mentioned about mean or proportion, I mentioned, thanks Prof. Normala, there are some special cases. Actually, my topic and sample size calculation, as I mentioned, I run many days. I have one group called I treat as a special type of sample size calculation for other common conditions. Regression is one of them. Regression, one of them, like linear regression, one of them, right? And also, let's say correlation, intra-class correlation coefficient, validation study, right? Either the EFE or CFE or anyway, all these I lump together. I call as special type of sample size calculation for what you call the some common conditions, right? I think Dr. Adam may touch some of them, right? So what I mean is, you're right, actually, Prof. Normala. All must be in line and the calculation must be what you call in line, and they must answer each other. That's the point. Yeah.
Okay, all right, thank you. That's very clear, Prof.
Okay. Thank you.
We shall answer one more question, Prof. Sahatim. I think the rest probably we can you may get some answer from the other
Maybe.
talks, and also we do have half an hour in the afternoon for more elaborative questions. Shall I bring to your attention? There's one questions from Leslie. Prof. Hatim, is there such a thing as rough estimate of duration for retrospective cohort study?
Rough
time constraint, 3 months, 6 months.
rough estimation
rough estimate of duration for retrospective cohort study.
Oh, okay. That is very subjective. Rough estimation of duration actually depends on the, of course, type of data, you got the sample available, right? And then, of course, the in-depth of the statistical analysis, the number of variables, right? Number of operational sites, and so on. Of course, the sample size and sampling method also. So there is no hard and fast rule about rough estimation of duration, whether fast or you got the slow or long or short. There are many factors that just now I mentioned. Generally speaking, if you want to do retrospective, I forgot to mention, we call it RRR, retrospective record review, right? Your study design is retrospective cohort, but your data collection approach may be retrospective record review, right? Many retrospective cohort study end up with RRR, retrospective record review, right? Maybe from the hospital record, maybe from the other health facilities, which is called record and so and so. So again, as I mentioned, there are many factors it can govern the duration, right? So, but of course, the reason why it's time and constraint is time and budget constraint is there is in prospective cohort study, of course, it's longer, right? For a person, smoker to develop heart disease, maybe take 10 to 15, 20 years. For HIV positive patients to develop full-blown AIDS will be take around 10, 15 years, for example. So what I mean is the duration is actually depending so much on many factors, right? Some situation, getting data is very fast. For example, go to registry data. Now in Malaysia, as we all know, there are many registries. So registry data actually basically retrospective record review. From there, you do the sample, you get it, and you can get fast, right? Some of my students did and they graduated already from the registry data for the eye registry, trauma registry, and so, right? And they have graduated already. Even some are still doing, right? So what I mean is, to answer the participant's question, actually is depends on many factors, right? Duration is again subjective. Of course, we want as fast as possible, right? Okay.
Okay. I promise we shall break for
Yeah,
morning break.
yeah.
But perhaps there's one quick one, Prof. Hatim from
Yeah.
Ting Jing Siu.
Okay.
How can I explain no sample size calculation for my study in writing?
How can I explain?
How can I explain no sample size calculation for my study in writing?
Okay.
Yeah, I can imagine. Yeah, the
Okay. That's why I say sample size calculation is for not all studies. Some situations, sample size calculation is not necessary. For example, as as I mentioned, that there is no clue. Sometimes there is not necessary. Then sample size may not be able to determine or may not be necessary to determine. So you must have your strong justification that you don't get this sample size. Some people claim like this. I think sample size is big, 1,000. I don't calculate sample size. I take all. Can I do? My study needs sample size 1,000. How do you get it? Because sample size 1,000 is big. So I don't calculate. The sample size available is 1,000. I don't calculate. I take all. By ethical norms, I think senior people like from Mamala, Dr. Chu, you know it. Sample size taking more than required is unethical, right? You are doing sample size. You don't calculate sample size. You take all, claiming that I don't need to calculate sample size because a lot. That is unethical, right? You may need a sample size only 200. You are taking 1,000. You may need a sample size, for example, 50 only per group. You are taking 100 per group. Also unethical. Again, sample size needed is, let's say, population base 3,000. You are taking only 1,000. Unethical also. You are taking you are doing the underpowered study based on the particular parameters. So the question is very good question. How can I justify it? You have to justify why you don't get this sample size. Something like same as sampling method, right? If the sample size required is smaller than sample size available, you need to apply a sampling method. If the sample size required is larger than sample size available, you have no choice. You have to take all. I repeat, no? If the sample size required is smaller than sample size available, you have so many cases. You have only you need. You need to apply a sampling method. If your sample size required is larger than sample size available, you have no choice. You have to take all. You cannot apply the sampling method, right? So in your sampling method, just write that no sampling method is applied. That's it. Right? So these are situations that you need to know. So question is good question, but you have to justify, right? Okay.
okay. Shall we break for 5 minutes to 10 minutes?
I think
Azifa?
I think 5 minutes only. And come back at 10:35.
Okay.
Okay, because I think there are so many questions about how to calculate sample size at the chat box, which I think can be answered after break.
Okay.
Yeah. Okay, Prof. At 10:35 we meet again.
Okay. Okay.
Okay, thank you.
Okay. Shall we start?
Yes, Prof. I think we can start. Prof, is it okay if Prof go through the talk first, and then only after the talk finish, then we take the question. If not, we will
Okay.
be lag a lot, lah, Prof. Okay,
Yeah,
thank you,
okay.
Prof.
Okay, no problem. Thank you. Thanks for reminding me. Okay, so we just continue. Second part, that is about statistical parameters, right? Can you see my slide?
Not yet, Prof.
Not yet. I can share. Okay, here. Can you see now?
Yes, we can see it.
Okay, so just now I have talked about study design. Do you remember one big illustration? I will come later, right? So after statistical part finish, I'll go back to that flow chart. Can you see the criminal trial by jury? Do you see?
Yes, we can see
Okay.
it.
Okay, so this part is, first part is study design. Second part is understanding about statistical parameters for you to be able to calculate sample size, right? This part is also very important. So actually, I'm supposed to explain you this table, right? But before explaining this table, I'm going to explain you this table first. It's easier for you, right? Based on the teaching, using this table is very easy for you to understand the next table, right? Whenever we think about jury system where criminal trials are conducted, right? This is not my table, right? This is the example from the Harvard School of Public Health, right? From Harvard University. So this is the one that widely used among statisticians, right? So if you look at it here, defendant was innocent or guilty. Verdict given was not guilty, right? So whenever the defendant was taken to the court, right, there are 4 probabilities, right? First one, defendant was innocent, verdict give not guilty, correct verdict. First one. The last one, defendant was guilty, verdict give guilty, correct. If you look at A, B, C, D, for example, right? Okay, I'm using that. Can you see my pointer, laser pointer?
Yes, we can see it, Prof.
Okay, defendant was innocent, verdict give not guilty, correct verdict. Defendant was guilty, verdict give guilty, correct. Defendant was innocent, verdict give guilty, incorrect, right? For those who are young, one may not remember. In many years ago, in Chicago City, I think one babysitter was given verdict of guilty. She was a British, but people believe that she was innocent, but the defendant was given guilty, but she was innocent, right? That is incorrect. If you remember, right? A very popular, well-known, the trial, right? So defendant was innocent, verdict is guilty, incorrect. The last one was defendant was guilty, verdict is not guilty, right? Only God knows whether it was going to be guilty or not. Remember the O.J. Simpson trial, right? Where defendant was guilty, people believe guilty, only God knows, but verdict give not guilty, incorrect. So in this jury system, where verdict given in a defendant situation was possibly 4 probabilities, correct, incorrect. Coming back to statistics, right? Coming back to statistics, similar one, if you think, right? In the population, null hypothesis was true. I think people are familiar with null hypothesis, right? Null hypothesis means hypothesis of no difference, hypothesis of no association. That is called null hypothesis. Alternate hypothesis of hypothesis of association, hypothesis of difference, right? In the population, null hypothesis was true. Null hypothesis was false. But statistical decision based on the sample. Remember, from the population, draw a sample. Population parameter, sample statistics. Population parameter is very big. Sample statistics, we cannot do population parameter too big. You have to draw a sample from the population. We call it sample statistics. P for P, S for S. Population parameter, sample statistics. So sample statistics, you collect the data and you infer back to population. That is called statistical inference or inferential statistics. I repeat, from the population, draw a sample. I have a big flowchart actually, but no time to show you, right? But from the population parameter, draw a sample, right? And that draw sample, remember, when you draw a sample, you must have a good sampling method, an adequate sample size, and of course, you must have a validity and reliability of measurement too. I will come to that later, right? So, if your sample statistics okay, adequate, then you are going to infer back to population parameter by doing hypothesis formulation and testing and estimation. Two approaches: hypothesis formulation and estimation. This is the one that I'm talking about, hypothesis formulation and testing. Another one I'll talk about estimation. We call it interval estimation, confidence interval. These two are statistical things that you need to understand for you to be able to calculate sample size, right? So null hypothesis is true, right? In the population, draw a sample statistics, right? And you are going to reject or do not reject the null hypothesis, the statistical procedure. Null hypothesis was true, null hypothesis was false. Are you going to reject or do not reject, right? So two decisions you are going to make, right? Reject or do not. Let's start with here, first cell. There are 4 cells. 1, 2, 3, 4. 4 cells. First cell. In the population, null hypothesis was true. Smoking and heart disease are not associated in the population. Researchers select the sample from the population, did the data collection, did the statistical analysis, and make the statistical decision. And decision made was do not reject the null hypothesis. In the population, null hypothesis was true. Smoking and heart disease are not associated. Researcher correctly did not reject the null hypothesis and correctly accept the null hypothesis and conclude that there is no association. In fact, in the population, also no association. Correct decision called as 1 minus alpha, we call it confidence limit. Number 1. Number 4, last one, A, B, C, D, last one, last cell. In the population, null hypothesis was false. Smoking and heart disease are associated. Researchers correctly reject the null hypothesis and accept the alternate hypothesis, conclude that there is an association. In fact, in the population also there is an association. That is called correct decision 1 minus beta, known as power of the study. That is called power of the study, 1 minus beta. Power is not beta, no? Power is 1 minus beta. Many post-graduates write wrongly, students write wrongly that beta is not power, right? Power is 1 minus beta. So what is the meaning of power? Probability of correctly rejecting the null hypothesis when null hypothesis is false. Probability of concluding that there is an association. In fact, in the population, it really exists. There is an association. That is called power of the study. Yeah? Correct. Third one. In the population, null hypothesis was true. Smoking and heart disease were not associated. Researchers wrongly reject the null hypothesis and wrongly accept the alternate hypothesis, conclude that there is an association. In fact, in the population, no association. False positive. False positive. This is true negative. This is true positive. This is false positive. Right? In the population, no association. Researcher wrongly reject the null hypothesis and wrongly accept the wrongly reject the null hypothesis and wrongly accept the alternate hypothesis. Conclude that there is an association. In fact, no association. Right? Type 1 error, or called as alpha, or we call it level of significance. I will come to that why I call it level of significance. Type 1 error or alpha. The last one. In the population, null hypothesis was false. Smoking heart disease were associated. Researcher wrongly did not reject the null hypothesis, wrongly did not reject the null hypothesis, and wrongly accept the null hypothesis. Conclude that there is no association. In fact, in the population, there was an association. False what? False negative. This is false positive. This is false positive. This is false negative. In the population, there was an association. Researcher wrongly did not reject null hypothesis and wrongly accept the null hypothesis. Conclude that there was no association. In fact, in the population, there was an association. False negative. True negative. True positive. False positive. False negative. Or known as beta or type 2 error. Type 1 error, type 2 error. Are you clear so far? Alpha, beta, 1 minus alpha, 1 minus beta. Are you clear?
Yes, Prof. Yes,
Okay.
yes.
So what? You may ask me, Dr. Zayadin, you are telling us all these, so what? I will answer you, so what? So what is application? Concept and application. You are going to apply this, right? You are going to apply this. How are we going to make meaningful in our sample size calculation, in our statistical analysis, in our conclusion, right? Of course, before that, in our proposal, how you could do, formulate and test a hypothesis. Whenever we write your proposal, when we calculate sample size, we always start from type 1 error. We set our type 1 error. Type 1 error is probability of wrongly rejected null hypothesis. One hypothesis is true. Probability of wrongly concluding that there is an association when there is no association. Type 1 error, right? Normally we set as 0.05, right? What does it mean by 0.05 for general medical health sciences study? 0.05. What does it mean by 0.05? Probability of wrongly rejected null hypothesis when null hypothesis is true, right? Researcher is given the flexible way of wrongly rejecting the null hypothesis. Out of 100 times doing statistical decision, you are given the 5 times to wrongly reject null hypothesis. In other words, 5 times to make error. Type 1 error, right? General medical studies, right? Some people may go less, less error mean more stringent, right? 0.01, especially like in laboratory-based medicine, they put at 0.01. What does it mean? Out of 100 times you make statistical decision, you are allowed to only reject only 1 time. If you can afford, go ahead. Very stringent. Some people in psychiatry, psychology, community medicine, family medicine, and so on, those who are involved in the field-based kind of thing, right? A lot of just your measurement is very long, right? Psychology, what you call questionnaire, I used to see, public health, I used to see 50 pages, 60 pages, very long questionnaire. Then you must give them more flexible way. They can do a lot of errors, right? Common sense. So they can put as flexible as 0.1, 10%. Out of 100 times make such a decision, 10 times you're allowed to wrongly reject the null hypothesis. But to me, not more than that. Enough already, 10%, right? For all studies, right? Remember, if you have more stringent alpha, your sample size will be larger. If you have less stringent alpha, sample size will be smaller. In other words, the more stringent your alpha, the larger the sample size. The less stringent alpha, the smaller the sample size. In other words, your most stringent means, what do you mean most stringent? Alpha smaller, sample size bigger. In other words, type 1 error and sample size are inversely related. Most stringent, sample size bigger. Most stringent means smaller alpha, right? Sample size bigger. Less stringent means alpha bigger, sample size smaller. So remember, type 1 error and sample size are inversely related. That is another MCQ question, right? True false question for postgraduate student. Remember, if you have alpha of 0.05, your 1 minus alpha will be 95% confidence limit. If you have 0.001, 99%. If you have 0.1, 90%. Right? That is 1 minus alpha. Beta, type 2 error. Type 2 error is probability of wrongly not rejecting the null hypothesis when null hypothesis is false. Right? False, negative. So type 2 error, normally we set for 20% for observational studies. You just learn about study design, right? 20% for observational studies, 10% for interventional studies, right? That is the standard we set it, right? In other words, interventional studies has less error, right? Less error. Observational studies can be set more error. It means that 20% for observational studies, either observational, descriptive, or analytical. But remember one thing, I will come to that. In the incidence prevalence studies, right, that may not be very much applicable. I'll come to that later, right? So type 2 error is actually set around 20% for observational, 10% for interventional studies. Remember, again, type 2 error is the error. It is inversely related to sample size. If you set type 1 error more stringent, sample size will be bigger. If you set type 2 error less stringent, sample size will be smaller. In other words, your type 2 error 0.2, sample size will be smaller, right? If 0.1, sample size will be bigger. Again, inversely related. Very easy to understand. Errors are inversely related with sample size. If you remember this, you can answer your MCQ question, you can answer your Viva, right? Type 1 and type 2 error are inversely related to sample size, right? The last one, power, 1 minus beta. If type 2 error is 0.2, power is 80%. If type 2 error is 0.1, power is 90%, right? Depends on type 2 error. That's why 1 minus beta, right? Power is 1 minus beta, not beta, 1 minus beta. So power is very important, right? And the power studies, you have problem. So power is actually directly related to sample size. The bigger the power, the larger the sample size. In other words, the larger the sample size, the bigger the power, right? Okay. So this is the application of this table. Are you clear? Type 1 error, type 2 error, confidence limit, and power of the study. Are you okay?
Yes, Prof.
Okay. You need to set your all these things before you calculate. Before you submit your proposal, you have to calculate all these in your sample size calculation. You will repeatedly see this, right? Repeatedly see this in my demonstration, right? Okay. Okay, this is just a definition. Type 1 and type 2 error, you can read it by yourself, right? Precision is very important, right? As I mentioned, confidence interval, width of the confidence interval is precision. I think I will come to that, right? So precision is a measure of the estimate of the population parameter, measure of the precision of sample statistics. As I mentioned in the beginning, if your confidence interval is narrow, the precision is good, right? Confidence interval is what you call the wider, precision not good. So to get the confidence interval, wider or narrower, sample size is very much involved. Now I'll come to that, right? So first part is statistical parameter. One is, I mentioned already, hypothesis population testing, right? From the population parameter, draw a sample statistics, and you are going to infer back to population parameter by 2 ways. One is hypothesis population testing, just now I explained already. Second part is estimation, or we call it interval estimation, right? Confidence interval. Now coming to confidence interval, right? You need to understand a bit about confidence interval. I cannot go in very detail about it, right? Confidence interval takes into account the sample-to-sample variation of the statistic by defining an interval within the true population parameter is likely to fall. When you have your confidence interval of sample statistics, where the population parameter fall within the confidence interval, right? You are estimating the mean blood cholesterol level of Malaysians is more than 40, right? So when you determine your sample size, you need, let's say, for example, Malaysian is more than 40 are, let's say, 10 million. Example, you need a sample size, let's say, for example, enough, okay, 500,000, for example, right? Some people make 10%, make it 1 million, for example, 500,000 enough, for example. Then you are going to determine it. In all days, we present by only point estimate. What do you mean by point estimate? The mean blood cholesterol level of Malaysian is more than 40 based on the sample size of 500,000 with the particular sampling method. Mean cholesterol level is 5.1 millimole per liter. That is called point estimate. Very stringent. Over the decades, statisticians propose that we don't estimate by point estimate. So stringent. We go by interval estimate, right? So interval estimate means lower limit, lower bound or lower limit is 3.8. Upper limit is 7.5, for example. Middle is still 5.1. 5.1 middle, lower limit is 3.8, upper limit is called 7.5, for example. That is called confidence interval estimation. Remember, it is not range. No? Range and confidence interval are different. This is lower limit, upper limit. Lower limit 3.8, upper limit 7.5. That is called confidence interval. So confidence interval, you are estimating the population parameter by using sample statistics. If your confidence interval is narrow, your estimation is very good, precision is very good. If your confidence interval is wide, for example, lower bound is 2.5, upper bound is 10.5. For example, some people maybe have very high cholesterol, for example, 10.5. So 2.5 and 10.5 is confidence will become wider. Precision is not good. So in confidence interval, as you are going to estimate, this is the formula. Dr. Chu reminded us already, no formula he mentioned, right? I agree. In statistics, I myself, to be honest, I cannot remember all formulas. I'm medical assistant for nearly 30 years, but I don't remember formula. You may think that are you joking? Yes, I don't remember. I remember only one formula. That is this formula. Estimate plus or minus k into standard error. Based on this formula, I can write formula. Trust me. Tell me what formula you want me to write, I can write. Because I go to basic. Estimate plus or minus k into standard error. This is the formula I want Dr. Chu and all of you to remember. Right? If I see you on the road, on the way somewhere that you say that Prof. Adam, I attended a workshop, I will ask, tell me the confidence level formula. Only that I will ask, right? Estimate plus or minus k into standard error. What is estimate? Point estimate. Plus or minus k into standard error. K means constant. Standard error is standard error of your study. So let's say just same example I use, right? Mean blood cholesterol level, estimate 5.1. K is you go and see in the distribution. If you are using a t-test, t distribution. If you are using a chi-square, chi-square distribution. So on. No need to worry, no need to remember. You will get it. Important thing is standard error. Standard error, right? The most important parameter in statistics is standard error, right? Standard error, small, common sense, confidence interval, narrow, right? Because it's plus or minus, lower bound, upper bound. So estimate plus minus k into standard error. Standard error small, confidence interval narrow. Standard error big, confidence interval wide, right? We all want a small standard error. How do you get a small standard error? Standard error is equal to standard deviation divided by square root of n. Standard error is equal to standard deviation divided by square root of n. So common sense, to get the small standard error, standard deviation must be small, am I right? Right? How do you get standard deviation small? I mentioned 3 points, especially to postgraduate students. If you got stuck something in your Viva, Prof normalize asking in your Viva, right? Asking you, don't be afraid, right? Prof normalize, I know 3 points. Remember, what are they? sample size must be adequate, sampling method must be appropriate, measurement tool must be valid and reliable. I repeat, sample size must be adequate, sampling method must be appropriate, measurement tool must be valid and reliable. If your sample size is adequate, denominator already, adequate, large enough, no need to worry, you get a small standard error. How do you get small standard deviation? If you have to, you use the sampling method, appropriate sampling method, not like convenience sample, not like purpose sample, non-purpose sampling method. If you have no choice, you have to apply. Otherwise, apply the appropriate sampling method. What are they? Probability sampling method, you know very well, right? Similar sampling, systematic sampling, stratified sampling, cluster sampling, multi-seed sampling. These are the probability sampling method you apply, you get a small standard deviation because samples are quite evenly distributed. They are homogeneous samples, right? The last one in measurement tool must be valid and reliable. You may be in public health, you may be in clinical, you may be in a psychology, psychiatry, you may be anywhere you are, your measurement tool must be valid and reliable, right? Like questionnaire. People do not validate questionnaire. Go ahead, questionnaire studies are easy, right? Just do the questionnaire. Our professor mentioned that questionnaire study can be done under coconut tree. Not true, right? Questionnaire studies are actually to validate the questionnaire, like in the psychology, psychiatry, questions are very, sometimes very, how to call it, very delicate, very difficult to understand sometimes. You need a good validation. If you don't have a good validation, your measurement tool is poor, right? Like in a psychiatry field, psychiatrists like a lot, they like concurrent validity, they like, right? Because they use a lot. Because their field, they need to have a serious validation, right? Psychology, same thing. Public health. So if your questionnaire is not validated well, your measurement tool is not valid and reliable, your data become haywire or extreme value there. Your standard deviation become bigger. But coming to the point, to get the standard deviation small, you must apply the appropriate sampling method. Your measurement tool must be valid and reliable. And your sample size must be adequate square root of n, then you will get the small standard error. How small? As small as near to zero. You can never get zero, right? So if your standard error is small, your confidence interval become narrow. Your precision is very good. So this is very important. You have to have your what you call a confidence interval. The narrow confidence interval. You need to have a good parameters like estimate, so right? Okay. About confidence interval, just to tell you, confidence interval, the concept, right? Your population parameter fall within the confidence interval, the sample statistics, right? If your population parameter doesn't fall, it means that you have something wrong. Sample size is so small, sampling method not apply, your measurement was not validated. Very possible it can happen. Then you will not get confidence interval, right? The good confidence interval, right? To estimate the population parameter. Okay, these are some theory you need to understand. So this is a flow chart, standard error depending on sample size and what you call the variation, right? Sample size small, you have a precision is not good. Sample size big, it is good. Sample size adequate, it is good, right? Also the variation I mentioned already for the standard error, standard deviation, right? So I have given you enough already, but one left. Is your flow, that big flow chart. This one I need to explain you, right? After that we can go hands-on already. Remember this flow chart? Okay, this one. Okay. So you are going to decide how are you going to get this sample size, right? Then this two combination, right? Two combination. One is study design. Another one is statistical parameter. Just what I mentioned, hypothesis formulation testing and confidence interval, right? So when you decide it, first one, let's see, observational descriptive study, right? I mentioned, remember, 5 points. What is the study design? What is the research question? What is the study design? Is it mean or proportion? If it is mean, how many means? If it is proportion, how many proportion? Start from this side, descriptive. For example, you are going to determine the prevalence of smoking among Malaysian adults. Right? Then, what is the research question? Your research question is determining the prevalence of smoking among adults. Number 2, what is the study design? You are going to, now you can apply already. I forgot to mention, prevalence can be obtained only from cross-sectional study. Incidence can be obtained only from prospective cohort study. I repeat, prevalence can be obtained only from cross-sectional study, true prevalence. And incidence can be only from prospective cohort study. So you are going for cross-sectional study, right? Number 1, what is the research question? Prevalence of smoking among Malaysian adults. Number 2, what is the study design? Cross-sectional study. Cross-sectional study can be for both, either for observational descriptive or observational analytical, right? If you want to do the association factors, you look for it, then go for observational analytical. If you want to determine prevalence only, then cross-sectional, that is the observational descriptive, right? So in cross-sectional study, you may determine proportion or mean. Mean, continuous variable, right? The mean of what you call blood cholesterol level, as I mentioned just now, right? Or proportion means prevalence of smoking among Malaysian adults. So cross-sectional studies are the best to do the single mean or single proportion. One mean, one proportion. Remember, third question. How mean or proportion? Mean or proportion. How many mean? One mean or one proportion. Is it an independent or dependent sample? Independent dependent sample mean, are you measuring this same sample or not? Or different sample? If you are measuring same sample repeatedly, that is, of course, this is a dependent sample. If you are comparing two groups, for example, right? What you call BMI among active and inactive group, right? Blood hypertension, blood pressure level between diabetic and non-diabetic patients, right? And so on. These are actually what you call the independent or dependent sample. If you are comparing two or more different groups with independent sample, if you are doing only one single group, repeatedly measure kind of thing, right, before after kind of thing, that is the what you call dependent sample. So here in the descriptive, maybe last question may not be applicable, right, because the dependent and independent sample, they don't have that kind of comparison. So you may do prospective cohort, you may do the single proportion, that is for incidence, right? So basically in the descriptive studies, right, observational descriptive study, you may do the single mean or single proportion, either by cross-sectional or prospective cohort study. So because of the time factor for observational descriptive studies, in my handout, I give you only single proportion prevalence study only I introduce, right? Those who want to know more about others, please contact me, right? Single mean and others, right? Single proportion only I will demonstrate for the prevalence study, the most common one, right? That is called observational descriptive. Coming to observational analytical, you have a prospective cohort, retrospective cohort, case control, and cross-sectional, right? So mostly actually you do the proportion studies, right? In this study design, normally are proportion, if you remember, right? Prospective cohort outcome is proportion of disease among exposed group, proportion of disease among non-exposed group, right? Case control, exposure among disease group, proportional exposure among disease group, proportional exposure among non-disease group. Cross-sectional study is just a correlation, right? So let's say cross-sectional is, let's say, smoking children among father smoker, smoking children among father non-smoker, again proportion, right? So basically, right, either two or more means or two or more proportions. You may do independent or dependent related sample, independent or dependent sample. You may do it, right? So in prospective, in observational analytical study, you may go for two means, but not very common, right? But more common is two proportions, like I mentioned in the prospective cohort, retrospective cohort, case control, and so and so, right? So in other words, you are looking in prospective cohort, disease among exposed group, disease among non-exposed group. All right. In retrospective, also same thing actually, disease among exposed and disease among non-exposed group. However, in retrospective cohort study, you cannot get incidence, right? So it is actually, people argue that it may be that exposure, but actually it's disease. You may put this arrow to this side also can. This arrow, this side also can. That is a retrospective cohort, right? So you may change this arrow in your handout, this arrow to this side, right? This to this side. And of course, in case control study, exposure disease, exposure non-disease, also cross-sectional, basically, also cross-sectional, right? But these are actually, if you cannot catch much, no problem, don't worry. I will show you by software that you much clearer. So my point is here, disease and exposure, right? Prospective cohort originally a disease divided disease exposed group divided by disease but non-exposed group. Others are actually exposure and then disease, exposure non-disease. But retrospective cohort basically is what you call disease by exposed, disease by not exposed group. However, these three you cannot get relative risk. That's why I put it this way, right? These three are actually odds ratio. These are relative. This is relative risk, right? Because of that, I put in this category, right? The odds ratio are these three of them. Relative risk is this one, right? But theoretically speaking, right, retrospective cohort is similar to prospective cohort, right? Disease divided by exposed group, disease divided by non-exposed group, right? Okay, so don't worry about this. When the one I demonstrate by software, you will be very clear, right? The last one is interventional studies. Remember, I don't include here in the systemic review meta-analysis. So only three: observational descriptive, observational analytical, and interventional. It has two types: parallel and crossover, right? Either independent or dependent sample. So research question is, for example, is there any significant difference of mean blood pressure reduction between drug A and drug B? Study design is double-blind randomized controlled trial. Mean or proportion? Mean. How many means? Two means, right? Blood pressure reduction in the drug A, blood pressure reduction in drug B, right? The last one, independent or dependent sample. In parallel design, by right should be independent sample. In crossover design, by right should be related sample. Why? In crossover design, do you remember? In crossover design, you have your crossover, right? First round, test drug, second round, control drug, and other way around, right? So basically, in parallel, we calculate by independent sample, in the crossover, and the dependent sample, right? Okay. So again, I have to pick up because of time. In the observational descriptive study, I will demonstrate single proportion for prevalence. In the observational analytical studies, I will demonstrate for prospective cohort case control, or maybe cross-sectional. And the experimental study, mostly I pick up the parallel design. I think maybe even that quite fast I have to do it. I have to explain also theory plus the do's and don'ts, right? So is it okay? I pick up some, right? Here the prevalence study, here the prospective cohort, case control, and cross-sectional. Here will be parallel design. For those who want to know more, personally contact me. I will explain you, right? Okay. So after understanding this, now coming to sample size. We are going to calculate sample size. In sample size calculation, as far as I know, there are 4 approaches. There may be some more approaches. Number one is formula. As Dr. Chu mentioned, I will introduce the formula just for you to understand, right? Theory, no need to remember. All calculation by software, right? So for me, formula and software. These are my 2 preferred way of doing, right? Formula, of course, I have to understand well, and hand calculation also I used to do, right? And then counter check with statistical software, right? If you understand about formula well, applying statistical software, no problem. I want to remind all of you, when you present your proposal, especially postgraduate students, also lecturers, right? I would recommend don't put both in a single proposal. You calculate by formula, you calculate by software. Both you put it. Then problem is majority of the times, right? Not all the time. Majority of the time, formula and software calculation are a bit different. Sometimes quite different. So like in the research and ethics community, some people who are very, very thorough, they may calculate, if they understand, they may calculate. And found out that there is a difference, they will send back to applicant, right? The waste of time. If you use one, stick to one. If formula, then you have to show the calculation and then set the sample size. If statistical software, right, you may show formula, but you mentioned that you calculate by software and then you copy paste your software output, software printout. Nobody can argue. And good thing about software, you will not do mistake. Formula you may wrongly calculate, right? So here, remember I told you tips and tricks and do's and don'ts all the way on the way. I will tell you. This is one of the tips I tell you, right? Don't put both, one enough, right? Okay. And sample size table. Some people use table. I'm not very much in favor of table. I prefer to calculate by either formula or software, right? And nomogram was a long time used. These days there are some available also, but normally first two methods are now more preferred by researchers, right? And the statisticians. Okay. I mentioned already, single mean, single proportion, two means, two proportion. Don't forget research design, independent or dependent step. Actually, there's 5 steps, right? 5 steps. I think you have got five tips already. Okay. Whenever you got stuck, you get the 5 tips. This is a software that Dr. Chu has kindly put for you already, right? So power and sample size, it doesn't mean it's the best software. It's a very friendly software, right? From University of Vanderbilt, right? So the one we use. And like single proportion formula, better use EpiInfo software. EpiInfo software is actually the developed by CDC, Atlanta, Georgia, and WHO, Geneva. It's a joint effort. Many years ago, right? They developed. Beginning was very sketchy software, but now it's very good, right? Software, and it's got now well known, used by many Ministry of Health, right? Especially good for data entry, right? For data entry. Plus now a lot of statistical software there. Plus sample size calculation. Very good, right? Okay. Okay, so actually is this part I finished. Now I have to go to start sample size calculation in interventional study, observational study for both of them, observation, descriptive, and analytical. Okay, so share another one.
Prof, are you okay?
Yeah. I'm looking for pi. Definitely. Okay.
Prof, are you sharing? Oh,
I'm going to share now.
okay.
Okay. Can you see now?
Yes, Prof, can.
Okay. Sample size determination in interventional studies, right? So the approach now, I will explain you a bit of theory, you know already, and then the formula a bit. And but important thing is inside formula, what are the things you need to know? And we don't calculate by hand, we go by software, right? So all of you have got some software sent by link sent by Dr. Chu, 3 software, right? So for me, I prefer PS software and Epinfo. G-Power also I use. But for your information, my personal opinion, for medical health sciences research with our concept application, some situation G-Power has some problem. The thing that G-Power us and we in our application, some are not matched, right? So some situation very good for G-Power. So because of that, I prefer to use PS software where it is easier to explain, but it doesn't. I don't discredit G-Power, but some situation only maybe a bit not really directly applicable, right? Otherwise, G-Power is a very good software, right? Okay, so I will not demonstrate G-Power. I will demonstrate PS software and Epinfo, right? Dr. Adam may use G-Power, I'm not sure, right? Okay, so determination of sample size in interventional studies. So as I mentioned, in interventional study, it may be two means, right? I will not go back to five tips every time, you know already, right? So it may be two means, it may be two proportions, right? For randomized control trial. Let's see here. This is the two means formula, right? You need to remember, but you need to understand. N equal to sigma square divided by, this is called, we call it, some people call precision, but this is actually detectable difference. It depends on this triangle symbol you will see in the number of formulas, right? The terminology is based on the concept and application of this formula, right? In this formula, this triangle is known as expected detectable difference. Expected detectable difference, right, between groups. Let's say here two groups. Here, if you see here, two mean two groups. If you have more than two groups, you have to modify the formula, right? There's a way to modify the formula. So n equal to sigma square. Sigma means standard deviation. Standard deviation of either group. Now, two means you are comparing two groups, right? In clinical trial, you are comparing two groups. So sigma is standard deviation. This formula is based on two independent t-tests. In two independent sample t-tests. In two independent sample t-tests, sigma is in both sides, right? Let's say drug A, mean and standard deviation of patient in the drug A. Drug B, mean and standard deviation of patient in drug B. So it is using standard deviation of both groups, right? Remember, sigma square is variance. Sigma is standard deviation, right? So sigma is population standard deviation, right? SD is sample standard deviation. Just for you to recall back. So my point is, as t-test using standard deviation for both groups, you can take any one of standard deviation. Standard deviation comes from literature. Standard deviation comes from literature or the most pilot study. Detectable difference triangle, right, comes from expert opinion. What do you mean expert opinion? You are looking for the difference of blood pressure reduction between two groups. Let's say blood pressure between two groups, right? So your detectable difference must be meaningful. Your expected difference, it must come from expert opinion. You are the researcher in this area, you know better than me. Some people will say that leave it to statistician, cannot leave it to statistician, because statistician is expert in statistics, but not expert in your field, right? So if you are looking for example, Prof. Normala is looking for the difference of, let's say, something score between two groups. How can I go and determine the score difference? I'm not a psychiatrist. She is a psychiatrist. Prof. Normala must tell me that my expected difference of particular score between two groups. That the one group I know, another group I have to predict. That is called expert opinion. That is her expert opinion. She knows group B. She'll need to predict group A. So the difference between group A and group B is her expert opinion. I cannot determine for her, right? That is called the expected detectable difference between two groups. So I repeat, sigma come from literature. Detectable difference, delta. Delta comes from expert opinion.
Prof. Sadim, may I also add,
Yes.
this is actually equivalent to minimally important difference
Sorry,
in
minimally?
the literature, right? The MID, minimally important difference.
Yes.
Yes.
That's true.
And
Minimally
that
important.
is-
Thank you very much, Dr. Chu. MID, minimally important difference. True.
And
And some people, yeah.
Experts also are to be informed and educated by the past literature when they
Yes.
come to this expert opinion. Yeah.
Yes.
Thank
As
you.
I mentioned, one group knows, so other group predict. Pronomal predict. They're very right. You must what you call the from the expert where you already educated from the previous study or previous literature. Thank you, Dr. Chu. So that is called, some people call, right? Some people, not some people call, some statistician they call is effect size. This is the absolute effect size. The difference between two. In this, he also effect size is there many times, right? So this effect size, this is called effect size. The difference between two of them, right? So remember, sigma bigger, sample size bigger. Detectable difference smaller, sample size bigger. Detectable difference bigger, sample size smaller. So how should we decide? I have gone through literature for 10 articles. I have followed out of them 5 give the information. They have given the different standard deviation. Which one I should take? Answer is very simple. If it is under your study, the similar groups, right, must be a comparable group, comparable nature of the patient, then take the larger standard deviation. Because larger standard deviation, bigger sample size. What about detectable difference? Like Dr. Chi just mentioned, MID, right? In that case, that detectable difference, right? You need to predict. I know one group, another group I predict, right? Remember, you have many literature from around the world. So I divide into 3 levels: local, regional, global. Which one is the best? Local. Provided peer review, published in index journal. From there, you got the information and you predict. Local. Regional. I cannot get Malaysia. Nowhere. Can go around here. Thailand, Singapore, Brunei, Philippines, Indonesia as well. And including maybe China, Korea, Japan, India. Cannot go for global. Problem is many people go global, go from Medline, go from Scopus, go from what you call the Web of Science, and get from America or Australia, but sometimes not applicable to our local setting, like psychiatry area, like public health area, even clinical area, right? Sometimes cannot apply to our local setting. Then you got problem. Your supply calculation was based on that. Your supply, if you cannot get it, right? So the best is local, cannot get the regional, right? So this detectable difference is very important. This MID is very, very important, right? You may ask me, many people ask me, I don't have any idea. I have no idea this detectable difference. What should I do? Then go for literature from wherever you can get it. Cannot get it, some pilot study you may do it. And my tip, this is a tip based on the experience, saying some maybe in some textbook may have, but so far I could not find much, right? My tip is go for the difference where you get it. You can predict. If you don't have idea for Malaysia, that difference from Europe, difference from America as well. So in the between two groups, you may, if you don't have idea for Malaysia, if you cannot afford to do pilot study, then you may go for the smaller difference. For example, in Europe, the difference between two groups for particular group of is millimeter mercury difference is 20. I have no idea about Malaysian context, no study in Malaysia. Then go for smaller difference, let's say for example 15 or 10 millimeter of mercury. The reason being, if you get the smaller difference, sometimes become bigger, you are safer, right? So my recommendation to many is actually that the tips and tricks and do's and don'ts. If you don't have idea, go for the smaller difference. That is my tip. Got it? On the way you will get many tips, right? Are you okay? Are you okay? So we understand already. At the back, Z alpha plus Z beta square, no need to worry. Z alpha is actually 1.96 for alpha, 0.05 two tail, 2.58 for 0.01 two tail. Z beta is 0.84 for 80% power. Z beta is 1.28 for 20% power. So these things, if you understand it, no need to carry it by hand. You don't need to remember Z alpha, Z beta. No need to remember. Software does everything for you. We become very lazy, right? Last time when I was a student, right? When I was a student, probably I started after that, what you call the medical statistics degree with Newcastle. I have to calculate many by hand. I calculate 2 way and over by hand in the exam. Remember? But these days, people are very easy already. But good thing is, if you calculate by hand, of course, you understand more. Apply the software easier. But these days, of course, your generation, younger generation, all are IT based, right? Okay, let's do it. You understand the formula? Okay, 2 means formula. Are you okay? Right?
Yes, Prof.
Okay. How are you going to determine a sample size? Randomized control trial. We are going to use the parallel, for example, right? Neutral, usual drug, 2 groups, for example. Okay. Question a bit long. I will explain you. Right? No need to read. I will explain. This is a randomized control trial. 2 means you have hypertensive patients, right? Those who are more than 160 milligram mercury per systolic and more than 95 for diastolic. You are going to do a trial. You have old drug. Old drug is actually still very good, but you want a new drug. So drug company approach you. They said that if the difference between blood pressure reduction is 10 millimeter mercury difference, the new drug can bring down blood pressure by 10 millimeter mercury more than old drug. This drug will be accepted. You understand? What is it? What is it? This is detectable difference. Delta, the triangle one, 10 millimeter mercury, right? That is the question, right? So expected detectable difference is 10 millimeter mercury. Which one is better? New drug is better, right? And power is 90%. Remember, beta, 1 minus beta, alpha, 1 minus beta, all must be set, right? Alpha here is 0.01. Researchers are very, very stringent here. Where's the pointer? Oh, yeah. Okay. This is alpha is 0.01. Researchers are very stringent, right? And 10 millimeter mercury is the detectable difference. Where is power? 90% power. So what is 90% power? 1 minus beta. Your alpha is 0.01. Your confidence limit is 95% confidence limit. Your beta is should be 0.1. 1 minus beta is 90%. All apply here. What is the study design? Randomized control trial, right? If you go back, right? Number 1, what is the research question? Is any significant difference of mean blood pressure reduction between 2 groups? Study design, double-blind randomized control, should be double-blind, double-blind randomized control trial. Number 3, mean or proportion? Mean. How many means? 2 means. What is this independent or dependent sample? They are independent sample. That is 5 points plus. Plus, don't forget your alpha, 1 minus alpha, beta, 1 minus beta. Alpha is 0.01, 1 minus alpha, of course, is 90%, 99%. Your beta is should be 0.1. 1 minus beta power is 90%. And one more left. What is that? One more left. What is that? Sigma. Sigma is from literature, 20 millimeter mercury from the previous study. You got everything already put in the formula, right? The formula alpha 0.01, what you call beta 0.1, right? And understood already, power is 90%, right? The detectable difference 10 millimeter mercury, standard deviation from the literature is 20. This is Z alpha, Z beta. Put in the formula, sample size got is 119, or let's say 120. 119 per group. Remember, this formula is 2 groups. Yeah, 2 groups. For those who want to calculate by hand, right? By hand, this group, if you have more than 2 groups, you need to modify the formula, or per group multiplied by 3. For example, you have a 3. You have to modify the formula, right? Then you get it. No, I don't want to modify. I calculate by this one per group. Then multiply by 3, 360. One group is 120, 3 group is 360. Example, right? But by right should be, if you have A, B, C, you calculate A and B, A and C, B and C. Get the biggest sample size, multiply by 3. I repeat, if you have 3 groups, A and B, A and C, B and C, right? So take the biggest one and multiply by 3. I don't want to do that. You can. You go to Starter Software. You have 3 groups comparison, 3 or more comparison, ANOVA, based on ANOVA. You can calculate and you can get a per group. So today I don't have time to demonstrate for Starter Software. In Starter Software, don't you calculate this way, right? If you have 3 groups, go by one way ANOVA, or what you call the command, and you will get it, right? So don't worry about sample size calculation. All are there. Important thing is you must understand the concept that apply, right? Okay, you got it already. Sample size is 120 per group. I don't want to calculate by software, by hand. I want to calculate by software. Go to software. Let's do it, right? So please get your software. Power and sample size software. Please open it. Are you following by hands-on, participants? Hello?
Yes, Prof.
Azifa, can you ask them whether they have all software or not? Must have a maximum benefit.
Yeah. Participant, can I have some feedback? Yes, some of them have installed.
Okay. For those who don't have, but this is online, no? Otherwise you can share. Okay. I have to share.
Yes. Some of them using phone, Prof.
Sorry?
Some of them using phone, so they cannot do the calculation with the software.
Okay. Can you see my PS software screen?
Yes, can see, Prof.
Okay. For those who don't have got software, don't worry. It is very easy. Within 5 minutes, you can download, and you just see here what I demonstrate. In PS software, power and sample size software, this software is from the one who created was by DuPont, right? You can see in front there, DuPont, D-U-P-O-N-T, DuPont, and the group of people. For your information, this software is why it is quite popular is in Starter software, which one is Starter is considered as one of the best epidemiological based software. Clinicians, public health people, right, laboratory medicine people should have Starter software, STACDA, right? Some American state software or Starter software, anyone okay? They use DuPont heavily, right? DuPont heavily. Many from application from the DuPont, this PS software are inside Starter software plus other software they use. I have done quite extensive analysis on this, right? So I know about it, right? So you can confidently use it. And for those who are familiar with Starter software, please go and see in Starter software. So here, survival, just to tell you a bit, it is a file. It was edit. It was a log. Log means you can get the your output log, right? You can just log and you can copy paste to your proposal. Everything is there actually. No need to calculate by hand, right? And help, and you want to have it help, you want to get it. And there are many applications here. Number one is survival analysis. Although clinicians, public health people use a lot. Survival analysis, we call it Cox proportional hazard regression, Kaplan-Meier curve, and all these things, right? So survival analysis, you can calculate sample size by using this survival here. Quite good, right? Quite reliable calculation of sample size for survival study, right? T-test is the comparing means. Regression 1 and 2 based on the 1 and 2 groups. The one I mentioned just now from normalization or regression, this is a linear regression, right? For linear regression, you can use DuPont here. And I have checked already this DuPont regression analysis for sample size calculation, right? This sample size calculation for regression analysis is same as in Stata. Exactly the same result you will get it, right? So quite reliable. And then the dichotomous, this is the 2 proportion and above, right? So t-test is for means, dichotomous is for proportion, right? For example, t-test for randomized control trial, dichotomous for, let's say, like case control, cross-sectional, cohort, this one you can use the dichotomous. And Mendel-Hazer, the one I mentioned, Mendel-Hazer, rarely calculate here, but you can still use Mendel-Hazer for those who are familiar with Mendel-Hazer. Okay, so now I'm going to use t-test, right? So sample size, you're going to calculate sample size, right? So design here, if you look at your design, software will ask you, is it a pair or independent sample? You are comparing 2 groups, independent sample, right? Now fill up one by one, right? 0.0, just now the hand calculation 119 per group, I will calculate by software, right? 0.01, right? 0.01. Remember, these researchers, they want a very stringent alpha. Power 90%, 0.9, 0.9. What is the Senate here? Sigma. Sigma is that you can click here. You can read everything here. You can see. Can you see, Azifa? Can you see the one
Yes.
that? Okay.
Yeah,
So,
very clear, Prof.
okay. So this is the one that if you are not clear, you can read, right? So because of time, I will explain. Please take a cup of coffee and sit down and read all these things, right? So sigma is the one that standard deviation of in the literature, 20 millimeter mercury, right? And sorry, delta is 10. Delta is looking for the difference, 10, right? Delta is 10 millimeter mercury. Remember just now, 10 millimeter mercury, they are looking for difference. Sigma is 20, right? M is ratio. This is very important. Ratio. Ratio is actually ratio of control to experiment, not other way around. Many people did mistake, right? If you read here carefully, they're mentioned here, right? Ratio for independent t-test, M is the ratio of control to experimental patient. M is not defined for pair sample, right? So this is the ratio. So this ratio is actually, like in this case, you have your new and old drug. New drug is the experimental drug. Old drug is the what you call the control group. So if you put as 1:1, 1 usual drug, 1 new drug. If you put 2 usual drug, 1 new drug. If you put 3 usual drug, 1 new drug. Not other way around. The reason why putting control increase is to get the statistical power when cases are difficult to get, right? If there are cases that are difficult to get, the experimental group are difficult to get, then you have to increase the statistical power by increasing the ratio. So in clinical medicine, preferably is 1:1. If you need to increase the control, but not very high, right? In observational studies, the epidemiologists recommended that in observational studies, the most is 1:4, right? 1:4, not more than that. Full control, 1 case kind of thing, right? With the exception, based on my experience, with the exception, some cases like, for example, like survivor data analysis, survivor study on the cancer breast, survivor studies on cancer pancreas, and so, sometimes the ratio may be more than 4. That is the exceptional case, right? I wish that one day I can explain about survivor data analysis. This is advanced statistics, right? Okay, I have a group of sample size calculation for advanced statistics. I have it, right? Multivariate analysis, Dr. Adam is going to touch on multivariate analysis one I saw on the list, right? I put as multivariate and multivariate analysis as a special group for advanced statistics, right? There are way to calculate, right? Survivor data analysis and others. There are many. Ordinal logistic regression, multinomial logistic regression, repeated measure. There are many more. for the special group for advanced statistics, right? And then at that time, survival ratio may be more than 4, exceptional case, right? Otherwise, normally we prefer for 1:1. Let's see 1:1 here, for example, 1:1. So check back, alpha is correct, power is correct, sigma is correct, delta correct, and so sample size is 1:1. Your hand calculation 119, right? Software 1:1, not bad, right? It is more or less the same. Okay, are you clear? Are you clear?
Yes, Prof.
Here you may, sorry?
Yes, clear, Prof.
Clear, okay. You may draw a graph. You may draw a graph for you to put in your proposal, right? Right. So your x-axis range, y-axis range. Okay, let's say you are going to draw a power. So it is already there, and then the sample size is 0 to, let's say now is 1:1, right? Let's say 1:5, for example, the bigger one. 1:5 and draw a plot. This is the plot. You put in this one, copy paste, right? Using log, copy paste, put in your proposal. Nobody get argue. Everything is there. Everything is there. So what does it mean? To get the power of 90%, your sample size is somewhere near to 1:5. Let's say 1:1, around here. 90% power is around here. So around here. So it means here 1:2 something, right? So this is a way of presenting, right? Okay. Can you follow? You follow?
Yes, Prof. Can.
Okay. Okay. Here, tips and tricks, do's and don'ts. I need to say. First, do's and don'ts, very important. Everybody must be very careful. Effect size. If effect size is in this kind of situation, effect size is equal to delta divided by sigma. Delta means detectable difference. Sigma means standard deviation. Effect size equal delta divided by sigma. Situation like this, effect size should not be more than 1. What does it mean? Should not be more than 1 mean your delta should be smaller than sigma. Am I right? Your delta should be smaller than sigma. In that case, you will always get less than 1. In other words, your detectable difference that you are expecting from this study should be smaller than standard deviation. If your delta is other way around, very big, you look for the big difference, then your effect size will exceed 1. For this kind of situation, effect size exceeds than 1 is not acceptable. What does it mean? You are looking for the big difference, and your standard deviation is actually smaller than your difference you are looking for. Then statistically not sound, right? Clinically, so much expecting the difference, right? Drug, just an example, old drug is good already, but because of cost and maybe because of that, they look for the new drug, but they expect only 10 difference, 10 millimeter difference, clinically very sound. So we need to think about both clinical and statistical, right? We are medical doctors, right? So this is just a guide. We have to go for clinical importance also, not only statistical significance. So if you are expecting so much of difference, clinically not meaningful, it means that you are expecting the miracle drug to get it, come down, miracle drug, right? Where expect is so much, then your effect size will be bigger than 1. Statistically also, sample size will be very small. If you put so much difference, as I mentioned, difference is too big, sample size small. Difference is small, sample size is big. So conclusion, for those study proposal with effect size more than 1, for me, effect size actually is, I prefer 0.8. Why 0.8? Kuhan, very popular statistician, right, based on clinical medicine. Kuhan recommended, you can go to the website, you can read. Kuhan recommended that small effect size is 0.2, medium effect size is 0.8, large effect size is medium effect size is 0.5, large effect size is 0.8, 0.2, 0.5, 0.8. 0.2 is small, 0.5 is medium, 0.8 is large. Kuhan recommend not more than 0.8. I agree with him because even 1 is big already, effect size. But if you want to go for 1, also still acceptable, but the preferably not more than 0.8. You can type Kuhan, C-O-H-E-N, Kuhan. You can read about effect size, right? So conclusion, effect size more than 1, don't submit your proposal. In your research and ethics committee, some are very knowledgeable, right? They will say that your effect size is more than 1. Please go back and look for more literature, look for more reasonable statistical difference, and come back again. Waste of time, right? So that is first tip. Another tip is, can you follow the effect size one? Can you follow?
Yes, Prof.
Okay. Another tip is, you have done a study already. Your sample size need is 121 per group, right? What happened? You cannot get it. Your sample size, you got 110 only, right? So if you want to get the 121 sample, right? With the power in 90%, you got at the end of your study, 110 only you got it. What are you going to do? Are you going to report with 90% power? Are you? Your 121 is your sample size you need, but you got 110 only. Your power is no more 90%. You remember? No more 90%. Then you need to write in your methodology, in your result, in your methodology, in your discussion. Not in result, in your methodology and discussion. Researchers require sample size 121 to fulfill the power of 90% and alpha of 0.01. However, at the end of the study, researchers could manage to get the sample size of 110 per sample because of some logistic problem. Therefore, post hoc power, P-O-S-T, post, H-O-C, hoc, post hoc power at the end of the study is like this. How are you going to present? How are you going to calculate? Go to power, right? Your everything is the same. Change your sample size. You got 110 per group only. 110 per group only. And you calculate your power is 86.6%. Trust me, you will graduate. Your paper will be published. No problem. Power is 86%, more than enough. Right? Even though we expect 90%, but still publishable, still you can graduate, right? If you don't write the post of power in your methodology and also in discussion, then the reader, the examiner will ask that you don't understand, your power is no more 90%. Your sample size need 121 per group. Now you got 110. Then you have to redetermine post hoc power. Don't forget to write in your methodology. Don't forget to write in your discussion. Are you clear? That is called post hoc power. Are you clear?
Yes, Prof.
Okay. Any more issue for this? I think only that. Right?
Prof, do you want to take a few questions from a participant? Were they asked on randomized control trial?
Okay. So related question I would take.
Yeah, but actually we quite I have a short time lah. So I take one question from Dr. Fatin. Well, actually she's asking Prof in the cluster RCT, how to
Okay.
determine the number of cluster. Can we fix the number of the cluster? For example, my cluster is 32 health clinic. Can I divide into 16 cluster per arm? What is the formula to be used to determine the cluster size?
Okay, good question. Cluster RCT is different from classical RCT. Question is very good. In cluster RCT, right? The person who Dr. Fatina, I'm sure she is knowledgeable about this. In cluster RCT differences, cluster RCT is based on clusters, not based on individual anymore, right? So methodology is different. So sample size calculation also different, right? not like individual anymore. So in cluster sampling RCT, right, as the basic of cluster sampling method, right, you need a larger sample size, right? Why larger sample size? I will touch on it in when you go for prevalence study. Why you need a larger sample? The reason being, the samples are homogeneous. You are taking this particular clinic or particular medical setting as a cluster. So you are taking all of them based on the cluster RCT. You must take all of them. Those who are eligible, you must take all of them. Because of that, they are considered a homogeneous sample. Because of that, you need to have a cluster effect or design effect, right? You need to multiply by 2, 1.5 to 2, right? So based on that, sample size is bigger. And don't forget another thing, they have a correlation, right? Correlation among that because of homogeneity, right? So based on the correlation, based on the cluster effect, sample size calculation is different, right? So come back to the point of Dr. Fatin, how are we going to take the sample based on the size of the cluster, right? You have to adjust based on the size of the cluster. Cluster size is big, sample size will be bigger. Cluster size will be small, sample size will be smaller, right? So you need to have the particular what you call the information before you allocate the sample for each cluster. You need to have information of what you call the sizes of the clusters, how many clusters, and based on that, you have to adjust it. Of course, in the calculation of sample size, correlation is there already, and also for the cluster, what the effect is there already, right? And so and so. That is called cluster RCT, right? Have I answered your question, Dr. Fatin?
Yes, Prof. So it means that we can fix the number of clusters, is it? From
Yes.
clinic,
Number
so
clusters.
I can fix 16 per arm. 16
You
for
can.
intervention.
You can, of course, number of clusters depending so much on your sample size required, and right. So you need to have some information, what you call the beforehand, and you decide how many clusters, right? Based on the clusters, and of course, the size of the cluster is one thing, number of clusters is one thing, and based on the formula, you calculate it, right?
So can we choose to use the ICC 0.05 or we have to use the lowest ICC 0.005?
Okay. Again, this is another good question. It is very much depending on ICC, right? We call it intra-class correlation coefficient, or we even call intra-cluster correlation coefficient. Anyone is called the same thing, intra-cluster, what's called intra-class correlation coefficient. Okay, so parent should be intra-cluster. So what you call rule of thumb, people take a 0.5 around that, right? But again, you can adjust it. Some kind of information you should get it. Smallest one you can go for it, of course you can. But again, it depends on how much you can afford. This ICC can be something like play around. You can, right? Depends on the affordable number and so and so. There's no hard and fast rule, right? But it must be the meaningful ICC, a possible acceptable ICC, right?
Sahatim, may I add to that is that the ICC, I think if you have similar study before, like in Malaysia in primary care, you may just ask the previous study or investigator team to provide you with ICC. Let's say you're doing on HbA1c or glycemic control, and the previous team had done something similar. You can ask them for the ICC for this outcome.
Yes, it is acceptable. It's acceptable. If published, correlation coefficient can be taken from literature. Can?
Yeah, Prof. I think another response and probably my question also is the numbers of clusters as posted by this participant. One, from what I know, is that because of cluster RCT of the study design is definitely ultimately will require something similar to hierarchical analysis, like mixed model. And for that to happen robustly, they need to have at least 10 cluster. I'm not sure why is the reason. I learned from literature that to have
Yes.
that kind of analysis robustly to be done, it has to be at least 10 cluster. But I do not know the reason. Maybe
Okay.
you can help.
Yeah, that is again arguable, right? Some put at fixed 10 clusters, but in logistically speaking, sometimes you really cannot get 10 clusters, right? It is not easy to get the clusters, right? So some feel like is not agreeable, but of course there's a point of putting 10 clusters because of possible differences based on the setting, geographical, and other factors. Because of that, putting more cluster where it can, because of the design is based on the cluster, so it may get some heterogeneous kind of sample. You can get it because of that. The cluster's number was fixed, right? Some people put the so 10 clusters, so. But logically speaking, sometimes not practical, right? Not practical. So some are not in favor. And another thing is, if some classes are very big size, sample size is actually already got the number already. Do we need to extend till you get the 10 clusters? There is another question again, right? So this is something like still arguing. My point is very simple. If you can get the what we call the relatively acceptable heterogeneous sample to answer the research question, and based on the cluster sizes, number, of course, if you are concerned for number of clusters, but still, acceptable, even though maybe less than 10 clusters, right, or more than 10 clusters. Like this case, 16 per arm, right? 16 per arm for the 16 cluster per arm. So thanks, Dr. Chu. I'm aware of that also. But yeah, thank you.
And then there is, I think I will take one question only actually from Prof. Ching. She's asking how to calculate sample size for feasibility study of RCT.
Feasibility study.
Yes, Prof. For RCT.
Okay. Feasibility study. I used to have. I even forgot. Feasibility studies. Prof. Chin, right?
Yeah, Prof. Ching.
Chin, can I get back to you later? I forgot already for feasibility studies. Long time ago, I helped. Can I get back to you, Prof. Chin, later?
Yeah.
I recall back. For the time now, I cannot remember. Feasibility study. I get back to you, Prof. Chin. Thank you. I'll get back to you.
Prof, we have another 3 topics, which I think we need to lag our time to up to 1:30 p.m. Is it possible to finish it for all the 3 topics?
Yes, can finish. Now is okay. Can finish. No problem. So okay, shall I proceed?
Yes,
Prof. Chin's question. I'll come back to that. Yeah.
Yeah.
Okay, so this is the one that calculate for 2 means, right? Dr. Malini question for nested case control. I found it already. Dr. Malini, maybe I will later explain you maybe afternoon. Dr. Malini, right? Okay. So wait. Okay. Can you see the slide? Can you see my slide?
No, not yet, Prof. This is still the software.
Software, okay.
Yeah.
Okay, yeah. Okay, so this is about 2 means. A post of power I mentioned already, right? Post of power I mentioned already. 2 proportions. Okay, these 2 proportion, if you learn now, it will be easier for you to do for case control cohort and cross sectional. 2 proportion means P0 and P1, right? In the software setting, formula is P1 and P2, right? So for information, many students, many lecturers ask me, they got confused. Should I use P1 and P2 or P1 and P0? Don't worry, right? In formula is, you can see my slide, Asifa, you can see my slide?
Yes,
yeah.
correct.
Formula is P1 and P2. Almost all formula except one, they use P1 and P2, right? For software use P1 and P0. Same thing. P1 is the proportion under interest. P2 or P0 is the proportion come from literature. I repeat, P1 is the proportion under interest. In other words, expert opinion. P2 or P0 is the one come from literature. Right? In other words, P2 or P0 should be the control group. If it is prospective cohort study, then the unexposed group. If it is case control, that should be control group, right? That is a control group. For interest group, P1 is if it is prospective cohort study, means proportion of disease in exposed group, right? If it is a case control study, should be the cases group, right? So in other words, P1 is the group under interest and must come from expert opinion. Control group is the one come from literature. I always remind this, right? Many people took wrongly, like in the two means, right? Two means, which one is literature, which one is expert opinion. I mentioned already, right? Sigma is from literature, delta from expert opinion. Same thing here, right? In two proportions, P1 from expert opinion, P0 or P2 from literature. So even though Dr. Chu reminded me not to talk about formula, but to complete it, I will just explain a bit. There are three formulas, and there are some more formulas, but these are the three most common formulas used for two proportion. One is called Pocock's formula, right? P1, 1 minus P1, P2, 1 minus P2 divided by P1, P2 squared, Z alpha, Z beta squared. So P1 is the one under interest. P2 is the one control group, right? This is the formula. So same thing here, Z alpha, Z beta is the one that I mentioned just now based on the power and alpha. So P1 comes from expert opinion, P2 comes from literature, right? And there is a second formula, formula number 2 is, I call it modern formula. Why? Same as Pocock's formula, but at the back, Z alpha, Z beta whole square is replaced by what you call the alpha and beta from the table. From the table, just get the value. Actually, these two formulas are the same, but this one is by putting in the value. This one is from the table. You take it. For example, 77.9, the value 7.9 for 80% power and alpha 0.05, 10.5 for 90% power and alpha 0.05. So just for your understanding, right? This is I just call it. There's no names. So I call modern formula, right? Third formula, I call it a classical formula. Very long time developed formula. This formula is very long time already, right? So this is a classical formula. Whatever formula, three formula basically is P1 and P2 or P1 and P0. They got more or less the same result. So just to explain you, three formula. Okay. So in two proportions, in RCT also you can calculate two proportions. In RCT also, right? Two proportions. So if you look at here, drug A and drug B, there's a randomized control trial, multi-center clinical trial. So they are looking at the treatment A and treatment B to follow up for 5 years recurrence of the disease, right? After 5 years, drug A and drug B, that particular disease recur or not. Treatment A is a central treatment which is known that 35% of disease occurrences obtained. This is the treatment A is a currently available drug, but the recurrence is 35%. It means a relatively high. So because of that, they want to create develop the treatment B. Treatment B is expected to be 15% only recurrence event. Remember, must be clinically meaningful, right? Here, treatment A, which is available, is 35% recurrence. Treatment B, which is new therapy proposed, expected to be 15% only, right? So by this way, which one is P1, which one is P2? P1 should be 15%, the one that you are interested. P2 should be P2 or P0 should be 35%. That is available from literature. So 35% from literature, 15% from expert opinion. Here again, we call it absolute effect size is 35 minus 15%, that is called 20%. Some people may call detectable difference, right? So detectable difference, or here absolute effect size, is 20%. They are different 20%. So if you are expecting 20% difference in these two drugs for recurrence, then how many samples do you need it? Right, power is 90%, alpha is 0.05. Right, so you must be able to determine P1, P0 correctly. Right, danger is in software, P1, P0 you put wrongly, sample size gives the same result. Same result. Software maker did it, P1, P0, same result. However, if you put that, for example, here, P1 is 35%, P0 is 15%, for example. Statistically, you may get the same result from the software, but your concept is wrong already, right? Old drug is giving 15% recurrence. New drug is giving recurrence 35%. Why do we need to do this research? Am I right? Right? Old drug is only give 15%. New drug is 35%. You expect. You don't need to conduct this study. Then it is wrong already, right? So your P1, P0 must be correctly identified. Here, P1 should be 15%, P0 should be 35%. Put in the formula, sample size, you got it 96 per group. This is the classical formula, put it in. 96 per group. You need a 96 for new drug, 96 for what's called the old drug. I forgot to mention, you can put that, you can add the what you call, like dropout rate, for example. This is clinical trial, dropout or withdrawal, right? 10 to 30% recommended by statisticians and epidemiologists, no more than 30%, right? So 10 to 30%, right? So you can add in if you are worried about your dropout, withdrawal, loss to follow up, and so and so, maybe death and so and so. So 10 to 30%, you can just edit, right? Okay. So you understand the question, right? So put in the software, right? So because of time, I will what you call, or maybe this the Codemas I haven't demonstrated yet. Okay, I will show you. Okay, go back to software. Share again. Okay. So can you see the software, PS software? You see, right? Azifa, can you see the software screen? Azifa?
I can see, Professor Atim.
Okay, okay. So you use dichotomous, right? What do you want to know? Sample size, right? Mesh your independent sample is independent sample. Case control here, case control or prospective. For your information, in the PS software setting, prospective cohort and clinical trials or community trials are under prospective. The rest are case control, right? This is the software setting, and nothing to do with statistics. It's the software, right? Software setting, control trial, randomized control trial, community trial, and prospective cohort study are under prospective. Case control is others, right? Others. Okay, so now should be prospective. How is the alternative hypothesis expressed? Two proportions, right? Two proportions, 50 and 35%. Is it right? And then the uncorrected chi-square or Fisher-Exact test. The reason why this option comes out is actually if the sample size is if the cells are small, you have to use a Fisher-Exact test. If the cells are large, you use a uncorrected chi-square, right? So normally use the uncorrected chi-square. Alpha is 0.05. Power is 90%, 0.9. Zero P1, you have to be carefully, right? 0 is 35%, right? 0.35. P1 is 15%. 0.15. Ratio is, okay, here we you got, let's say 1, right? In that case, the percent needed 96. Hand calculation also 96, exactly the same, right? 96 per group. 96 per group. This is by using two proportions. Are you okay? Are you okay?
Yes, Prof.
Okay. So you can report that 96 per group. If you want to add, you can add, right? So adding must be very careful, right? How do you add 10%? How do you add 10%? If you add 10%, right? What normally people do is 96 plus 10% mean 9.6. Let's say take a 10, right? So 106. Am I right? 96 plus 10% is 9.6, made it rounded 10. So 106. That is not the right calculation. Many people do that, right? Right calculation is 96 divided by 1 minus 0.1. 10%. 96 divided by 1 minus 0.1. How much you got it? (96) divided by 1 minus 0.1 means 0.9. Sample size is 106. That's 107, right? Sample size may be the same, right? But calculation is not right, right? If you put as 96 plus at 10%, that is 9.6 made it 10 is 106, right? That is not the right calculation. What you should calculate is 96 divided by 0.9, 1 minus 0.1. That is 106.67, 107. Sometimes more of the same, but calculation is the first one is not correct, right? Because way of calculation must be denominator must be 1 minus what you call the dropout rate. 1 minus 0.1, 1 minus 0.2, and so on, right? I will repeat it during what you call prevalence study. Right? Okay, I finished the clinical trials already. Any question? Maybe I should go to observational.
Yes, Prof.
Yeah, observational
Yeah.
analytical first. Yeah. So as we have started 2 proportions already, I will continue. Okay, I will continue to observational analytical studies. After that, last one, observational descriptive studies, right?
Prof, wait, there is one question from Muhammad Numan. I think he's tried to ask on the RCT.
Okay.
If we're doing safety and efficacy study of how we can calculate delta and standard deviation and M.
Safety and
Safety and efficacy study.
efficacy. Efficacy, right?
Yeah, safety and
Okay.
efficacy study of drug.
Okay. Efficacy study actually is it is the same. It is you are talking about the phase 3 trial, right? Phase 3. If it is efficacy, is the same, right? Safety may be a bit different, right? Safety part is you are talking about in the phase 1 and phase 1, phase 1
Phase 1 and phase 2.
Phase 2, right?
Yeah.
So efficacy studies are same calculation here, right? So you are looking for the difference of a particular parameter, right? As phase 3 is we got among those with disease. So phase 3 is the phase 3 studies efficacy are the same, right? You put in the particular parameter, looking for the difference, the expected difference based on the delta, and of course standard deviation, and what you got, you just get it, right? It's the same. It's the same. Okay. Wait, we're going to observational analytical. Okay. Okay, after understanding about true proportion, it will be much faster, right? Observational analytical studies, right? Aziba, can you see my sharing?
Yes, Prof. Can.
You know, okay.
Hmm.
Observational analytical study, okay. So same thing come back, two proportions, right? And then I mentioned about the Pocock's formula and modern formula and classical formula. So now we're going to calculate prospective cohort, right? In prospective cohort studies, right, as we all know, starting from the exposure to disease and non-exposure to disease, you get a sample size, right? Based on that you calculate, right? So of course, here added thing is risk. So I will demonstrate for you also risk, right? How to calculate based on risk, right? Okay, so let's see here. This example is also quite a good example. This is based on the population, right? Two communities, A and B, they are considered as that exposure, they are different in exposure to a particular environmental chemical pollutant, right? There are two communities. One is exposed, another one is non-exposed, right, to the chemical pollutant, right? So this chemical pollutant environmentally, it is considered as it is a risk for developing cancer, right? So we need to do a screening program. So this screening program is actually, they are going to do the permanent resident age more than 35 years in the two communities. They do the prospective cohort study. After some time for prospective cohort study for follow-up, right? They got the two groups, right? Where unexposed group got the incidence rate of 1 per 1,000 population, right? That is for the unexposed community A. In the exposed community B, it is estimated. So it means that this is a P1, right? P0 should be from literature, 1 per 1,000. P1 is 15 per 1,000. In other words, proportion is 0.001 and 0.015, right? 0.001 and 0.015. Must be meaningful for the exposed community must have a higher incidence, right? So the question is, how many people in this age group, right, need to be screened, right? If the power is 90%, a significant level of 5%. So alpha 0.05, 1 minus beta 0.9, and then the P0 and P1. P0 is 0.001. P1 is 0.015. Can you follow? Follow?
Yes, Prof. Can.
Okay. So, okay. Calculate the sample size based on this formula, classical formula. You got a sample size of 848, right? The difference is how much different? 0.001 and 0.015, right? So relatively quite big, right? But still okay for this parameter. Sample size you got is 848 per group. Per group means what are they? Two arms, right? So two groups. So 848 per group. Now we are going to calculate sample size based on software. Okay. Okay, here, put it in, right? 0.001, 0.015, right? Maybe because of time, I will just show by software. I mean the output, right? So alpha is 0.05, right? Power is okay. Alpha is 0.05, power is 0.9, P0 is 0.001, 1 per 1,000. P1 is 0.015, right? Ratio of 1, sample size you got it 849. Just now hand calculation was 848. Here is 849, only one different, right? So sample size is acceptable. You may add 10 to 30%. Let's say missing the non-respondent. Are you okay? This is the prospective cohort study. Any question about that? Is it okay?
Yeah, Prof.
Okay. So coming to case control studies. Case control, right? In case control studies, cases are those with disease, controls are without disease, right? Remember, this is a control. Cases are those with disease, control are without disease. Looking for the exposure among cases, exposure among control. So in other words, proportion of exposure among cases divided by proportion of exposure among control is that is the one that you are looking for, and you get the odds ratio. Okay, this is the example. Case control study is being carried out to determine the relationship between eating jelly beans and developing rubebitis. It is known that approximately 20% of the population eat jelly beans and increase in consumption to 30% in cases, corresponding to an odds ratio of 1.5. Question is, you have two groups. One is rubebitis, another one no rubebitis, right? And then looking for the exposure. Why rubebitis? Got it, right? And then the interest in eating jelly beans. Whether eating jelly beans can increase the chance of getting, increase the odds of getting rubebitis, right? So information is, it is known that approximately 20% of the population eat jelly beans and increase in consumption to 30% in cases, corresponding to an odds ratio of 1.7. Can I ask you, in this case, which one is P1, which one is P0? Which one is P1, which one is P0? Right? I give you a hint. In the population means, right, for those who are not eating jelly beans. In the population, in the population is actually people take naturally jelly beans. How many percent of people take? Whereas in 30% means, right, if you take jelly beans and develop rubebitis, right? So which one is P0, which one is P1? Common sense, for those who eat jelly beans, right? It is those develop rubebitis should be higher or lower. Should be higher or lower. Should be higher or lower.
P1 is 20%.
Which one you are interested? You are eating those with jelly bean.
I think interested to 30%, the increment.
Then that should be
P1.
P1. So 30% is P1. P0 is
20%.
20%. P0 come from literature. P1 come from expert opinion. So yeah. So increase in consumption mean you are right. That is the P1. Increase in consumption to 30% mean P1 in cases. Remember, in cases, that is important. In cases. So in that case, increase in consumption to 30% in cases is P1. P0 is 20%. That must be correct. Okay, it's considered to be clinically important. How many cases the controls are required to detect this difference at alpha 0.05 with a power of 80% power, right? Okay, so here we can calculate by two ways. One way is using two proportions, 20% and 30%, by 20% as P0, 30% as P1, right? And remember, I want to tell you how to calculate by what's called determining risk, right? So here risk is for those who eat jelly beans, where right? Where higher risk of developing what you call ribovitis by looking at the odds ratio. Odds ratio 1.7. Odds ratio 1.7. So it means that this you can calculate not only by proportion but also by using risk assessment, right? So we try to calculate by both. Right, let's do it. Okay. Can you see PS software slide?
Yes, yes.
Okay. So here we are going to use dichotomous, right? And then sample size and independent. They are independent. This is case control. So is it the alternative? It's what you call the alternative you mentioned by two proportions? Yes. First, we use the two proportions. And as I mentioned, incorrect, sorry, the uncorrected chi-square official exact should be uncorrected chi-square. Now alpha is 0.05, power is at 80%, 80%, right? And here, what is it? Here is, you got the ribovitis, and so P0 is, how much P0? P0 is 20%, am I right? 20%, and then sorry, 20%.
35.
Yeah, 30, right? Yeah, 30, am I right? 20
Yes,
30.
correct.
The difference is 10%. Ratio, let's say 1. So sample size is 293 per group. Per group, right? What is the sample size we got from hand calculation just now?
290.
290. So there's 293. So not bad, right? 293 per group. As you know, it's the case control study. So it's got, of course, it is rare, right? So sample size is actually relatively big, right? By right should be maybe even the bigger actually, right? Okay, so 20 to 30 is not bad, 20 to 30%. 20 is P0, 30 is P1, right? Okay, so you got the case control study with the for ribovitis, you got the two groups, right? That is the 293 per group, 293 per group. That is important, right? Are you clear? Any question? Maybe later I take the questions, right? Okay, so this is case control. Ajba, can you see?
Yes, I can see, bro.
Okay, case control done already. So subset 293. Okay. So if it is subjects are small, you need a boost of power. Right. The boost of power actually that time somebody asked to calculate. So 0.2, 0.3, and then subset okay get only 200. Right. The one that needed how much? The needed how much? 290. 93, right? So power is much down, 63.7. So comment is, if it is like this, comment is how the power Of course, this is not clinical trial, this is the observational study. So observational study is still allowable, right? Observational studies, right? Still allowable, even though power is quite low. I recently saw one, same thing, wrote what you call the final paper already, but the problem is it was some issue, right? Some issue. But anyway, got the green light, right? And then I think now I'm preparing for publication, right? But of course, if you can get the higher power, it's better, right? But it's better. Not really bad, but not very good, right? 63.7%. Okay. So how to calculate a cross-sectional study? This is the last one for observational analytical study, right? So this is a cross-sectional study. How to calculate, right? So in cross-sectional study, if you remember, you are looking at the association between disease and exposure, right? Association between disease and exposure. So, example, researcher would like to conduct a cross-sectional study to identify the associated factor of smoking among adolescents. Among all potential associated factors, paternal smoking among adolescent non-smoker was reported as 20% by the previous study. Right? Paternal smoking among adolescent okay. So how many adolescents you needed? It is a power and a level significance of 5%. So this 20% is P0 or P1 by the previous study. P0 or P1. Sorry? By the previous study. Yeah, somebody wrote there, P0. Okay, correct. P0. P1, you have to predict. So can I ask you the very biologically meaningful, meaningful one? This is P0. You want to predict P1. P1 should be higher or lower than P0. Read back. The researcher wants to do the associated factors of smoking among adolescents, right? Paternal smoking among adolescent non-smoker. It means that this is father smoke, father did not smoke. Am I right? And then the adolescent, the child smoke, do not smoke. Right? So paternal smoke, child smoke, yes or no. Paternal do not smoke, child smoke, yes or no. 4 categories. Is that right? So you are looking for the association between paternal smoking and adolescent smoking. Am I right? So paternal smoke, adolescent smoke, do not smoke. Paternal do not smoke, adolescent. Paternal do not smoke, child, adolescent smoke, yes or no. Paternal smoke, what about what you call adolescent, yes or no? 4 groups. So this is paternal smoking, but child doesn't smoke. Is that right? Adolescent non-smoker, right? So this is P1 or P0. This is P0, right? But the P1 should be higher than P0 or lower than P0. Common sense? Common sense? Paternal smoking, non-smoker, right? Should be higher. Okay. How high? How high? Yeah, I propose for 15% difference. Right? So P0, 0.2 mean proportion of paternal smoking among general population reported by previous study. 0.35 mean the expected proportion of paternal smoking among adolescent smokers. Right? Here is what you call among adolescent non-smoker. Right? So you have your Father smoking, adolescent non-smoker. Father smoking, adolescent smoker. Of course, adolescent smoker should be much higher. How high? Right? P1, I put as the difference 15%, the technical difference, 15%. M equal 1, right? So sample size needed is 135 per group, right? So if you want to get the additional, this look at it here, how to add the 20%. 135 divided by 0.8, 169. Not the way that I mentioned, right? 139 divided by 0.8, it should be 0.8 mean 1.1 minus 0.2, right? So $169 per group multiplied by 2, because there are 2 groups. This is the way of calculating sample size for cross-sectional study, right? It's a cross-sectional study. Can you follow? You get
Yes,
it?
Prof.
Okay.
Yeah.
The calculation here, right? 0.2, 0.35. So the one you can do by yourself. Everything given already. P0 is 0.2, P1 is 0.35. Important thing is don't make it reverse. P0 is 0.2, P1 is 0.5. Okay, this was the last one. I haven't finished yet. Because the prevalence study left. So observational analytical finish. Observational analytical, prospective cohort, case control, and then cross-sectional. In intervention, it is a parallel, right? And then second one was that intervention is, first one is parallel design. Another one is outcome is categorical, cure or not cure. Right? That's it. So we finished interventional, what you call the interventional studies. We finished observational analytical study. The last one is, sorry, the other one is observational descriptive. Observational descriptive. So let's go for observational descriptive. In observational descriptive studies, as I mentioned, right, we will do the prevalence studies, right? How to determine a sample size for single proportion, right? So prevalence studies are actually, can you see the slides? Can you see? Azifa, can you see slides?
Can, Prof.
Prevalence studies, right? Okay. Observation, you got the disease and non-disease. You are interested in occurrence of the disease, right? Prevalence studies. So you got a population, you got a sample. This is, of course, single proportion, right? Single proportion formula here, n equals z divided by precision. Here we call it precision, right? Z is 1.96 fixed already for power 0.05, right? Precision, which got the, sorry, not power. What is this precision? The meaning of precision means, if I explain a bit, precision means width of the confidence interval. Confidence interval, lower bound, upper bound, how close to each other. If the precision is wide, right, sample size is smaller, precision is small, sample size is bigger, right? So this precision is basically how much difference between sample proportion and population proportion. Let's say smoking. Sample proportion is, let's say, 35%. Population proportion should be more than the same, right? So the sample is 35%, but population should be more than the same, right? So together more than the same, then your sample prediction must be, sample precision must be very good, right? Because this triangle is meaning is difference between population and sample proportion. That's the meaning, right? So if you are expecting proportion of the proportional sample as population, if they are not much different, very close to each other, sometimes very big. If you are expecting the difference, right, reasonably different, what you got the result, then subset will be smaller, right? So how to fix? How to set these? Z is 1.96. It is fixed. Z is 1.96. Delta, or here, not delta, sorry, this is the derivative difference, right? The derivative difference between population and a sample prevalence. How much they are different? So normally we put as 0.05. However, if there are reasons, you can change, right? 0.05, it is adjustable, but that 0.05 is the one that we can afford to see what is the difference between population prevalence and sample prevalence, 0.5%, right? That is the meaning of precision 0.05, right? You can add 0.05, you can add 0.1 difference, can also, right? But remember, if you have your what you call the percentage is the bigger, sample size is smaller. Your percentage, I mean, the difference between two is not much different. They're close to each other, sample size will be bigger, right? So that is the concept. Z is 1.96. Z is fixed, 1.96, right? But down there, that triangle, precision is actually, it can be varied, right? Precision, good, very narrow, sample size will be bigger. Precision poor, sample size will be smaller. Okay. P is prevalence from literature. Same thing, local, regional, global, you need to decide, right? The best is local. P1 minus P. So Z divided by precision whole square, multiplied by P1 minus P. Population prevalence is there, right? So based on that, we calculate sample size. Okay. A local health department wishes to estimate the prevalence of dental caries among children under 12 years of age in this locality. How many children should be included in this example so that it may be estimated to within 5% points of the true value within the welfare? It means that 5%, 0.05, right? It has been estimated that the prevalence of dental caries among children was 20%, right? So it means that P is 20%, alpha is 0.05, confidence interval 1 minus beta is 0.95, right? That's it. I want to ask you, how you are observant? Something is missing. It has alpha 0.05. It has difference of communal limits. It has prevalence is 0.20 to 0.2. What is missing here? Anybody who can look around? Look at your 2x2 table. What do you see? What is missing? Okay, I will answer. Here, there is no power. You notice that? 1 minus beta. You notice that?
Yeah.
Yeah. Descriptive studies, power is not necessary. Even though some software asks, but go back to theory, power is not necessary. Right? Just for information, right? Okay. So we calculate by formula. 20% is prevalence, 0.05 is level of significance, and precision is the one I mentioned, how much difference between population prevalence and the sample prevalence 5% different. That is precision, right? So put in the formula, you got a sample of 246, 246, 246, right? Go to AppInfo software. I think I need to demonstrate for AppInfo software. You know, mine will not come. Have you got AppInfo?
Yes, yes.
Wait, why did it not come up? You know, no problem. Okay, sorry, some technical problem. Yeah. Okay, sorry. So you got AppInfo software. Okay, you got like this.
Yeah, Prof.
Okay, sorry, no, take time. I have some problem with my computer. So go to StatCalc, right? StatCalc, and go to population survey. Okay. So can you see this table?
Not yet, Prof.
Uh,
Is it the small
this one?
table?
Small table. Do you see small table?
No, there is a background of your
Okay.
slide.
Now can you see the big one? Big already?
No, Prof. It's a software by software app info. I mean I mean your PowerPoint.
Oh, I have shared already.
I think Prof need to stop share the PowerPoint first.
Okay.
Yeah.
Then go to okay. Now can you see? So I'll stop sharing. I need to share. Share again. Then this one. Can you see now?
Yes. There is a two table here.
Okay, this one.
Yeah.
Big one, right?
Yeah.
Big screen already. Okay. So now we are going to calculate sample size for a situation like this, right? So just now was what was the question? Then it was the what was the question? I forgot. Is it 10 degrees? The question.
Yeah.
Just a minute. I read back. Okay. For those that 10 categories, looking for the prevalence, right? So those were 20% from previous literature. That is P, right? And then 0.05 and confidence interval 95%. Power is not applicable here. So now we are going to see the what you call the here. Can you see here now, right? So expected frequency is 20%. 20%. Acceptable margin of error is just now mentioned, the 5%. Here, very important, right? So the one that just now Dr. Fatin asked and also Dr. Chu asked, right? This one, sample size based on 95% CI is 246. Can you see? Can you see 246? Our hand calculation also 246. Here also 246. Can you see? Can you see 246?
246. Yeah.
Can you see?
Yes.
Okay, so 246 sample sizes. I mean, I'm showing the table. Am I right? 246. Yeah. So this calculation is based on other sampling method. Maybe a simple random sampling, systematic sampling, stratified sampling, and so and so. But if you use a cluster sampling, as I mentioned, when you do cluster sampling, the samples are actually sharing same geographical background and any other thing. So because of that, you need to accommodate for cluster effect, right? It is very possible that if you take do the cluster sampling, like the cluster as you just now mentioned, right? Now it's clusters, we got the cluster probability sampling method, cluster sampling. If you are doing taking the cluster sampling as your method, then majority of the people are sharing the same criteria, right? Same geographical characteristics and so and so. Because of that, because of the homogeneity, the researchers are worried that you cannot find the possible significant difference. So in that case, you need to apply design effect. How to apply design effect, right? Here is sample size 246 only, right? So sample size is there already. So it means that only one cluster in the one particular particular operational area. That's it. However, researchers want to apply cluster sampling. Let's say you have 5 clusters, for example, right? Here you have only one cluster, so sample size 246. If you have a 5 cluster, then you need to have your design effect you have to apply. Design effect is between 1.5 to 2. You need to multiply the sample by 1.5 or 2. Normally, I make it easier, multiply by 2, right? So that is called design effect, or we call it cluster effect. 2. And you have your what you call the clusters are 5. Clusters are 5, for example. Then sample size you need is 495. One cluster is 99. You see? You see, and then first combination number. You see? Sample size you need 495. Remember, if you apply the cluster sampling, your sample size increase. Same as a cluster RCT, right? Compared to classical RCT, a cluster RCT sample size is bigger. So here, same thing, right? Sample size is bigger, right? You apply cluster sampling, so multiply by 2, and you got the 5 cluster. That is multiplied by divided by 5. So sample size, total sample size is 495. Divided by 5 means 99 per cluster. The one that the question asked, Dr. Fani asked question, right, in the cluster RCT. Then again, you need to think about how sizes of the clusters are different. If sizes of clusters are different, then this one like this cannot apply. This is, of course, this is not for RCT calculation. This is for prevalence study, right? So in what you call the cluster RCT, based on the size of the cluster, you have to calculate sample size, right? It will be different, right? Okay. Let's say, for example, I have what you call the difference between population and sample prevalence is not 5%, it is only 3%. But looking for the closer, what you call the closer prevalence between population and sample, right? Their sample size should be bigger. Here, bigger already. 1365, one cluster need 2733, right? No, even I go for, even if difference is 1, I'm population based. I'm doing the population based study. I want to have a very strong precision where difference is only 1%. Sometimes it's very big, right? So 1, 2, 2, 2, 0. This is a population based study, right? So we have 5 clusters, right? So total sample size is 1, 2, 2, 2, 0. One cluster need 2, 4, 4, 4. Right? I think we got clusters should be more. I need a 10 cluster. Of course, if we share 10 cluster mean one cluster 1, 2, 2, 2, sample size is 1, 2, 2, 2, 0. That is based on cluster sampling. Other sampling method, probability sampling method, no need to multiply by 2. Right? That is called cluster sampling. Is it right? If there is no cluster effect, there is no cluster, effect or design effect, then this one no need to apply, right? And then the cluster also no need to apply. You may go in the one particular community, you may do it, right? Are you okay? Are you okay?
Yes, Prof.
Yeah, okay. The last one example is estimate the proportion of Malaysian-based smoke. What sample size is required to achieve a 95% confidence level of with 5 plus or minus 5%, right? 37 years ago, found approximately 30% were smokers, right? So in that case, 5% and the proportion is prevalence is 30%, right? So go back there, go back to same calculation. You can see, right? Okay, so 30%. So this is the 30%, right? Maybe in one particular area, then the cluster is only 1, right? And then no design effect. Design effect is 1. So sample size you need is 30%. Expected is not 30%. Sorry, 30%. Oh, this is still 1% is very high. Sample size you need is 323. right? 3 to 3. I think here's this in PowerPoint also same thing. I think. Yeah, 3 to 3, same thing, right? In your PowerPoint that I give 3 to 3. So if you want to add 25%, we got the dropout, then 3 to 3 divided by 0.75, you need a 431. In your handout, you can read, right? 3 to 3 divided by 0.75, 25%. Dropout, so 431. That's it. Finished already. Our target of all subsides are all finished already. Do's and don'ts, I forgot to mention. In do's and don'ts, in prevalence, right? Prevalence studies, many people got confused, right? I went into calculation for sample size. I look for in the literature, prevalence is some give 30%, some give 40%, some give 20%, for example. Which one I should take? Can I take average? Can I take average? Right? By right, average is not encouraged. Should not take average because they are different operations, different what you call geographical area. So the best is go back to same thing, principle of local, regional, global, same thing, right? Locally, there's a publication prevalence, then go for local. Otherwise, it is actually regional or global kind of thing, right? You cannot take average. That is, average is not recommended. Are you okay? Right? That is the one tip. Of course, another tip is your difference between population and sample. The one that if we call it what you call the precision, right? Precision is small, sample size is big. Precision is big, sample size is small. So that precision must be also reasonable. By our experience, right, precision is normally take at 5%, but if you think that sample size is still big, the most you can go maybe 10%. I used to see some people take even 15%. I think for me personally, 10% enough maximum, right? If 10% sample size will be smaller. Of course, if you can afford, go for 3%, 1%, it's up to you, right? If those who are doing population-based from the Ministry of Health, for example, population-based studies, they may take the smaller precision, right? The sample size will be big, right? These are the tips. What else? Adding for the percentage, be careful, right? Only that. So the one that I have targeted, all finished, right? So any question, except the one that I want to add, remember, assignment, the one only I want to add. So I'm giving to you 1:30. So we got can I take questions? How, Azifa?
Can. Prof, do you want me to read a few questions from the floor?
Yes.
Or okay. I think there is a few question from basically there is some participant that not understand what is expert opinion. So what is expert opinion?
Okay. Expert opinion means, as I mentioned, when Prof. Normala came and discussed with me for sample size calculation, I can do for statistical part, I can, but as she is the expert in that particular area, for example, in psychiatry, the study is the psychiatry-based study. The one that she proposed, I need to get opinion from her, where let's say she's looking for the difference between two groups, for example. She has two groups of two different types of drug therapy for depression patients, for example. She has a score, she has something score. She wants to look for the difference, right? So at that time, out of two groups, right, the usual drug group she got already from literature, but for the new drug group, she wants to she wants to come up with idea where the difference between two score, right? What would be the possible difference of score, right? So as I mentioned, if the two means, for example, you look for the sigma standard deviation from the literature. Difference between two groups is expert opinion is not me. Expert opinion is Prof. Normala. Prof. Normala will come up with the expected difference of score. She know one group, another group she predict. That is called expert opinion, right? She is the one who will give the possible difference between two groups based on the one group she knows from literature, another group she predicts. That is called expert opinion, not me, right? Because I'm not the expert in that area. That is called expert opinion. Same thing to what you call the categorical. Categorical, let's say this particular drug is cure rate is how much? Let's say cure rate is out of 100 patients, cure rate is only 40%. So new drug we want to develop, then new drugs should have better cure rate. Am I right? Right. So old drug is 40%. New drug should be, let's say, how many percent? We don't know yet because it's a new drug. Then expert opinion comes in from the expert. Expert will say she predicts that he or she predicts that the cure rate should be, of course, higher than the what's called the old drug. Let's say difference is 15%, right? Old drug is 40% cure rate. New drug is 55% cure rate, 50% different. That difference is predicted by the expert. That is called expert opinion. You got it?
Farah, do you get it?
Yes. Thank you.
Okay.
Okay, I think next question is from Hasni Hashim. He planned to conduct a cross-sectional study, population, one manufacturing company for about 2,600 staff. Then asking which formula to calculate the sample size.
Objective?
Dr. Hasni?
Cross-sectional is two types. One is descriptive, one is what you call the analytical. Which one? What is the objective?
Dr. Hasni?
Are you still around, Dr. Hasni?
Yeah.
Okay, I can answer. If it is prevalence, let's say prevalence of something in the company, for example, right? If it's prevalence, then it goes for single proportion formula. If it is association factor of something, for example, people in this that company, are they happy, not happy, for example, dichotomous. Then what are the associated factors? Salary, work shift, number of people working there, who is the boss, all these things. Then associated factors, then analytical. Right? I have an example. I will come to that. Yeah, I have an example. So it depends on the objective, right? Okay, and next. Aziba, next.
Wait, Prof, because there is one question from our Gambo, but I can't really understand it. Can our Gambo explain your question?
Come, explain.
Oh, is it our Gambo is here? No. And there is one question from Nurul Salwana. What is relative precision and absolute precision?
Relative?
Precision? Precise?
Precision.
And absolute precision.
Okay. Precision is based on either one or more population or one population. Where is the precision where you are going to talk about precision between the population and the sample kind of difference? That is actually possibly is the relative precision, right? When you are looking for the difference between two groups, where you are estimating based on the either proportion or either confidence interval or any other method, you are going to look at the difference between these two particular what you call the comparison. That is actually absolute precision, right? So this precision is actually very much depending on many factors, as I mentioned, sample size, what you call way of determining method, and so and so, right? So you are looking for the real difference, that we're looking for the difference either based on any parameter, proportion or mean or anyone, then that is called absolute precision, right?
Okay, thank you, Prof. Is it Farah Raihana has any question? No more. Okay, thank you. I see your hand there. Is it? Does anybody here still have any question to Prof. Hatim?
If you don't have, I have a test for you. The last one. Offhand test that I do.
Yeah, sure, Prof. Can.
Okay. Maybe I will straight away do here.
Assalamu alaikum, Prof.
Waalaikumsalam.
Please have a question, sir.
Yeah, okay.
Yeah, my question is about the deviation from population from sample size. Deviation from sample size, from calculated sample size.
Not very clear. What from sample size? Deviation.
Yes, after calculating the sample size,
Okay.
some are arguing that you can still deviate from that size and take a higher sample size.
You can still deviate from
Yes.
this sample size.
Yes, they said if the sample size, if for example you calculated 200 as your sample size, you can take 500. The only problem is you will not take lower than calculated sample size. So how rational is this argument?
Okay, I did not clear. I did not hear clearly. You mentioned that out of 100 sample, what do you mean? Can you repeat again?
For example, sir, you calculated 250 as your sample size.
Okay.
They said you can take 500 instead of taking that 250.
Instead of 250, you can take
Yes, 500.
500.
Yeah, you can go higher. The only problem is you cannot go lower.
You mean your calculate something like 250, but you can take 500.
Yes.
Okay. As I mentioned just now, sample size calculation is 250, and based on the scientific background and the statistical background, right? So if you have sample size calculated is 250, but you are taking 500, that is basically it is unethical, because sample size taking more than required to take is unethical. Same thing to sample size taking less than required to take also unethical. So some people take the what you call sample size bigger because they think that bigger the sample size, larger the power. Not necessary. Power is adequate already. No need to take more than that, because it has become unethical. You can imagine if, like for example, clinical trials, right? Clinical trials are anyway it is a risk, right? So you are putting the patients at higher risk unnecessarily, because sample sizes already fulfill the requirement. So taking sample size more than required to take it is unethical. It should not actually. Should not.
Perhaps I can give some response, Prof. Hatim.
Yeah.
What he was asking, if your calculated estimated required sample size is 200 or 250, and you should actually aim to collect slightly more is okay, but cannot be like too many over than your estimated sample size. Let's say you were saying you required just 250, but then you can slightly more than that, let's say 260, 70, all that, but do not actually get lesser than that, because you have already calculated that you need at least 250. And then you should go slightly more than that, not too many, and you do not want to go any lower, because there will be the risk of not achieving the power that you want for your study. Yeah, I think that probably helps to clarify a bit more.
Yes, correct. That's correct. Yeah. So basically, you got minimum required sample size. I mentioned the first in my lecture. I mentioned minimum required sample size, right? So we have to stick to that. like Dr. Chu mentioned, if you need some more because of the expected dropout and so, okay, fine, no problem. But you should not take very much different. That is unethical, right? Have I answered your question, the participant? Okay.
Yeah. It's okay, sir. Thank you.
Okay. So I just want to
Hello, Prof.
Yeah. Yes.
Hello, Prof.
Yes. I can hear you.
Okay, please. Sir, maybe you have discussed something I didn't get you right. For example, for those that are doing bioinformatics analysis.
Yes.
For example, I'm about to undergo a certain experiment on the comparison, or let's say the gene expression, which is bioinformatics, which involves the downloading of or retrieving of data from an online database. How shall I please calculate my sample size? Or it is among those that said it is not involved the calculation of the sample size.
Okay. So I want to ask you back. In bioinformatics, like you mentioned just now, do you have a testable hypothesis? You can
Yes,
any testable hypothesis do you have? Hypothesis. Let's say so and so gene. Let's say that gene expression so and so is associated with development of diabetes mellitus, for example, or that gene expression is associated with something. So if there is a testable hypothesis, definitely you need to calculate, and then you got a sample size, and based on your database online, you can do sampling, right? You can do sampling.
Okay.
You don't need to take all. So let's say, for example, online you got quite a number of data available, but you calculate sample size, right? You calculate sample size, and what you call if the sample size, as I mentioned, it is smaller than available. Of course, in your online, the sample size is very big, right? So sample size needed, for example, online available is 3,000. Your sample size you need it around 500 only. Then you have to do sampling method, right? So online of the database where you can do sampling, Let's say systematic sampling, simple random sampling, you can apply it and then you can take it. So to answer your question, if you have a testable hypothesis, definitely you need to have a sample size and sampling method. Right?
I'm sorry also, Prof.
If you have a testable,
I'm sorry also, Prof.
Can you get it?
For example, yes, sir. For example, I'm about to take a gene expression, let's say profiling of this gene expression profiling. That's to compare between certain cancer, let's say cancer experiment and a control group, maybe to find a differential expression gene between the two groups, for example.
Okay.
Yes,
so
sir.
Two groups, you are looking at the gene expression. So your hypothesis is there is a significant difference of gene expression between two groups. Am I right?
Yeah. Yes, sir.
Yeah, then definitely there's a testable hypothesis. So you need to calculate based on the what you call the particular information. So gene expression is, if I'm mistaken, gene expression, is it a categorical data? Is it a category or is it numerical?
It's numerical, sir.
Numerical. Then in that case, based on numerical, your expected difference, you are going to do based on the two independent mean kind of thing, which got the concept, two independent means, then you can calculate based on the two means formula, right? In some genetic area, they have some modified formula and a modified name for that you can follow. For example, two independent independent t-test, maybe they may cause some name in the genetic statistics, right? So you have to follow it. Some modified formula also there is, right? Otherwise, what you call the concept is the same, right? So to answer a question, you need to calculate sample size based on the two independent mean, right? And what is the expected difference? What is the standard deviation? Based on that, you will get it, right?
Okay, sir. Thank you.
Okay. Okay, so here the questions are here. Question number 1: a local health department wishes to estimate the prevalence of obesity among primary school children in locality. It has been estimated that prevalence of obesity among primary school children is 15% from previous publications. How many children should be included in the sample so that the prevalence will be estimated within 5% points of true prevalence, true value with 95% CI? What is the solution? Can I ask? Can I ask? Is it, what is the research question? Research question is, you can answer prevalence, right? To determine the prevalence. What is the study design? Study design?
Cross-sectional, Prof.
Very good. Cross-sectional. Mean or proportion?
Proportion, Prof.
Proportion. How many proportion?
1 proportion, Prof.
One proportion. So
Yes, single proportion.
Single proportion formula. Very good. Do you want me to calculate straight away, or because of time, do you want to calculate by yourself and get the answer in the evening if you have time? How? I think you better calculate by yourself, right? So write down what is the prevalence. Prevalence is 15%. What is your what do you call the
Precision.
Precision? How much?
5%.
Very good, 5%. Then calculate by using software. So you calculate it. Maybe evening we can check the result. Is it okay?
Okay, Prof. Can.
Yeah, I think we should do two-way teaching kind of thing. If I give you answer straight away, you may not be excited, so you calculate by yourself. Is it okay?
Okay, sure. Sure, Prof.
Okay. Number 2, researcher would like to estimate the prevalence of regular exercise among secondary school children in a state with 10 districts. Each district is considered as the first stage cluster, which has 5 schools. By applying cluster sampling method, researchers selected 3 districts and again selected 3 schools in each district. That actually is the basic of cluster sampling, right? Cluster sampling is the first stage cluster, second stage cluster. From the first stage cluster, 5 schools, and go down to second stage, it has 3 districts, and there are 3 schools in each district. So it means that nine schools. So to be able to say as it's the cluster sampling, first stage, from the first stage, go down to second stage. Inside second stage school, all children, remember here highlighted, all children in those 3 schools were recruited to the study. That is called cluster sampling, right? So you need to read some more about cluster sampling. Cluster sampling is the first stage cluster, second stage cluster. Inside second stage cluster, for those who are eligible, tick all. That is the cluster sampling. If you do sampling again inside those second stage cluster, is no more cluster sampling. That is called multi-stage sampling. So difference between multi-stage and cluster sampling is that in cluster sampling, inside second stage cluster, tick all. In multi-stage sampling, inside second stage, go down again sampling. That is called multi-stage. So this question is cluster sampling. Calculate the number of children per school that should be included in the sample so that the prevalence may be estimated to within 1 percentage points of the true value with 95% confidence. What is your precision? Your precision? How many percent? Your precision?
1%.
1%. Very good. Previous publication had reported that prevalence of regular exercise among secondary school children was 5%. That is what?
Prevalence.
Prevalence. So what is the difference between question 1 and question 2? Question 1 is, I give you a hint. Question 1 is classical cross-sectional study, right? You calculate just by formula. Second question?
Cluster.
Yes. So cluster, how are you going to calculate?
Using AP. AP info.
You can calculate.
Yeah.
You have to apply what? Apply?
Design effect.
Yes. How do you apply?
Putting the number of the cluster inside
Number
it, and also the design effect times 2.
How many? Multiply by 2. How many clusters here?
9 cluster.
9 clusters. Is it right? Those who So the 3 schools, I can select the 3 schools in the East District. Yes. So in the three districts with 9 clusters. So you need to calculate the difference between question 1 and question 2. Is question 1 a classical one? No need design effect, cross-sectional study. Which called the just using the 5%, what you call the 5% precision and what you call the prevalence of 15%. Is it right? Here is prevalence is 5%, right? And your precision 1%. Clusters are 10. You need to apply cluster sampling. That is multiplied by 2. So let's see whether you can do it or not. That is a cluster, right? So cluster sampling. So this is a design effect apply. So these two are different, no? Both you can use by APinfo, right? Okay, no need to get it by hand or by software. Number 3, in a study to determine whether an administered drug can reduce the average blood pressure, investigator wants to calculate the sample size required so that he would have a 90% chance of detecting a 5 mm mercury reduction using a 2-tail test at the 5% level of significance. It is known that the standard deviation of blood pressure in the study population is 10 mm mercury. What is the surprise sample size? Number 1, what is the research question? What is the research question? Is there any significant difference of blood pressure between
2 drugs?
2 drugs. Study design, interventional or observational? Come on.
Interventional.
Interventional. Most probably?
RCT.
RCT, correct. RCT. Mean or proportion?
Mean 5 mm
How many
HD
How many
reduction.
means? How many means?
5.
How many means?
Oh, 2 means.
2 means. Right? They are independent or dependent sample?
Independent.
Independent. Very good. So what independent sample? So you are going to apply what formula? Come on. I know you are hungry, but how many? What formula?
Independent. Two mean sampling proportion.
Yes, 2 independent means, correct. So in 2 independent means, what are the features? Sigma and detectable difference. Where is the sigma? Standard deviation? How much?
10 mm.
10, yes. What is the detectable difference? Delta?
5.
5. What is your effect size?
19.
Effect size?
5.
5 divided by?
5 divided by 10.
Yes. Effect size how much?
0.5.
Very good. 0.5 is a median effect size. Go ahead, no problem. So 2 means formula, you have to calculate this one. So you please write down. This is a 2 means formula, right? 2 means formula. So I want to see all of your answers, right? So first one is prevalence, classical you calculate. This is by what you call the cluster effect. This is 2 means, right, per group. Question number 4. Question number 4 is, in a study conducted by so-and-so, 2 drugs for the treatment of peptic ulcer were compared. Percentages of ulcer healed by the drug pyrazipine was 75% and 60% of ulcer were healed by trithiazine. 2 drugs, definitely this is, what's the design? What's the design?
RCT.
RCT. How many subjects would be required for a randomized control trial to have a 90% chance of detecting this difference? That is 75% versus 60%. It means a 90% chance of detecting this is, what does it mean? What does it mean? This is a 90% power, right? 90% power, yes, power. And 0.05, what is that? 0.05. Alpha, very good. Alpha is 0.05, power is 90%, right? You got everything there already. And 2 proportions. 2 proportions are, what are they? P0 and P1. Right? So here is actually, they don't mention anything. So P0, P1 is okay. Anyone is okay because they don't mention any what you call the particular drug, what you call, which is under interest. Both are under interest. So what formula? 2 proportion formula. In your PS software, what command you are going to use? What selection you are going to use? Dichotomous, very good. Dichotomous. Then you can use it. You calculate sample size, but for that. Number 4. Okay, you can, right? Let me see answer in the evening. This question is very good actually. Question number 5. Researcher would like to determine a sample size for a prospective course study with coronary artery disease, heart disease, CHD as an outcome. Information from literature and expert opinion were as follows. Remember, when you really do the study, you are not doing only one variable. You have many, right? So this study is a prospective course study. Outcome is heart disease, coronary heart disease. So it has a smoking, dietary habit, family history, exercise, gender, now sample size determined. So this is the one that I am testing you whether you understand or not. You have to calculate sample size for each and every variable based on the information given and take the largest one. Okay, let's see here. Smoking. Prevalence of coronary heart disease among general population is 20%. Smokers are expected to develop coronary heart disease with a detectable difference of 15%. Can I ask you, this is what formula you should use? Mean or proportion?
Proportion.
Very good. Which proportion, which is P0, which is P1? General population is
P0.
Yes, very good. P0. What is your P1? How much?
15.
15 is different. So P1 is?
Expert opinion.
5%.
How much?
5%.
Are you sure 5%? 15%.
15%.
Right? General population P0. Should be?
1.5, right? The P1.
1.5 is different. So for those smokers, it should be 35. Very good. 35. Because P0 is 20. P1 is the one that you are interested in, smokers, right? General population means those who are non-smokers. P1, a difference between 2 is 20 plus 15 means 35. Very good. Okay, P0, 20, P1, 35. What formula are you going to use? Two
proportion, Prof.
2 proportions. Then you got the sample size, right, for this smoking. Dietary habit. For those who are with diet control, is reported to develop coronary heart disease by 12%. For those without diet control, are expected to have coronary heart disease with a detectable difference of 15% again. So in that case, again, 2 proportion. Which one is P0? Which is P1?
12% is the P0.
Sorry?
12% is the P0.
12% is the P0. Why do you say so? Because those with diet control.
Yeah, reported.
Yes. For those who are without diet control is?
27. 27. 27.
27. Yes, that is P1. Again, 2 proportion. Which command you are going to use in PS software? Which option?
Dichotomous, Prof.
Dichotomous. Family history. For those with family history are expected to have 15% of heart disease, whereas those without family history are 5%. Then which is P0? Which is P0?
5%, Prof.
5% is those without family history. P0 is 5. This is straight we mentioned. Those with family history are 15% in P1. Okay, this is clear cut. Exercise. Prevalence of coronary heart disease among general population 10%, whereas for those without exercise, it's expected to have coronary heart disease with a detectable difference of 15%. Which is P0? Which is P1? P0
is the P0.
10% P0. P1 how much?
25.
25. Very good. Gender. All are dichotomous. All are categorical. The males are 2 times more likely to have. Oh, I forgot to mention about the what you call the risk. I missed one. Yeah, 2 times more likely to have the coronary heart disease than females. Incidence of heart disease among 10%. So I missed one. Actually, in your our calculation here, 10%. Okay, I can tell you very easily. When you put the P1 and P2, you put the 2 proportion. Am I right? Right, 2 proportion. Instead of 2 proportion, you go and click risk. If you appear risk, you put the value 2. That is called what you call the that is sample size, right? That is sometimes you will get it. So never mind, because of time, I will explain it in the afternoon, right? So your risk assessment here is 2, right? So instead of 2 proportions, you can calculate by 1 proportion with risk. If it is prospective cohort study, risk is relative risk. If it is case control, risk is odds ratio, right? So it's a matter of going and click it. Instead of 2 proportion, when you click it, you get what you call down there is risk. So if you were to click risk, if it is prospective cohort, relative risk. If it is odds ratio, what you call it, if it is case control, odds ratio. So there you will see it. It's a risk is you put as 2, right? So afternoon I will explain you. So I give you result, right? Smoking is 138, dietary habit is 108, family history is 140, exercise is 100, gender is 199, right? So among them, right, so among them, the biggest is gender, right? Biggest is gender. So gender is, oh, gender is with the risk. Okay, I need to explain this one, right? So gender is 199, so you have to add the 20%. So 199 divided by 0.8249. So the sample size is multiplied by 2 groups, right? So the sample size is nearly 500. So can you do this, right? Can you do this? Except gender, if you cannot do, never mind. I will explain you in the afternoon, right? Okay, this is case control, right? Case control study is planned to investigate whether those with family history are at increased risk of having retinoblastoma compared to those without family of retinoblastoma. It was reported that about 15% of those without retinoblastoma had the family history. It has been estimated that those with family history would increase risk of having retinoblastoma 3 times. Oh, this one again is a risk. So I have to explain you this one, risk, right? So here is calculation by risk, right? Risk assessment. I forgot this to what you call explain it. So this is by risk. So this question, gender, and this one afternoon, sometime I will explain. So this one is sample size can you calculate based on the odds ratio, right? So this is the what you call, this is the case control study, right? Okay. So using 1 proportion with risk. The last one, researchers would like to conduct a cross-sectional study to identify the associated factors of vaping among male adolescents. Among all potential associated factors, peer influence among adolescents, non-vapers was reported as 50% by the previous study and 10% increase in expected among adolescent vapers, right? How many adolescents was the sample? And power study 80% with the significant level 5%. So can I ask you, which one is P0, which is P1? From literature is P1, sorry, P0, right? Which one from literature?
15%.
15%. And increase 10% increase expected among adolescent vapers means? Mean P1 is how much?
25.
25. Yes. P0 15, P1 25, right? I think only that. So 7 questions. So you can do all except this risk one I need to show you. So gender, that one, using gender here with the risk, and then this question, case control. I forgot to demonstrate for risk. That's very easy actually. Just change the option only, right? What time is it now? 1:42.
Welcome back to all participants of sample size workshop. So come to our afternoon event with our second speaker, Dr. Adam Mujang. Let me introduce a bit who is Dr. Adam Mujang. Basically, he's a well-known statistician, a research officer from CRU Hospital Sarawak, and has collaborated a lot with medical researcher in all over the Malaysia. And he has published almost 100 papers with a high citation. So without further ado, Dr. Ajam, I pass the mic to you.
Okay. Bismillahirrahmanirrahim. Assalamualaikum dan salam sejahtera everyone. First of all, I would like to take this opportunity to thank the organizer for inviting me, and it is an honor for me to present the lecture together with one of my earliest guru in sample size determination, which is Prof. Syed Hatim. Okay, can you all see my slide?
Yes, can.
Okay, good. Okay, sample size calculation or sample size determination is a huge topic. By right, participants should equip with some knowledge, such as statistical inference, study about distributions, statistical tests. Okay. However, it is not possible to study sample size only for 1 day based on expectations. So my expectation in this workshop is I would like participants to know the concept of sample size calculation as an estimation. And secondly, to know how to determine sample size for common statistical tests such as correlations, Coombs alpha, multiple linear regression, and also logistic regression. Okay. This is my scope of presentation. First of all, I would like to discuss about the approach in statistical analysis. I will touch about the definition, the difference between descriptive and inferential analysis. Next, I will teach how to calculate or estimate sample size for Pearson correlation tests and also Coombs alpha. And although Prof. Syed already touched about type 1 error, type 2 error, and power, I would like to emphasize it again. And then for next module, we will learn how to estimate sample size for multivariate analysis and some tips for determination of sample size. Okay, why we need to calculate or estimate sample size? We can have many answers, such as this is one of the requirements for protocol submission. And also the other reason, perhaps we want to plan for budget. In some studies, each recruitment will cost some amount. So when we know how many subjects to be recruited, so easy for us to plan for the budget. Perhaps next is to know when to start and when to stop the recruitment. When we know our sample size, the minimum requirement of sample size, and we know our capacity, how many manpower that with us to collect the data, how many centers participate in the study. So roughly we will know when to start and when to stop the recruitment. The other important reason, perhaps to get significant results. To get significant results, meaning we want to have sufficient evidence to show to the audience whereby our results can reach p-value with less than 0.05. These are the common reasons why we need to estimate or calculate sample size. Okay, look at this figure. Can you see my cursor? Okay. When we conduct analysis, imagine that we are about to conduct the analysis for our study and we have data with us. Before we conduct the analysis, the most important thing is to understand the study objective. We need to understand the study objective. From this study objective, the researcher or the statistician will be able to identify what is the appropriate statistical analysis to be applied to answer the study objective. So I repeat, we need to understand the study objective. From here, researcher or statistician will know the appropriate or the valid statistical analysis to be applied to answer the study objectives. Okay, before that, we need to also understand, are we dealing with population data or we are dealing with sample data? Are we dealing with population data or we are dealing with sample data. So although it is rare, quite rare, we analyze population data, but it is not impossible because population data is not necessarily mean large data set. It depends on the definition of the population. So if we have the population data, for example, we want to conduct a study to measure quality of life among healthcare workers in Sarawak General Hospital. And we know that the population number is around 5,000. So we recruit each and every individual into the study. So in this case, we have population data, only 5,000 units or 5,000 subjects. So when we have population data, the approach of analysis that we need to apply is just only descriptive analysis. I will explain after this what is meant by descriptive analysis. In the other hand, this is the most common situation where we are dealing with sample data. There are many reasons why we can't afford to collect population data: manpower, time, cost, and many other factors. So most of the time, we are dealing with sample data. When we know that we are dealing with sample data, so it is not sufficient just do descriptive analysis. Besides descriptive analysis, we need also to do inferential analysis. So I hope this is clear. So what is descriptive analysis? A quantitative processes that involve describing the data to show pattern, magnitude, trend, and association of the variables. In other words, when we have data set, we can play with the data. Up to us, depend on the study objective, whether we need to present percentage, mean, we need to do comparison, we need to do association, or we need to do correlation, just merely descriptive. This is when we have population data. However, when we are dealing with sample data, just by describing the statistics, people might argue to what extent your statistics derived from the sample data can be generalized or can be inferred to the targeted populations. This is the argument. To what extent your results can be inferred to the targeted population. Because the audience know you not analyze the population data. You only analyze subset of the populations. So hold on, I want to adjust this. Okay. So therefore, inferential analysis is a way of making inferences about populations based on samples. It involves various of statistical tests to analyze sample data and make a conclusion about the population based on concept of probability. The statistical test will produce an evidence such as p-value. And it is used as an indicator to justify the statistics or our results that are derived from sample can be inferred to the parameter or the true values of the targeted populations. So basically this is the difference between descriptive analysis and inferential analysis. Okay, let's see this figure. Okay, imagine this is, we have population data. This is a population. And we want to measure some parameters such as percentage or mean comparison by gender or descriptive statistics for income. We call this as a parameter because these variables derive from the populations. So when we derive this parameter from the population, it is a true picture, true value that represent the populations. Okay, one researcher want to conduct a study. He want to measure all the same parameters, but instead of recruiting all the subject, he decided to conduct sample study using sample. So he collect sample based on some sufficient sample size, and then from this data set, he do similar analysis to get the percentage of adults, mean age by gender, mean monthly income, and so forth. So all this we name it as statistics. We call it as statistics because it derived from the sample data. When we produce these statistics based on sample data, people will argue to what extent your results can be generalized, can be inferred to the targeted population. Therefore, it is not sufficient to just presenting the descriptive analysis. In addition, you need also to do inferential analysis. You need to do extra work. You need to apply some statistical tests and provide another evidence, additional evidence to justify your statistics can be inferred to the targeted populations. Okay. How good statistics derived from a sample can be inferred to the targeted population? So there are two factors drive the accuracy of the statistics. So number one is sampling technique. Basically, we want to apply a fair sampling technique to eliminate bias in selection. When I mention sampling technique, it is not necessarily a mass probability sampling. Sometimes to apply probability sampling is not possible, especially in clinical setting. We can apply non-probability sampling, but the most important thing is we need to ensure there is no bias in the selection. So most common scenario in clinical survey, investigator will apply convenience sampling, or to be accurate or to be specific, consecutive sampling. They put some strict inclusion and exclusion criteria, and then they intend to recruit all the subjects that fulfill the inclusion and exclusion criteria based on two time periods. Okay, next, besides sampling technique, is sample size. So these two factors is the main factors that drive the accuracy of the statistics. So therefore, researcher need to calculate or estimate sample size because they study or analyze sample data instead of population data, and they want to get significant results to justify for inference. Basically, this is my introduction about sample size, and I think we have another figure to show. Okay. Imagine that we have a study and we have objective of study. We need to understand the objective of the study. In the morning session, Prof. Said already mentioned about study design. Okay, one of the important elements that we need to understand to justify that we know what type of statistical analysis that can be applied. So besides study design, perhaps we need to also understand the type of measurement, type of variables that we are dealing with. So anyway, when we want to answer the study objective, researcher or statistician need to know what type of statistical tests need to be applied to answer the study objective. Some objective just want to know the percentage or proportion. So just this simple descriptive analysis such as prevalence will answer the objective. some objectives may require you to apply univariate analysis, such as independent sample t-test, Pearson chi-square, and so forth. Some objectives may require you to do a correlation or modeling or diagnostic study. So yeah, we need to understand the objective of the study so that we can determine what type of statistical analysis that can be applied to answer the objective. So once we know the type of analysis, the type of statistical test that we will apply to answer the study objective, the formula to calculate or estimate the sample size will be derived from the formula of the statistical test itself. For instance, the objective required me to use independent sample t-test. So to calculate or estimate the sample size, I need to use formula from independent sample t-test. If the objective required me to use Pearson chi-square test, so the formula for sample size need to derive from Pearson chi-square test. So there is no single formula for all. You can imagine there are so many statistical tests available, so there are many formulas to estimate and calculate sample size. I chose this statistical test because it is easy, common, and very easy to estimate or calculate, which are called Pearson's correlation test and also Comba alpha. Before we move on, we want to discuss about what affect sample size, what contribute to sample size. Number one is alpha, or we call it as type 1 error. Number two is the power of the study. Beta is the type 2 error. And number three is effect size. So in this morning session, Prof had explained regarding these terminologies. Okay, when we do study and making conclusion for our study, researchers are bound to make errors. We call it as type 1 and type 2 errors. Okay, so we look at this figure. Imagine this is the truth based on entire population, meaning the results. And this is based on our conclusion, based on our sample data. So the audience should not memorize the location of type 1 or type 2 error because it depends on the definition in the rows and column. So in this example, this is a conclusion based on our sample. Let's say, based on our result, we don't see anything, meaning the result is not significant. We fail to reject null hypothesis. I repeat, when we conduct a study, we analyze the data. Our conclusion is we don't see anything. Our result is not significant. If the decision in line with the truth based on entire population, so this is the right decision. Based on the truth, nothing is there. There's no correlation. There's no association. So we made the right conclusion. However, if based on the truth, should be something is there. There should be a correlation. There should be an association, but failed detected by our study. So we make type 2 error. So we make wrong conclusion. So this is type 2 error. Another example, when let's say we conclude there was this significant result. You see something. you see some correlation, you see some association, with some you see some difference in mean and so forth, and based on the truth, nothing is there, so you make wrong conclusion. So this is type 1 error. So basically, when researcher making a conclusion, we are bound to make errors, type 1 and type 2 errors. So what is good about sample size calculation or sample size estimation? Scholars will fix the alpha and power of the study. They will fix alpha at 0.05. They will fix alpha beta at 20% usually, so power about 80%, and it will ease us to calculate or estimate sample size. The main concern is the effect size. So in this workshop, we are not able to discuss further about these two terminologies. At this point, I think we need to accept alpha is fixed at 0. When we calculate or estimate sample size, alpha is always fixed at 0.05 and power is at 80%. Can we adjust the figure? The answer is yes. Some scholars prefer to use alpha 0.01, power of study 90%. It is still possible. For the sake of exercise, we maintain alpha and beta 5% and 20% respectively. Okay, now what is effect size? Sorry. Okay. This is a popular scientific paper by Cohen, Power Primer, so famous for many citations. What is effect size? Measures the magnitude of differences, association, correlation, and etc., depending on the statistical test. Look at this figure, the table 1. In the first column, this represents the difference of statistical tests. The second column referring to the formula, how to calculate the effect size for different statistical tests. For example, this is independent sample t-test, and the formula is quite straightforward. We need mean in another group minus mean in the another group, and they divide by standard deviation. So this will represent effect size for independent sample t-test. The easiest effect size is correlation test, because the R, the coefficient of the correlation, is actually represent the effect size of the correlation test. So in this table, Cohen proposed some cutoff for effect size for different statistical tests in 3 categories, such as small, medium, and large. For example, in Pearson correlation test, 0.1 referring to small effect size, 0.3 referring to moderate, and 0.5 referring to large effect size. So this is proposed by Cohen. Okay. Next, in the same paper, so Cohen tabulated a table. The analysis was based on power 80%, and he tabulated with using 3 different alpha, 0.01, 0.05, and 0.1. So just focus on the 0.05, the alpha 0.05. So how to read the table? If the researcher intend to detect small effect size, which is 0.1. So the researcher require minimum sample size requirement of 783. If the researcher require to detect moderate effect size, which is 0.3, so they need about 85 subjects to get significant result. Okay, so this is proposed by Cohen in his paper. The citation, if I'm not mistaken, almost 50,000 for the past 20 years. Okay, so what we learned from this paper, if the real effect size is large, ideally there is no need large sample size to prove the large effect size exists. Okay, if we want to detect large effect size, ideally we will not require large sample size to be able to get significant results. If the sample size, if our study aim to determine small effect size, then this study will require large sample size to get significant results. So in sample size calculation or sample size estimation, researchers need to determine the effect size of a study. Okay. Say we set low effect size. You purposely set low effect size. You may need large sample size to prove the result is significant. You need to recruit more subject to get significant results. But if you set high effect size, although you are required to recruit small sample size, but you may not be able to achieve the desired effect size from the sample. For instance, in sample size determination, you assume your study can detect correlation coefficient of 0.5. So your sample size is just 28. How you set 0.5? It depends. You may get the statistic from the literatures, or this is perhaps you derive from some subject of expert opinion, or some target set by researcher. So what happened was, when you have the data, you recruit subject around 28 or 30 subjects, and you analyze the data. Unfortunately, you're not able to get coefficient of alpha 0.5. You may get 0.4, 0.3, 0.2. So in that case, if that's the case, you won't achieve p-value less than, your study won't achieve p-value less than 0.05. So this is the danger if you set large effect size for sample size calculation. So researchers will normally set the smallest effect size that they can tolerate to convince themselves and also the audience that the finding is clinically or scientifically significant. Okay. For example, say you hope you will able to prove the correlation coefficient is can reach to 0.5. You hope your study can produce correlation coefficient of 0.5. If that's the case, you only require sample size of 28. But you need to know. But the problem is we won't know the true effect size until we have the data and we analyze the data. Then the most important things to conduct the study is to be able to infer the results to the targeted populations. So instead of putting effect size of 0.5, you can set effect size as 0.3, although you may take slightly larger sample size, 85. So at least you will able to conclude your result is significant, although the correlation coefficient is within 0.3 to 0.5. Okay, so this is still the introduction. We will not touch yet about how to calculate sample size for correlation. This is just for introduction. Okay, now we go to the next module. How to estimate, calculate sample size for correlation test. Okay, so there are a lot of statistical tests available. Before we learn how to calculate sample size, we need to be familiar with the statistical test. So I remember when I attended one of Prof. Said workshop, Prof will teach about the study designs and statistical tests the first 2 days. Then the last day, he will touch on sample size estimation or sample size calculations. The reason is because when we want to estimate or calculate sample size, we need to be familiar with statistical tests that we dealing with. Okay. So I assume this test is common for everyone, but just for some recap, the test is a measure of the correlation and strength between two variables, and this variable in numerical form. We want to measure a correlation or strength of correlation between two variables, and this two variable is in numerical form. There are other assumptions, but I did not plan to put here. For instance, about parametric assumptions. Okay, so beside the variable should be in numerical form. So the data also need to comply with parametric assumption. We can keep that aside first. So we need to understand the test. So this is when we plot the data, we can have high correlation such as R with 0.98, and we can also have negative correlation such as this figure, negative 0.94, and also we also can have this result where we didn't see anything pattern. Okay. Okay. When we conduct the analysis, imagine that we have the data set and we want to conduct analysis for Pearson's correlation test. There are two approaches. This approach stated in the textbook. When this approach stated in the textbook, step 1, we need to state the null and alternative hypothesis. Second, we need to select an appropriate inferential statistical test. Step 3, we need to select level of significance, and so forth. This is the approaches taught to us during our undergraduate, how to conduct inferential analysis. But practically, when we conduct analysis for all our study, we didn't follow this approach. Normally, when we have the data, we need to understand the study objective, number 1. From the study objective, the statistician need to be able to inform what type of statistical test can be applied to answer the study objective. Okay, so sometimes like myself, I don't have medical background. So for me to understand the study objective, I need to interview. I need to ask a lot of questions to my research client until I understand the study objective. So after we know the statistical test to be used, then we conduct the analysis, we interpret and make a conclusion. So this is the common approach when we apply inferential analysis. I give a scenario here. This is a common scenario. Okay. This study aims to determine the correlation between age and knowledge score. This study aims to determine the correlation between age and knowledge score. So step one, we need to understand the objective of study. Since both are in numerical form and parametric test is assumed, thus a Pearson's correlation test was conducted. So this is referring to step 2 and step 3. Then results show the result was statistically significant with p-value 0.013 with correlation coefficient of 0.3. And this is step 4. And therefore we make the conclusions. This is a common scenario. Let's convert this statement into scenario of sample size. This study aims to determine the correlation between age and knowledge score. Both variables are observed in numerical form. What is the appropriate sample size of this study to determine a low or moderate correlation between these two variables? So this is the scenario. A researcher wants to conduct a study to determine the correlation between age and knowledge score. Both variables are reported in numerical form. Okay, then the query is how many sample size for this purpose, for this study. Okay, I have mentioned before this, for alpha, we fix at 0.05 and power, let's fix it at 80%. Now the problem is the effect size. For the sake of example, say we estimate the minimum value of correlation coefficient is 0.3. Say we estimate the minimum value of correlation coefficient is 0.3. So in sample size calculation or in sample size determinations, how we can determine the effect size? So it depends. In most cases, it derives from literatures. If the study, but we need to look at the study objective. Is it similar with the benchmark paper? Is it the population characteristic almost the same? The study designed. So if we have the benchmark paper, yeah, we can quote the effect size from that paper. If not, the other way is to the subject matter to give some expert opinion, or it also can be some target that we want to achieve. We want to achieve some target. So it depends. It can be from the literature, subject matter expert opinion, or some target that we set. Okay. Say we estimate the minimum value of correlation coefficient is 0.3. Okay, so what I will do, I will calculate the sample size using PASS software. So in this workshop, it is not a requirement for you to calculate the sample size with me. Okay, so it is also not the purpose to teach you how to use PASS software. PASS software is a commercial software. One single license maybe around 4,000 to 5,000 ringgit Malaysia. Okay, so I need to put these two values in the software. Okay, So sorry, perhaps the figure is so small. Okay, this is power 0.8. This is alpha, type 1 error 0.05. So this is fixed, although we can modify these two values. So what we need to put is the PO and P1. What is the PO? PO is the value of the population correlation under the null hypothesis. P1 is the value of the population correlation under the alternative hypothesis. Meaning to say, when we conduct study, we assume that there is no correlation for these two variables. So it is fair to assume before we conduct study, we assume that there is no correlation for these two variables. And when we conduct the study, and when we have the data, we hope that we can reach the effect size of 0.3. So this is the target. So using that software, the sample size is 84. Okay, relax. We can put various figure. Besides 0.3, we can also put 0.5 and 0.7. Stated here in past software, the output, the sample size for if P1 0.3, the sample size is 84. If P1 is 0.5, sample size is 29. If P1 is 0.7, the sample size is 13. So I tabulated the sample size table for audience. PO is the value of the population correlation. Sorry. PO is the value of the population correlation under the null hypothesis, meaning we assume that before we conduct the study, we assume that there is no correlation. So in the alternative hypothesis, we need to set a target at which effect size we want to achieve. 0.1, 0.2, 0.3. If you want to detect low effect size, you need sample size of 84. If you want to detect high effect size of 0.7, you only require to recruit minimum 13 or 13 subjects. Okay. So I have tabulated the table and I published a paper for this purpose. It has citation 137 published since 2016. So the most important thing is to write the sample size statement because we need to put this in the proposal or protocol. This is the example. This study aims to determine the magnitude of correlation between age and knowledge score. So my practice, when to draft a sample size statement, I will advise or encourage participants to put the objective in the first statement to remind us what is the objective of the study, and this will relate the formula that we will use to estimate or calculate sample size. So this study aims to determine the magnitude of correlation between age and knowledge score. The basis of sample size calculation will use formula based on Pearson's correlation test. So based on the first statement, I will know which formula to be used to estimate or calculate sample size. And then the minimum correlation coefficient to be detected in the study is at least 0.3. So we need to inform the reviewer or inform the audience the effect size that we intend to achieve, with assumption that the magnitude of correlation in the null hypothesis and alternative hypothesis are equal to 0 and at least 0.3 respectively, hence the minimum required sample size. We need to mention the minimum. This is also emphasized by Prof this morning. Hence the minimum required sample size is 84 based on alpha 0.05 and minimum power of 80%. So by adding 20% of dropout, the study need to recruit about 105 participants. Or we get 105. Let's say the dropout is 20%. So 84 divided by 0.8. If you estimate the dropout is 10%, so 84 divided by 0.9. This is the right formula how to calculate the sample size plus the dropout rate. Okay. So based on this table, based on this table, and based on this sample size statement, I hope this will help you to estimate or calculate your sample size for correlation test. So when to use this? If your study required you to use Pearson correlation test to answer your study objective. So if your objective require other statistical tests, for instance, Pearson chi-square, so you need to use formula showed by Prof this morning. So if your study require you to use Pearson's correlation test, then you can use this table and this sample size statements. Okay, so you can read this paper. So I put some different scenario. That's all for Pearson's correlation test. So no need to calculate because I already have to calculate it for you. Next is Cronbach alpha. Cronbach alpha. So I hope this test also common for everyone. Aim is to determine the strength or magnitude of internal consistency or stability of domain or latent variable measured by a group of variables. Latent variable measured by a group of variables. Commonly used to measure internal consistency of domains for questionnaire development and questionnaire validation studies. So the statistics or coefficient of Cronbach alpha can range between 0 to 1. Okay. For example, say variable A or question A, question B, and question C have high internal consistency. So it means that question A, B, and C are measuring the same thing and consistent with each other. But question A, B, and C are not necessarily a valid measure for certain things. So to measure validity, we need different statistical tests. For example, exploratory factor analysis, structural equation modeling, rush analysis, and so forth. But to measure the internal consistency alone, this is Cronbach alpha. Okay. Okay. I think everyone familiar with DAS questionnaire. It's quite famous. Depression, anxiety, and stress scale. The revised question have 21 items, 7 for each domain. So this is what we call as a domain, psychological symptom, measured by 21 items. In this questionnaire, in terms of conceptual framework, psychological symptom can be measured in 3 different elements: depressions, anxiety, and stress. So these are the items for DAS questionnaire. For example, for depression, item 3, 5, 10, 13, 16, 17, and 21, and so forth. Okay. So these are the items will measure depression. These are the items will measure anxiety. What I want to show is what is meant by domain actually. What is meant by domain? This all. Okay. This parameter, depression, cannot be measured directly. We can't measure depression directly. There is no machine or tools or the device can measure depression, but instead require other measures to explain the parameter. So this is what we mean by latent variables. So when you conduct questionnaire development studies or questionnaire validation study, very likely you need to report Cronbach alpha. Another example. My team have developed job satisfaction questionnaire for healthcare worker, published in MJMS in year 2020. So we developed a framework which has I can't remember, maybe 7 to 8 domains. So one of the domains is teamwork. Okay, so these are the items that are measuring teamwork. These are the items measuring leadership. So TW1, TW2, TW3, TW4, and TW5 report excellent internal consistency with Cronbach alpha coefficient of 0.924. This is the Cronbach alpha. This group of items is suitable to represent a domain. In this case, is teamwork. So this is only the measure of internal consistency. For those who are familiar with questionnaire development study or questionnaire validation study, you will notice that this is a result from exploratory factor analysis, where the scholar will construct, the software will construct the item into few domains. Okay, so this is one of the example of the successful results. Okay. I provide some guideline for Cronbach alpha. Cronbach alpha more than 0.5 is relatively acceptable. For questionnaire development studies, I suggest we aim for more than 0.7. For questionnaire validation study, it's okay to report Cronbach alpha more than 0.5. If you found that Cronbach alpha less than 0.05, domains may need further revision. Okay, so if domain does not exist when Cronbach alpha less than 0.1. This is some just rough guideline for you. Okay, similar to correlation test, I put a scenario. This study aims to determine the internal consistency of 4 main domains of questionnaire Z. So questionnaire Z has 4 main domains. So the objective is to determine the internal consistency or to report the Cronbach alpha for each domain. All domains have 5 items each, and thus a Cronbach alpha test was conducted. Results show that all the 4 domains report Cronbach alpha more than 0.5. Therefore, the internal consistency of questionnaire Z domains are acceptable. So this is only in terms of internal consistency. For validity purpose, you need to apply different statistical tests. Okay. We need to estimate or calculate sample size, right? Okay. So to calculate sample size, we can use manual calculation, just merely based on pen, paper, and the formula, maybe by the help of calculator. Or you can use sample size software. So in this case, I use sample size software, PASS software. So I fix the alpha 0.05, power 80%. So these are the information that we need to calculate the sample size, the coefficient of Cronbach alpha in the null hypothesis, and also in the alternative hypothesis, and also the number of items. Okay, let's see the scenario. Let's put into the scenario to estimate or calculate sample size. This study aims to determine the internal consistency of questionnaire Z domains. There are 4 main domains and each domain has 5 items. It was noted that the acceptable Cronbach alpha is more than 0.5. What is the appropriate sample size of this study to determine acceptable internal consistency? Okay, so we know we already fixed the type 1 and type 2 error. We already know what are the information required by the software. So I just plug in the figure into the software. So again, I would like to emphasize this is not the workshop to calculate sample size using past software. So no need to hands-on. So I just do the calculation for you and tabulate the table for you later on. Okay, say we put power here 0.8, alpha 0.5. There are 5 items. We assume there is no internal consistency in the first place, and we target the combat alpha minimum to reach 0.5. So the sample size is 41. So I tabulate the table for you. So we assume that there is no internal consistency at the first place before we conduct the study. After we have the data, we assume the combat alpha can reach to 0.3, 0.4, or 0.5. So this is the required sample size. For 0.5, you need sample size of minimum 41. If you want to achieve 0.7, you need minimum 14 subjects. Okay, sample size was calculated based on formula by Bonnet and Douglas, 2002. So past software used the formula by Bonnet, 2002. So I also published a paper for this. You can read the paper published in MGMS 2018, citation 159 since 2018. So this is the purpose I write this paper to help researchers all over the world. So hopefully they can estimate or calculate sample size after they read this paper. So it saves my time. So then no need require statistician to help them maybe. So if you have time, you can read this paper. So the most important thing is to write the sample size statement. This study aims to determine the internal consistency of domains for question Z, which has 4 questions in each domain. So we need to remind what's the objective of the study. Why? Because we need to know the correct or the right statistical test to be used to answer the study objective. The basis of sample size calculation will use formula based on combat alpha test. So we set the sum effect size. The minimum combat alpha coefficient to be detected in the 4 domain is at least 0.5. There are many papers that you can cite. The ideal cutoff. Some say 0.3, some says 0.4, 0.5. So there are many citations. You don't need to worry. With assumption that the Cronbach's alpha coefficient in the null hypothesis and alternative hypothesis are equal to 0 and at least 0.5 respectively. Hence, the minimum required sample size is 41 based on alpha 0.05 and minimum power of 80%. By adding a 30% dropout, the study needs to recruit minimum of 52 participants. Okay. I hope this is easy for everyone. No need to calculate, no need to use formula. I already provided the table for you, an example of sample size statement. If you need further understanding, you can read the paper that I mentioned earlier. Okay, so I chose these 2 tests because it's easy and common. Easy to explain and it's common. It's so common for everyone. Okay. What time is now? Okay, 3:30. Is there any questions? Is there any questions?
There's a question from Omar Ahmad. Where she's asking, how can we know what kind of statistical test to run when we did not run the normality test?
Pardon me, how we going to know the right statistical test?
Yeah, without running the normality test.
Okay, I hope I understand the answer correctly. how should we know the statistical test to be used?
Yes. Without run the normality test.
Without
Doing the normality test.
Oh, how to answer this question? Okay. Okay. Let me try to understand the question first. Okay. Okay. For example, say you want to compare mean difference. For this morning session, you want to compare mean in two groups. So by right, you need to apply independent sample t-test, right? You want to compare mean in two different groups. So independent sample t-test is a parametric test. It's a parametric test. And for parametric test, there are certain assumptions that we need to comply. For example, the normality assumption should be assumed. Okay, so then it will determine whether we can apply independent sample t-test or man-width U test, right? Okay, but for sample size calculation, as far as I'm concerned, and I know, it's quite difficult to estimate sample size based on man-width U test. It's quite difficult. Maybe some scholars have proposed some formula to calculate sample size for non-parametric. Maybe there's the paper discuss about that. But to ease ourselves, it is better to assume that the data is normal, and parametric test can be assumed. We can assume the data is normal, and parametric test will be applied. So I think it's no harm to assume that parametric test is assumed. No harm. So therefore, we can estimate the sample size using independent sample t-test. I think it is fair because we don't have the data yet. So it's okay to assume the data is normal. Similarly to correlation. When we conduct correlation, we know that besides Pearson correlation test, we can use Spearman's correlation test. The difference is Pearson is in parametric test, and Spearman's is non-parametric test. So when we estimate sample size, this is okay and fair to assume data is normal, or the parametric test is assumed, so we can estimate the sample size using Pearson's correlation test. So okay, so this is fair because we don't have the data yet, we just assume. Okay, so I think that's perhaps answered the question. To know the statistical test to be applied, this is another challenge. What I can suggest is, number one, you need to get a benchmark paper, study that about similar to your study, and then say the objective is the same, to measure the association or to measure the correlation. Say the objective is the same, so you can read in the method section what types of statistical tests the author have applied to answer the study objective. You can see how the author tabulate the table or tabulate the figure. This will help you to determine what type of statistical test can be used to answer the study objective. If not, you can liaise with your friends, your colleagues, your supervisor or statistician, and perhaps sure they can help you to determine the right statistical test to be applied. For myself, this is I run a clinic almost every day, consultation clinic about research. So I don't have a medical background, so I admit I have problem to understand the study objective because I'm not aware about the real scenario about their study. So I will ask question, I will interview them, I will ask the benchmark paper, then I will be able to help them to decide the right analysis to be applied. I hope that answers your questions. Any other questions?
Sorry, Prof, I have a question.
Yes.
Thank you for this informative session, actually. But I want to ask you about the 20%. After we determine the minimum sample size, for example, in this slide 41, why we have to add 20% of dropout? And what do you mean with dropout?
Okay. Why we need to add some dropout, right?
Mm-hmm.
Okay, good questions. So,
sorry, Prof, I have another question. After you answer, I have another question.
Okay, you have another question after this. Okay, I answer this first.
Sorry,
can I answer this question first?
Yes, thank you very much.
Okay. So, say based on some effect size, we fix the type 1 error 5%, power 80%. We know that we need to recruit minimum 41 subject or 41 participants. Okay, 41 is a minimum number. Say when we fix at 41, recruit 41 subject and we stop the recruitment, anything can happen. For instance, you lose your survey questionnaire, or when you check the questionnaire, they are empty, there are many missing value maybe, or this subject don't fulfill your inclusion and exclusion criteria maybe. There are so many reasons for the dropout cases. So to maintain, we have at least minimum number, we need to add some dropout. 10%, 20%, it depends on the situation. For example, an online survey, the response rate is very poor, sometimes up until 50% or 40%. So if you know that you need to recruit minimum 200 subjects, you may need to consider to increase your sample size to 450 or 500, so that you get minimum number. At least you will confident you will get minimum 300 at the end. So that's the reason why we need to add some dropout for this purpose.
So, Prof, is this applicable only for the studies based on the questionnaire, or also applicable in the experimental studies?
So it depends. In the experimental, it's also applicable. For example, you take blood sample or urine sample, and suddenly, I don't know, perhaps due some reason, it will fall down and broke, or the sample contaminated maybe. So there are so many reasons. So to be safe, good practice to add some dropout rate.
Okay, thank you very much for the answer. Actually, my second question about the level of confidence. I have noticed that you have set the level of confidence into 95. So what is the effect of the level of confidence on the overall outcome of the study? For example, let me assume if I consider the level of confidence as 90 or 85, is there any harm on the overall outcome of my study?
Okay, meaning can we use a different confidence level beside 95%? Okay, ideally you can do that. You can use 85% or 90%, but the general standard.
Sorry for interruption, Prof. Actually, I'm asking this question because in some type of studies, the cost is a major concern. So that the researcher decided to minimize the sample size by adjusting the level of confidence or the power.
Yeah, I understand.
That's why I understand. Is it possible to change the level of confidence to the minimum level? And what is the minimum acceptable level? Thank you very much.
Okay. It is possible, but the problem is you might not able to convince your audience that your result is strong or significant, because the standard consensus to accept alpha less than 0.05 or 95% CI or more than 95% CI. So the answer is possible, but the problem is to convince the audience that your result is sufficiently significant, because the general consensus among scholars only accept P less than 0.05. That's perhaps the issue.
Thank you, Prof. Thank you very much.
Okay, I think I will move on. Okay, sample size for multivariate analysis. Okay. Can you see my finger? Okay, so this is this is outcome variable. Outcome variable in numerical form. Okay, so this is another variable, independent variable. So when we do association, this is univariate analysis, one-to-one analysis. One variable as outcome and another variable as predictor or risk factor or independent variable. Okay, so we call it as one-to-one analysis or univariate analysis. Independent sample t-test, Pearson chi-square, correlation test are all univariate analysis. In some cases, we might be interested to study multiple factors that associate with the one outcome. It can be numerical, it can be categorical. So this is multivariate analysis. So normally we will apply logistic regression, multiple regression, Cox regression for this purpose. For example, to determine to what extent the socio-demographic profile. Sorry, I can read this. How to move this one? Never mind. Hold on. Okay. To determine to what extent the socio-demographic profile and perception among UPLB scientists are associated with the use of social media in research. Or this is your research question or your objective that you set earlier, to determine to what extent the socio-demographic profile and perception among UPLB scientists are associated with the use of social media in research. So when you see this research question or objective, good if the researcher can produce what we call this as a conceptual framework. So this is the outcome variable, the use of social media in research. So perhaps this researcher needs specific questionnaire to measure the use of social media in research. And these are the factors. Consists of two major elements. One is socio-demographic profiles, and the other main independent variable is perceptions. So in the demographic profile, we have a lot of parameters such as age, work orientation, ethnicity, and so forth, and similarly about perceptions. So this is one of the examples that require you to use multivariate analysis. Okay. Now is multiple linear regression and general linear model ANCOVA. So one of my guru used to say, the test is children. Multiple linear regression is father. General linear model ANCOVA is grandfather. What son can do, father can do. What father can do, the grandfather can do as well. So I mix these two together, multiple linear regression and general linear model ANCOVA. For you who are familiar with SPSS and statistical tests, we need to apply this test using different modules, either multiple linear regression or based on general linear model. So we put that side first. Let's see. Is a statistical technique that uses several explanatory variables or independent variable to predict the outcome of a response variable. So the outcome variable must be in numerical form. Or to study how the explanatory variable associate with the response variable. So the outcome is always in numerical form. For example, based on a cross-sectional study, a group of researchers aim to determine to what extent age, gender, ethnicity, education level, BMI, exercise, and diet are associated with systolic blood pressure. This is an example of scenario that require us to apply multiple linear regression or general linear model ANCOVA. Two different modules can answer the same research question. I think most of you are familiar with multiple linear regression. So let's assume this is for multiple linear regression to make it easy to understand. So the question is, how many participants should you recruit? So this is your objective of study. You know your outcome already. You know how many independent variables that you want to study. And the question is, how many participants should you recruit? Okay. So for univariate analysis, such as Pearson chi-square independent sample t-test, it is still convenient to calculate the sample size. You have the formula, you can calculate the sample size, or you use sample size software. But for multivariate analysis, we will dealing with so many variables, a set of independent variables. It's quite difficult to determine effect size for each parameter. You can remember in the morning session when you try to calculate sample size for independent sample t-test, for example. So you need to estimate the standard deviation, the mean difference, and so forth. So yeah, this is only univariate analysis. You can imagine how many effect size, how many parameters we need to plug in to estimate sample size for multivariate. So therefore, scholars prefer to use rule of thumb instead of calculate the sample size. Just use rule of thumb. So we need to, before sample size calculation or to be accurate sample size estimation, we need to understand the scenario. So determine the appropriate sample size technique to answer the objective. We need to determine the appropriate sample size to answer the objective. Sorry, we need to determine the appropriate statistical test. I did typo there, sorry. Determine the appropriate statistical test to answer the objective. So in this scenario, we understand that we need to apply multiple linear regression. We need to apply multiple linear regression or general linear model ANCOVA. So there are few regression models. If not multiple linear regression, most of the time it's logistic regression. If you have time of event, you can use Cox regression. Or another scenario, maybe Poisson's regressions. So there are not so many. If you have many follow-up, then you can use repeated measures. So I chose this because it's easy to estimate multiple linear regression. Okay. I took the rule of thumb from Tabachnik. He wrote a book published in 2013. So the number of sample size should exceed 50 plus 8 times the number of independent variable or number of predictor or risk factor. For example, if you have 5 independent variables in the final model, so 5 times by 8 plus 50. Okay, so the sample size statement is as follows. the aim of this study is to determine to what extent age, gender, ethnicity, education level, BMI, exercise, and diet are associated with systolic blood pressure. So according to study by Tabachnik, 2013, which is referring to a guideline of sample size for multiple linear regression, the number of sample size should exceed 50 plus 8 times by number of independent variables. Since the study has 7 independent variables, therefore the study will need a minimum samples of 1 or 6. So very simple. You can use this formula. So perhaps when you conduct the study based on cohort data, registry data, or based on questionnaire, we noticed that we have so many variables, right? Sometimes 20 to 30 parameters. Not necessarily we need to plug in m equal to 30, m equal to 20 based on the number or based on independent variable that we have in the instrument. But here we need to estimate the number of independent variable in the final model. This is based on the final model. Okay. So normally when we do multivariate analysis, first of all, we need to do univariate analysis. You will test one by one. Sometimes you use chi-square, use independent sample t-test. So out of 30 parameter, perhaps only 7 variables were significant. Then you will plug in the 7 in the multivariate model. So you can use this guideline by Tabachnik. I also write a paper for this. So my concept is based on the validation. I will explain it later. Okay. So what I did was I have registry data, and I set the outcome in numerical form, one outcome, which is the HbA1c. Then the outcome is in numerical form. Then the independent variable, some in numerical form, some in categorical form. Okay, so I assume I have the population data. What I did was, me and my colleague, we divide into few samples from small to large, 30, 50, 100, 200, 300, 400. And then we analyze using multiple linear regression model or linear model ANCOVA, and we compare the effect size. Compare the effect size derived from the samples and compare with the population data. So then we can measure the bias. For example, this is the sign symbol for different different variables. Okay, so if the effect size based on the sample is similar to the effect size based on population data, so we should get 0. The bias should be 0 if the statistic is the same. It's not the same, we will see some bias here. So based on 300 and above, look, we can see that the pattern is quite consistent. The bias is not too much. So this result also similar with simulation analysis done by other scholars. So I just give some rough guideline. For multiple linear regression, you need to recruit minimum 300. For example, the aim of this study is to determine to what extent age, gender, ethnicity, education level, BMI, exercise, and diet are associated with systolic blood pressure. According to study by Bujang, 2017, which is referring to a guideline of sample size for multiple linear regression for an observational study, the number of sample size should exceed minimum 300. to be able to derive characteristics that are mimic with the parameter in the targeted population. So it's up to the participant. You can use rule of thumb by Tabachnik, or you can use rule of thumb of 300.
Sorry, Dr. Adam.
Yes.
Does that simulation study subjected to the numbers of variables?
Okay. What I see, it depends on the author, how they design the regression model. So this is the limitation of the study, because the author maybe just put in 5, 6, 7 independent variables. So it is impossible for them to simulate the different number of independent variables. So if I'm not mistaken, they have some specific model. Maybe they put 5 or 6 or 7 parameter and they see the simulation pattern. Yeah, they fix the model. They fix the model.
So would you advise if the study has more independent variables and the required sample size would actually also goes up?
Okay, yeah, the fair answer is we don't know. But based on validation that I do, not only using this data, also the other data, the other population data, the sample size of 300 quite sufficient to ensure that we can report accurate statistics, and this is consistent with a few simulation studies that I read. To be safe, we should recruit more subjects, but 300 is minimum. Then it is larger than sample size recommended by Tabachnik.
Was that the study that you did the simulation on? How many these independent variables in that study?
Okay, I just did the validation part. Actually, the simulation part I read from other literature.
Okay.
I discussed in my paper there are some consistency.
I see. Okay.
Yeah.
Because what I
didn't do the simulation.
Okay.
I do the simulation using different paper for other purpose.
Okay. What I learned from other epidemiological studies is that it actually required 20 to 30 samples per independent variable if it's linear regression. Is that something that also agreeable from your study?
Okay, there are perhaps many rule of thumb. For me, no harm to follow or use any of the rule of thumb as long as it has proper citations. Yeah, so for this workshop, I only stated 2 rule of thumb. I noticed many rule of thumb for this purpose.
All right, thank you.
Yeah, welcome.
Doctor, sorry. May I ask whether that rule of thumb apply to all study design, provided they use the similar statistical test?
I can't hear you. Can you repeat, please?
Does the rule of thumb apply to all the study design, provided they use the similar statistical test?
Okay. We noticed that we can apply multivariate analysis in a cohort study design, in a case control study design, in what else? Cross-sectional study design, right? Yeah. So based on this rule of thumb, we didn't mention this specific for cross-sectional, specific for cohort. We didn't mention that. So my standpoint, we can apply this rule of thumb for cohort, case control, or cross-sectional, as long as it require you to use multivariate analysis. I don't think any scholar, maybe I didn't read much paper. I need to update myself. But so far, I didn't see any scholars propose sample size for proposed rule of thumb for different study design, referring to multivariate analysis. Perhaps there is there, but I didn't see yet.
Okay, thank you, Doctor. Because sometime in the clinical trial, basically they didn't use the rule of thumb. Am I right?
Okay. Pardon me?
For clinical trial, they didn't use the rule of thumb.
Yeah, sure. Because when we do clinical trial or interventional study, we will try as much as possible to control the confounding factors. We will apply strict inclusion and exclusion criteria. We will apply randomization to eliminate the bias or the confounding factors. Therefore, it's not require us to use multivariate analysis. Sufficient to use independent sample t-test, Pearson chi-square. Then, for sample size quotient, must use univariate test, such as what Prof taught us this morning. But for observational study, where your objective usually referring to association, risk factor, to determine risk factor, you can apply this rule of thumb.
Yeah, understood. Thank you, Doctor.
Yeah, welcome. Okay, now is for logistic regression. The difference between multiple linear regression and logistic regression is the outcome variable. So for this example, the outcome variable is in binary form. It's in categorical form, but in binary. For example, poor outcome, good outcome, okay, life or death. For example, the scenario based on a cross-sectional study, a group of researchers aim to determine to what extent age, gender, ethnicity, education level, BMI, exercise, and diet are associated with status of systolic blood pressure, say control and not control. So how many participants should they recruit? So just by changing the outcome variable, different analysis need to be applied. Okay, the famous rule of thumb by Peduzzi. I can't remember how many citations, maybe close to 10,000, I can't remember. Okay, so he and his colleague proposed an EPV 10 rule of thumb. So this rule of thumb depends on two criteria. Number one is the prevalence of the outcome of interest. For example, you can imagine you have outcome variable in categorical form, which has two levels, poor outcome or good outcome. So number one is the prevalence of the outcome of interest. For example, 30% of poor outcome. And number two, you need to determine number of participants to be recruited. Okay, so based on item 1 and item 2, researcher be able to determine number of independent variable to be tested in the final regression model. I will show you the example. Okay. Number one, we need to estimate the prevalence of the least category from a binary outcome. So you need to estimate the prevalence of your outcome of interest. Is it your interest is good outcome or poor outcome? So if your interest is good outcome, what is the prevalence? If you interested in poor outcome, what is the prevalence? So this prevalence you can find in the literature. Okay, step number one, you need to know the prevalence. Step number two, you need to estimate the sample size at the first place. Okay, you need to set some target. How many samples you can recruit? For example, you want to recruit 300. So based on 300, you need the minimum required subject in your variable outcome of interest is 90. 30% out of 300 is 90 subject. So I hope you understand until this stage how you get 30% from the literature. This is you yourself target how many subjects you need to recruit. Then based on A and B, you can estimate number of subjects you need to recruit based on the 30% prevalence. Okay. Based on the 90 subject, you need to divide by 10. This is where how the rule of thumb comes in. You need to divide by 10, so you have 9. So meaning to say, based on a sample size of 300, you are allowed to study 9 independent variables in the final model. For example, based on sample size 300, you found 5 variables significant in the final model. So the sample size is sufficient because you can study until 9 independent variables. Let's see another example. Say the prevalence is 30%, still 30%, but instead of 300, you intend to recruit only 100 subjects. So you need to ensure the number of subjects in the outcome of interest is 30 based on the prevalence. Based on the prevalence, your number of subjects in the outcome of interest is 30 subjects. So divide by 10, you will have 3. So based on 100 subjects, you are only allowed to study 3 independent variables in the final model. For instance, you have 4 variables significant in the univariate analysis, and you want to include 4 variables in the final model, so your sample size is not sufficient. So let's see another scenario. Here, you need to know the prevalence first. Kan? You can see from another angle. For example, you need to estimate how many independent variables in the final regression model. You need to be able to estimate the number of independent variables in the final regression model. So based on the literature, some studies, you estimate 5. So you can times by 10 based on EPV 10. So you have 50. 5 times by 10, we have 50. Next, you need to determine how many sample size you can recruit based on your capacity. Okay. So next, you need to know the prevalence of the outcome of interest. Say 20%. When I say prevalence, you need to understand that this is based on the outcome variable. In logistic regression, our outcome variable is always in categorical form. In this example, in binary form. So for example, good outcome, poor outcome. So based on 20% out of 300, you can have 60 subjects or participants in the outcome category, in the outcome variable that you're interested to see. So this is higher than 50. So meaning to say sample size 300 is sufficient. Okay, so you can, it's up to you whether you want to use this table or you want to use this approach. Okay. Next is the sample size statement. What time now? The aim of this study is to determine to what extent age, gender, ethnicity, education level, BMI, exercise, and diet are associated with poor control of HbA1c. According to the study by Peduzzi, which is referring to a guideline of sample size for logistic regression, suggests a minimum per variable is 10 for the least number in the outcome variable. Since this study is interested to study 7 risk factors, therefore, the study will need a minimum sample of 70 patients in the poor outcome category. This study plans to recruit at least 300 subjects, which is exceed the minimum number of sample size since the prevalence of poor outcome is estimated at 50%. So this statement might confuse you, but this table will ease you. Okay. Any question? Okay. I move on. The concept of EPV10 was introduced for both logistic regression and Cox regression. So Peduzzi and his colleague also promote EPV10 also can be used for Cox regressions. This is the citations. The concept of EPV with 10 received some critics. So there are many debates about whether rule of thumb EPV10 is still applicable. There are some reference who critiques this rule of thumb. Okay, I also came out with a paper for this, published in MGMS 2018, sample size guideline for logistic regression from observational study with large population, emphasize on the accuracy between statistics and parameter based on real-life clinical data. So I use, in this paper, I promote two approaches. Number one, to apply rule of thumb of EPV 50 instead of EPV 10, or using a simple formula, 100 plus 50 times by number of independent variables in the final models. So the citation is quite encouraging, published until 8 February 2020, citations reached almost 200. Okay. For sample size statement. For those who are familiar with logistic regression, you can run the analysis based on enter method or stepwise method. So enter method meaning you will derive the result based on the number of independent variables that you put into the model. But based on stepwise method, we allow the software to eliminate the not significant variable for you. The software will help you to eliminate, omit the variable is not significant. Okay, same, for example, in this statement, the aim of this study is to determine to what extent age, gender, ethnicity, education level, BMI, exercise, and diet are associated with poor control of HbA1c. So, for example, we assume that all these factors are significant in both univariate and multivariate analysis. According to study by Bujang 2018, which is referring to a guideline of sample size for logistic regression, suggest using a simple formula, Since this study is interested to study 7 risk factors, therefore the study will need a minimum sample of 450 patients. So another example using stepwise, the aim of this study is to determine the associated factors toward poor control. So we want to determine a set of risk factors that associated with the outcome. We might have many variables at the first place, but eventually we want the major risk factor that associated with the outcome. Okay, out of 313 participants and 7 independent variables were tested out of 313 subjects, and 7 independent variables were tested. Only 3 factors, age, diet, and exercise, were statistically significant. So according to study by Bujang 2018, which is referring to a guideline of sample size for logistic regression, suggests using a simple formula n equivalent to 100 plus 50 I is the number of independent variables in the final model. Since the study found 3 risk factors, therefore the study will need a minimum sample of 250 patients. Since the study had recruited 313, so the sample size is sufficient. So this is more to justifications rather than sample size statement. So yeah.
Dr. Adam, can I just also clarify? Your earlier suggestion was actually based on the lower events rates of the category, right? For the logistic regression. saying of the two binary outcomes. So the one with the lower events should be taken to consider for the numbers of variables to enter into the model, right?
Yeah.
Yeah, and is this? I mean, this is actually simple rules of thumb. Let's say for the one on the left side on the example, let's say if the events occurred at 10% and less, then we would only have 90 lah, then it's still sufficient. What if the events actually occur less than that? Then we will have, let's say, just say 50 or 45, say it happened like 5%. Then with 7 risk factor in the model, then that would actually go against the earlier rule of thumb.
Okay, true. Thank you for highlighting that. I propose 2 approaches. Number one, either the researcher can use rule of thumb of APB 50, and number 2, using a simple formula. So unfortunately, the simple formula did not incorporate the prevalence, regardless the prevalence. It can be low, it can be large, but APB 50, yes, it depends on the prevalence. The sample size will jump if you use APB 50 for low event rate. The calculation is the same with this table. I show the calculation is same with this table. It's just that instead of times 10, you should times 50. Instead of divide by 10, you should divide by 50. So yeah, the sample size here should be very large to apply APB 50. So you can use this rule of thumb, APB 50, or I give another option using a formula. Eventually, unfortunately, yeah, you are right. In this formula, we will not incorporate the prevalence. That's the limitation.
Okay, thank you.
Yeah. So in the citation, I don't know whether the scholar prefer use to APB 50 or the formula. I not really read their paper. Okay. I also validate a few population data, compare the statistic and the true parameter, and I found that if the subject more than 500, the statistic derived from the sample will about close or similar to the parameter in the targeted populations. So usually we can use this reference to justify that our sample size is sufficient. For example, the aim of this study is to determine the associated factors toward poor control of HbA1c from large cohort of data. The previous study found that when the sample size reached at least 500, the statistics analyzed from the sample are likely to be close with the parameter in the particular population. Since the current available data in the cohort is 4,371, therefore the current sample size is sufficient to estimate the parameter in the populations. Okay. What time should I stop? 5 o'clock? I think 5 o'clock, I think.
4:30.
4:30.
Yeah,
4:30.
but we
Okay.
can give extra.
Okay, I think we have sufficient time. I have another 10 minutes. So basically, we estimate or calculate sample size to get significant results. So then we'll know to plan our recruitment, plan for our budget, and finally to provide a sample size statement to be put in our protocol. Okay, to ease everyone how to estimate or calculate sample size, I write another paper, a step-by-step process on sample size determination for medical research. So these are the steps required for you to estimate or calculate sample size, just published in 2021. Okay, number one, you need to understand the objective. Like I mentioned before, when I dealing with my research client, I ask so many questions until I understand the study objective. Then I can only advise what type of statistical analysis can be applied to answer the study objective. So we need to familiar with various statistical tests. If you have problem with this, get the benchmark paper. And if the study design population is about the same, you can see the statistical method in the method section. This will help you. Okay, when to estimate or calculate sample size, we can use various approach. Number one, manual calculation, or you can use software, PS software, AP-Info, PASS software, or you also can use sample size table published in the literatures. And also rule of thumb for multivariate analysis. In this paper, I list many papers, and these papers have tabulated the sample size table for this purpose. For there are various statistical tests. So you can refer to this paper later on if you want to estimate a sample size. For example, here we don't touch about intra-class correlation. We don't study about kappa agreement. So you need to get this paper. So you need to provide some non-response rate. I already justify why we need to add some non-response rate. It can due to missing response or broken sample data, missing value. Last but not least, sample size statement. So I provide you the checklist here to help you. I skip this. Okay. I provide you the checklist to issue for sample size calculation. Number one, you need to understand the objective of study. Okay. Then you need to decide what is the right statistical analysis to be applied to answer the study objective. Okay. So to estimate, step 3, to estimate or calculate the sample size, it is necessary to ensure that the basis for which the determination of the effect size and or condition assumption for the use of a rule of thumb are appropriate. So when you estimate sample size, for example, you want to compare mean difference, the effect size that you put in should be appropriate. Okay. When you try to do when you want to do correlation test, the effect size you put in should be appropriate. When you do modeling, such as regression, you want to apply logistic regression, the number of independent variable, the prevalence should be appropriate. The prevalence of the outcome of interest should be appropriate. Okay. Then it is necessary to state clearly the planned effect size for the statistical test or the rule of thumb that you use. You need to mention in the sample size statement. For example, for compare mean between two groups, you need to mention the standard deviation. What are the references? Okay. When you want to calculate sample size for correlation test, you put 0.5. What are the reference? What's the reference? You need to cite some paper to justify that figure. Then when you want to calculate sample size, you can use either manual calculation or sample size software, or you refer some sample size table or well-recognized rule of thumb. Then after you calculate the sample size or estimate the sample size, it is necessary to ensure that the estimated sample size is feasible to be recruited within the allocated time period for recruitment. Number 4 is easy, to provide additional allowance to cater for the possibility of non-response rate. So it is necessary to decide whether the total non-response rate is acceptable. If you say 10%, justify why is 10%. Is it sufficient? Then it is necessary to adjust the estimated sample size. So when you need to add the non-response rate into your sample size statement. Last but not least, to write the sample size statement. So in your sample size statement, it should consist all these elements: the study objective, the choice of statistical test. So this is not a must, but proposed by the author. Okay, I think that's all from me.
Thank you, Dr. Adam. Actually, it's kind of eye-opening to me, but there are a few questions in the chat box, but I think we can wait for our open forums, because I need to give some time for Hatim, 5 minutes to 10 minutes for Hatim first, and then we proceed to our open forum. I hope it's okay to everyone, and Dr. Adam as well.
Yeah.
Okay, Hatim. Hatim. Hatim, are you here?
Perhaps Dr. Adam can answer a couple of questions in the chat box.
Okay.
Yeah, sure.
Yeah.
Okay. The first question is, does it require for us to calculate sample size for each objective in the study?
Good question. Okay. Commonly, when we do research, we have any objective. And perhaps each objective may require different statistical analysis, right? Okay, so there are two approaches. Number one, for myself, I will encourage my research client to estimate or calculate sample size for the main objective. So normally we have main objective, we have secondary objective. Yeah. So the main purpose of this study is to answer the study objective, the main study objective. So to ease your work, just estimate sample size for your main objective. But if you feel that your secondary objective also important, you can estimate the sample size for the secondary objective. If the sample size is lower than the main objective, then it is fine. For example, main objective require 300 subjects. Secondary objective require only 100 subjects. So it is fine, no need to spell out the sample size calculation for the secondary objective, because sample size for main objective can also be used to answer the secondary objective. But the problem is when the sample size based on secondary objective require more subject. For example, sample size calculation based on the main objective require 300 subjects. But sample size for secondary objective require 400 subjects. So you can use the sample size statement based on the main objective, but you need to know that you need to recruit more than 400 subjects to cater the requirement for the secondary objective. So in this first approach, just sample size statement for the main objective. But you need to look also whether your sample size is sufficient to answer the secondary objective. But the common practice that I see when I consult my research client in various universities, their supervisor or their panel require the student to estimate sample size for each objective and select the highest. For example, we have 4 objectives. we have sample size statement for 4 objectives, then look which one is the highest. So regardless, it is secondary or main objective, you need to make sure you need to recruit sample size based on the highest number. So there are 2 approaches. I can accept both, but the final say is based on the common guideline set by your university.
Okay, for the second question is by Dr. Hasni. Do I need to conduct EFA or CFA for my new developed questionnaire?
Do I need to conduct EFA and CFA?
For her new developed questionnaire.
Okay. Wow, this is a tough question. I understand the participant want to develop new questionnaire, kan?
Yes.
I have a present, a gift for all scholars. I just published a book. How to develop a questionnaire, and it's free in a major online bookstore, Google Play Book, Smashword. Okay, you can type my name. I just published yesterday, I think. Okay, so I categorize instrument into 4 different categories. Some question to observe factual or information. Question number 2 to measure knowledge. Question number 3 to measure latent variable. Question number 4 for diagnostic purpose. So all these different type of questionnaire will require different validity basis. So I'm not so sure, but I assume our participant develop a new questionnaire that measure latent variable, for example, quality of life or the depression, anxiety, stress scale. So develop some framework. Okay, so is that the case? Yeah, it is necessary to conduct EFA or CFA as a validity basis. But if you develop a questionnaire to measure knowledge, then you cannot apply EFA and CFA. You need a different statistical measure to validate those. For example, a researcher develop a questionnaire to diagnose a disease. Then we should not apply EFA on CFA. We should apply different validity testing, such as sensitivity and specificity. So it depends on which type of questionnaire you are developing. It's okay. I hope I answered the questions.
For sure, want to add up anything?
Maybe I would like to add also. I think probably it's a new questionnaire. Usually we can do with an EFA. To do a CFA, I remember the data set has to be very big enough for you to actually do a CFA. Otherwise, you may want to wait until more studies have been done and more data has been collected. Then you can do a CFA. Because I think you need a larger data set and to split the data set into 2 for you to do a confirmatory factor analysis. Otherwise, you'll not be able to do that. That was what I understand.
This is true for questionnaire that measure latent variable. For example, quality of life, domains, we have few domains, kan? So yeah, we need EFA and CFA. So other questionnaires such as for diagnostic purpose, to measure knowledge, we require different statistical tests.
Thank you.
Okay.
Dr. Adam. Hello, Dr. Adam. Hello, Dr. Adam.
Yeah, hello.
Okay, I'm Hasni, the one who asked just now. A new questionnaire. My new questionnaire is a latent type.
Oh,
to measure the culture level.
Is this challenging?
Yeah, but there was a school of thought. I went some seminar. So the researcher said I should conduct CFA because he said EFA actually meant for the new theoretical, but there is a lot of school of thought on that opinion. So I just confused which factor analysis that I should conduct in my study. Thank you.
Okay. For the current trend, I noticed for those who develop new instrument that measuring latent variable, they will apply both AFA and CFA. Good to fulfill both, so it can increase your merit in terms of methodology.
Oh, okay. Okay.
So
But
AFA will help you to construct your domains into few domains. CFA will measure the model fit. So we need to report both to strengthen the evidence of your instrument. I hope you can get my paper, Doctor. Just published yesterday.
yes,
No,
I
not
will look
paper,
for your
book,
paper.
actually book.
Books. Yes,
Book.
inshallah, I will look for your books. Thank you, doctor.
Yeah. You can find the book from CRC website also.
I posted the link on the chat box. There are 3 ebooks that you have free for download. Is it right?
Thank you,
Okay. And then there is more question, I think, from a student. What is the minimum accepted margin of error and level of confidence for estimating sample size for observational study measuring the prevalence of something in a population?
Margin of error. This is quite difficult to answer, but I try. We touch about margin of error in the morning session, right? For example, to estimate sample size for 2 proportion. Okay, so we need to set a margin of error 5% or 10%, or for example, to determine the prevalence. Yeah. Okay, to determine the prevalence of a population. For example, our study aimed to determine a prevalence of a disease or of an outcome. So we estimate the prevalence based on literature is 50%, for example, kan? So what is the appropriate margin of error for 50%? Okay. If the prevalence is high, such as 40% or 50%, I believe it is fair to use margin of error 5%. Okay, so for example, you estimate, you determine the prevalence. You want the objective of the study is to determine the prevalence of some outcome. Based on the literature, the prevalence is 50%. So based on margin of error 5%, you will need to recruit 3 at 4 subjects. After you recruit 3 at 4 subjects, you calculate the prevalence, maybe around 50 subjects, plus minus 5% margin of error. So this error we can tolerate. But if the prevalence is very low, for example, the prevalence in the literature is 10%. I think it's not fair to use margin of error 5%. Or the prevalence is very low until 5%. I think it's not fair to use margin of error 5% because the prevalence is already very low. Maybe you need to use 3% or 2.5%, something like that. Okay. So it depends on the prevalence. If the prevalence is closer to 50%, fair margin of error 5%. If the prevalence lower than 10%, I think should use lower than 5%. This is my opinion.
Do you have particular reason for that kind of opinion? I mean,
okay. Okay. For example, okay. Let's say the prevalence is very low, less than 10%. Okay. So based on sample size calculation, the sample size required is 200. For example, this is just an example. You want to determine the prevalence of an outcome. Literature says less than 10%. You use test estimate with margin of error of 5%. Then the sample size required is 200. When you recruit sample size of 200, you calculate the prevalence. You found the prevalence is 7%. And the margin of error is 5%. Are you happy? What I understand, when the prevalence is 7% and margin of error is 5%, meaning the true value in the parameter, the true value in the population is ranged between 2% until 7 plus 5, 12%. So it's so huge. Actually, you don't know what is the prevalence. It can be 3%, 4%, 10%. So meaning you sacrifice the accuracy. So therefore, you need to increase the accuracy of the estimate. You need to reduce the margin of error because your prevalence is very low. For example, let's say the prevalence is less than 10%, you use margin of error 2.5%. Of course, the sample size will jump, but your accuracy is increased.
Okay, understood. Can I call Nasihah Sakinah to ask the question to Dr. Adam?
Hello, Dr. Adam.
Yeah.
Okay. I have a question regarding the sample size calculation based on the logistic regression. You mentioned that there is two methods, right? The enter method and stepwise method. So if I decided to use that as my sample size calculation, I should include both the statement in the study, right? Meaning
No.
in the no. Okay, so can you clarify?
It depends. Okay, we put it this way. It depends whether you basically it depends on your objective. Okay, you need to determine let's say you use the formula, the simple formula that I propose. You need to determine the number of independent variable that is significant in the univariate analysis. Therefore, you want to put all these parameters in the multivariate model. So yeah, you can use the sample size. You can use the sample size, the first sample size statement based on the enter method. We assume that we assume that we didn't omit any of the independent variable based on the regression model. For example, you have 30 variables, 30 independent variables. You did univariate analysis. You found 7 variables that were significant. So you intend to put 7 independent variables in the multivariate model. So you can use the formula 100 and use times plus 8 times by 7. Okay. For stepwise method, I just add some additional scenario, so you can justify that your sample size is sufficient. For example, when you do based on enter method, you estimate you require. Okay, for example, let's say this is I put another scenario. Let's say I need to go back first. Where is sample size statement? Okay. Based on this sample size statement, 100 plus 50 I is the independent variable in the final model. You know that you require 450 patients, right? Based on 7 independent variables. let's say you not able to collect sample size 450. You only able to collect until 250. But based on the analysis, based on the enter method, you found some variable is not significant. So you let stepwise method do the job for you. Out of 7 variables, left only 3. The sample size requirement for this purpose is only 250, no longer 450. So your minimum requirement sample size is 250, not 450. I repeat, out of many variables, 7 variables significant in the multivariate analysis. Therefore, you put the 7 independent variables in the final model, but eventually you don't have 450. You only have 250. By right, your sample size is not sufficient. But lucky that based on the analysis, 4 variables were not significant in the multivariate. So when we do stepwise, only left 2 variables. Based on the 3 variables, you only require to collect 250. So in this case, your sample size is sufficient. But if you want to maintain conclusion based on the enter method, you need 450 based on this rule of thumb. Because logistic regression or other type of regression, it can answer 2 different hypotheses. Number 1, for specific research question. Number 2, to determine risk factor or set of risk factor. To determine set of risk factor is easy. The example is here to determine the associated factors. But the other research questions such as we want to determine to what extent age contribute to BP after control for gender, ethnicity, education level. In this case, we need to apply enter method. We won't apply stepwise. If that's the case, then we need to maintain 450.
Thank you, Dr. Adam.
Okay. Yeah.
Okay, next, there is a question from, I think, Dr. Umar. Does it mean for each sample size, according to any statistical rule, require a formula to calculate the minimum sample size for the objective?
Pardon me, Doctor. Quote sikit, please.
Does it mean for each sample size calculation for any statistical rule require a formula? I mean, a unique formula for each. Yeah.
Yes. Yes. It depends on the objective.
So
if the objective to determine the prevalence, like this morning session, easy. Calculate the sample size based on the prevalence formula. If the objective to compare the mean difference, apply the formula from independent sample t-test. But if the objective is to measure the correlation, we can apply Pearson correlation test, formula based on Pearson correlation test. If you want to do diagnostic research, we need to apply formula based on sensitivity and specificity tests.
May I ask, for the rare event, right, that require a Poisson analysis, what is the sample size estimated?
Poisson regression.
Yeah.
Oh, I hope I can write the paper for that, but I don't have opportunity to write the paper. So I'm not really familiar with Poisson regression. Sorry.
Okay. Thank you, Dr. Adam.
Yeah, but PASS software have the module for Poisson regression. PASS software have module for almost all statistical tests.
But
I can help to calculate. I have the software with me.
Sure. Roshu, you want to ask questions some more?
Shall we invite Prof. Hatim to come on the forum so we can begin the forum?
Actually, I think maybe Prof. Hatim have something else good, because actually I cannot contact him.
Sorry, I'm around.
Prof.
He's back.
I'm around.
I called Prof just now.
Sorry. I was reading many other things, so I also listening to the talk. So okay.
Okay. Prof, Prof,
Yes.
do you want to I mean because you told me that you need 5 to 10 minutes, right?
Sorry?
You need 5 to 10 minutes for relative risk.
Oh, okay.
Yeah.
Yes. Let Dr. Adam finish. Let Dr. Adam finish already.
Yes, done.
Okay.
And then we continue with more topic discussion lah. Okay,
Okay.
Prof.
Just now asking about last question, asking about Poisson. Poisson actually is based on count and rate. So like Dr. Adam mentioned, in some software available, right? So but Poisson is actually a quite tricky one. Poisson is a count data, rate data. If the assumptions are not fulfilled, you have to go for other analysis like a negative binomial and many other analysis. So Poisson is a bit more complicated, but sample size calculation is not really difficult. Have some. I have supervised around 4 students. What you call it? Later, if Dr. As if I want to know, I can explain you for the Poisson regression. Right. Okay. So the one that you are asking about is what you call the risk, right? This morning, I and Dr. Siva missed one part, the small part actually, that is for risk assessment, right? Risk assessment. So maybe I just go back to explain you a little bit, right? Just by PS software, very simple. It's not difficult. But there is one example actually. I let's say cross case control study. Wait, where is the? Okay, here, let me share. Okay, so can you see the slide?
Yes, Prof, can see.
Okay, here this morning example case control study, right? We did the 2 proportions, but we forgot to do on for the estimate, risk estimate. So here mentioned corresponding to an odds ratio of 1.7. Actually, for risk, it is similar to like proportion. Risk estimate comes from literature. However, even though it comes from literature, you need to determine by your expert opinion. For example, the risk assessment, either odds ratio or relative risk, anyone from literature, by right you should not take as it is, right? We have to take and see the risk. Let's say the published article in, let's say, in Europe or Asia or anywhere. If the risk is mentioned, we can take the risk. If you think that it is smaller than the same, of course you can take. Otherwise, you have to estimate. But remember, if the risk is high risk, you estimate, sample size will be smaller. If the risk is small, sample size will be bigger, right? Sample size, risk of, let's say, odds ratio of 3 and odds ratio of 2.5. Odds ratio of 2.5, we get a bigger sample size. So that assessment, the adjustment also necessary. So this example, I just go back, right? It is about rubebitis and eating jelly beans, if you remember this morning example. So 30%, 20%, 20% is the P0, P1 is 30%, right? So what we have, we can do is here, go back to power and sample size, right? Can you see the software, power and sample size?
Not yet, Prof.
Not yet. Okay, here. Okay, so we use dichotomous, right? And then it's the sample size here, independent case control, two proportions. Instead of two proportions here, right, we are going to use odds ratio. From the literature, right, it is mentioned that odds ratio is 1.7. So if you think that odds ratio is more or the same from literature in Malaysia, for example, then you can take it. If you are not sure, recommended you take the lower one, smaller one, right? So same example, the 20% is P0, right? And then 80% power, M ratio is 1. This is odds ratio, right? Odds ratio, then the odds ratio 1.7. For example, if it is the same, 1.7. So sample size will be 303. The sample size calculation by hand with 20% and 30% is, if you remember, what is the sample size? It is 293, right? 293. But by risk assessment based on odds ratio, sample size is larger. It is not surprising because, example, rubebitis is rare. If it is rare, odds ratio is appropriate, right? Case control is appropriate. And instead of estimating by using two proportions, if you use one proportion and odds ratio, sample size will be larger, right? So this is the way of estimating sample size, calculating sample size based on estimated risk. Are you clear, right? Let's say if this study is prospective cohort study, then prospective, automatically you will see here relative risk, right? Same thing, a relative risk, you put it. For example, this example, for example, if it is a, let's say prospective cohort study, for example, this is not a rare disease, for example, then relative risk, for example, you take the relative risk, if it is odds ratio is 1.7, relative risk, you estimate it to be lower because normally sample size, normally odds ratio is estimated larger than relative risk. Let's say 1.5, for example, just an example, right? So, what will be the required sample size? Sample size will be 293. Okay, it is because we low down to 1.5, it's a relative risk, right? Sample size is 293 compared to odds ratio. Let's say if it is same or the same relative 1.7, sample size will be what you call smaller. In what you call the estimating the calculating the sample size based on odds ratio relative risk. Normally, odds ratio has bigger, larger sample size. So this is the only one that this morning we missed, right? This morning we missed. So any question about this? Any question?
I think it's clear, Prof. It's very clear.
Okay, so it is actually if we want to estimate sample size, you can estimate like this kind of study either by using two proportions or one proportion with risk assessment, that is risk estimate. That is okay, right? This is the only one we missed this morning, right? Okay, have you finished the what you call the calculating sample size? It's very good that Dr. Adam has introduced about multivariate this afternoon. This morning, I have introduced all our univariate analysis. So because I was thinking that it's the first workshop, so it should be all basic one. So basic one, all I introduced, all our univariate analysis, right? Very good, Dr. Adam has introduced afternoon multivariate analysis. So there are many, right? As I mentioned, statistics are 3 levels: basic, intermediate, advanced, right? So basic we talked about this morning. Afternoon introduced by Dr. Adam for intermediate statistics, right? So in intermediate to advanced, there are many actually, right? Regression group, GLM group, right? So there are many. So way of calculating sample size will be quite different, right? Like this afternoon, Dr. Anna mentioned about whether by enter method or what you call the stepwise method based on the number of variables significant and the beginning number of variables you got the included. So that kind of thing. Actually, there are many interesting things like rule of thumb or by some other approaches. There are many from intermediate advanced statistics. So if Dr. Chu, I'm sorry, Dr. Chu, you are Professor, right? Prof. Chu, right? Prof. Chu and what you call the Dr. Azifa, or if you want to continue for next level for our same cohort of participants, it will be very good. Starting from intermediate, basic, intermediate, advanced. And there are many things which, like Dr. Adwan mentioned just now, validation studies, right? Till related is like structural equation modeling, right? There are many. And also for regressions, there are so many, right? Linear, logistic, Cox regression, Poisson regression, ordinal logistic, multinomial, there are many, right? Log linear and so and so. And GLM group also there are many. One way ANOVA, tail, multifactorial ANOVA, ANCOVA, MANCOVA, MANOVA, repeated measure ANOVA, tail, repeated measure MANCOVA. And there's one more group of analysis where now become popular is panel data, right? Panel data. So I teach some, but panel data problem is problem is softwares are not really developed yet, right? So some situation we can teach, some cannot because softwares are not ready yet. And then the other thing is that the software, apart from what Dr. Adam mentioned about software and the one that I demonstrated software, other software I recommend is, as I mentioned this morning, starter software. Starter software, the people like in clinical unit, research unit, I think staff should master starter software because epidemiological studies, starter is one of the best. Of course, now these days you can use R. R is public domain, free of charge. But I still believe that for epidemiological studies like field epidemiology, clinical epidemiology, I feel that starter is still one of the best. So I and my wife, we both of us, we are medical statisticians. We train people for starter software from basic to advanced level. And when I develop Master of Science and Medical Statistics degree program, starter was heavily taught. So CRC, actually all CRC should master starter software. Sample size calculation, a lot of options there you can. So one software you buy it, very economic, right? Many things you can do, many things, right? So that's just my suggestion, right? As Prof. Chu is leading the CR unit, right? Okay. Last year I ran a number of starters workshop, basic intermediate workshop, right? And around this region I run in the Southeast Asian region for the starter software. Okay. What is our plan, Dr. Azifa? What about this morning assignment given?
Prof, I think sebab actually if we follow the schedule, supposedly currently is the for open forum open forum, Prof and Dr. Adam Bujang. Basically, it's just open forum where the participant will ask any question to the both of the speaker.
Okay, no problem. So what about this morning assignment? We will give them the assignment. I think they can do it, I think, right? I put the risk assessment also already, so they can answer all questions. For those who want to know more about answers as well, so just let me know. I can give answers. Right. Okay, so in that case, I leave it to Prof. Chu and Dr. Azifa for the forum.
Yeah, I think I pass for Prof. Chu.
Okay, I think we are running very short of time. But I think since we are promising to have a forum of discussion, if there is any burning questions among the participants, and let's be specific about sample size determinations. If you have, I think we can take one or two questions. Otherwise, we don't want to delay too long for your evening time to your family or that, as we promised to end by 5. Is there any burning questions?
Yes. Okay. I would like to ask to Prof. Syed or Dr. Adam. I would like to ask in the current what is your opinion on the sample size calculation on the SEM? Because I think SEM structural model equation modeling are quite I mean, in the latest trend in medical field of study. So, what is your opinion on the sample size calculation that you recommend we can use?
Okay.
Thank you.
Dr. Adam wants to answer. Dr. Adam? Dr. Adam still wrong.
Dr. Adam, we cannot hear you.
Sample size for SEM, structural equation modeling, right? Okay,
yes, yes.
I noticed there are some guidelines on sample size requirement for structural equation modeling. Yes, the author have some rule of thumb for this purpose. I can't name the some rule of thumb at this point but the rule of thumb is available. Yeah, I noticed that is available. And yeah, that's for now. Yeah, Prof, maybe can add.
Okay, thank you, Dr. Adam. Right, Dr. Adam has mentioned that as a rule of thumb available, right? The sample size calculation, because as you know, SCM is the combination of CFA, confirmatory factor analysis, and regression, right? Originally, structural equation modeling is a combination of CFA and multiple linear regression, but these days it has extended, right? It is CFA and let's say logistic regression, CFA and Cox regression, and so. They have combined very much what's called developed. So, but you need to find the added module, right? Compared to sample size, as Dr. Adam has mentioned about rule of thumb, and there are some way to calculate also. For example, one of the very common one is Monte Carlo simulation, right? That you can calculate that. There are ranges of there is a range of ways of calculating sample size, but the rule of thumb is still very much acceptable, right? Like in CFA and EFA, also rule of thumb is still widely acceptable. So correct, the one that asked Doctor, your question is very important. For SEM, you must get the right sample size. So there are ways to calculate, and maybe because of time, we cannot elaborate more. The one way is what you call the rule of thumb. Another way is some ways of calculating sample size based on available information, right? Monte Carlo is one of the very well known one, right? Okay.
Okay, thank you.
And use G power to calculate the sample size. Is it acceptable? G power software.
Dr. Adam wants to answer?
Since SEM involves multivariate analysis, it will be difficult to estimate or calculate sample size for this purpose. I will advise researcher participant to use the rule of thumb instead.
Okay, thank you.
Your question, G power is for SEM or G power for other purpose?
For SEM sample size calculation, because based on how many related variables.
Yeah. G power, as far as I know, for SCM, I'm not very familiar. But as I mentioned this morning, for our medical health sciences research, I have gone through a number of software available. G power has some situation very good. For example, Poisson, G power is one of the best one, very good. But some situation, G power asks unnecessary things. That's I must comment this way. I don't downgrade G power, but based on our concept of medical research, some situation G power asks unnecessary things, which is not applicable to us, right? So G power is very general software developed. So some calculation I don't use G power because problem is unnecessary string asked, so we cannot answer. And problem is when you put any number, it comes out. So that is a bit danger, right? So if I'm not convinced, I don't use G power, but in some situation it is good. It's quite good, right? SCM, I'm not very sure. I don't think so. I don't think so for SCM. That's my knowledge, right? Okay.
Yeah, I think Prof. Ching, it's not every final analysis that you plan is available in sample size software or formula. And in that situations when you don't have the exact formula available, you can go for the next available, the next closer formula available. Let's say, for example, you are actually have to do a mixed modeling in your study, but there's no such formula for sample size estimations for mixed model. And then the next closer one, you may choose a multiple linear or just a simple t-test. Okay, is there the last burning questions before we have to end this one? Otherwise, we'll not be able to finish this workshop. There are so many questions.
Assalamualaikum.
Yeah, go ahead.
Assalamualaikum.
Waalaikumsalam.
Yeah, it's a question. Have a question.
Yeah, I have a question. Today we talk about the main.
Assalamualaikum.
Oh. Can I ask
Who's
you one
speaking?
question?
Jian Hong. Okay.
Yeah.
Okay, please
today,
speak.
Yeah, today we talk about use the t-mean to calculate the sample size, right? If we have more than 2 means, how can we use the software we talk about today to calculate? In my study, because my study I have 2 groups. I use the myofascial technique to treat the low back pain patients. So all of my the weight is continuous variables. So I use G power to calculate the sample size, but today I got the new software to calculate the sample size, but I don't know how to use which one to calculate. So Prof, can you explain?
Okay, you are talking about more than 2 groups, right?
Yeah.
Okay, I can answer you. The formula that I gave you this morning, remember, 2 sigma square divided by we got delta square and the ZFR Z beta. Remember, that's a formula. That formula is only for two groups only, 2 groups comparison.
Yeah.
Right. So if you want to calculate for more than 2 groups, you have ways to do. Number one, you have to modify that formula if you want to calculate by hand, right? Modify formula, I can tell you how to modify. That is one way. Second way is no, I don't want to calculate by hand. I want to calculate by software. No problem. There are 2 ways to do. One way is you calculate like PS software kind of thing. You calculate as I mentioned this morning. For example, you are comparing A, B, and C. So you have to calculate A and B one time, B and C one time, A and C one time, 3 times, and take the biggest one multiply by 3. We've got 3 groups, right? No, I don't want to calculate like that also. I want a straight way. I got it, no problem. You go to Stata software, for example, Stata, and there's some software available. I think G power also available. That is actually based on ANOVA. When you compare 2 groups, that is based on mean. When you compare 3 or more groups, it's based on variance. That's why we call it analysis of variance, analysis of covariance, and so and so. So analysis of variance, then you are going to use software for 3 or more groups, right? Either Stata software or G power or any other software, and it will get straightway, straightway per group, straightway per group. So no need to calculate the A and B, A and C, B and C kind of thing straightway. Because I did not have time. We don't have time. Otherwise, I can demonstrate for you by Stata software, right? That is just by using analysis of variance command, the option, and then you will get per group, right? Straightway you got a per group. That is the way we calculate. So number of ways to calculate, no problem. You don't need to calculate by hand. You calculate by software. Of course, you need to have a software, right?
Okay, Prof. So I just repeat for for make sure I understand your explanation. So if we use the directly to calculate, we only need to use the alpha type 1 alpha to divide the how many times we calculate, right? For example, we okay.
Yeah, go ahead. Yes.
For my understanding, so because if we compare A and B, B and C, and
A and C.
Yeah, A and C. So if we compare A and C, so we need to use the type 1 error to divide it to 3, right? It just change the
Multiply by 3. Take the biggest one. Let's say you calculate sample size A and B is sample size 70.
Yeah.
A and C is 80. B
Yeah.
and C is 100. In that case, take the B and C 100 multiply by 3.
Oh,
That is the way we long time we calculate, because at the time was software not available. Now software available, it will straight away give you, if you have 3 groups, straight away give you per group. Straight away. For example, sample size is 70 per group. It means that 70, 210. For example,
okay.
Right?
Okay, perfect. Thank you.
Okay.
Okay.
Yeah. Only thing I just want to tell Prof. Chen. Prof. Chen asked the question this morning, right, about the feasibility.
Yes, Prof.
Yeah. So feasibility actually is many people confuse feasibility and pilot study, right? Pilot study is a miniature of real trial. What feasibility is whether this study is feasible or not, right? So by right, feasibility study also need to calculate sample size based on the available the parameter, right? And so we can calculate. But of course, feasibility study is not like actual study. It is not really as big as as big as a real study, but still you need to calculate sample size. So still need to look for some kind of parameters you can calculate. It's not a very big problem, but to answer Prof. Chen's question, yes, calculate based on the parameters and based on the possible groups that you are going to do, like something like actual study, right? Pilot study is a miniature or clinical real trial, but pilot study normally no need to calculate sample size, right? So that is the difference between pilot and feasibility study. So your point is very valid. Feasibility study still need to calculate with sample size. Yeah, but answer your question, Prof. Chen?
Yeah, is there any software to do the calculation for feasibility study besides we look at the nomogram or table?
Yeah. So last time, traditionally was looking from nomogram, right? But these days people calculate, right? So it is good to calculate, right? Even though it's smaller scale, but still need to calculate. So we have to collect the information, same information. So calculate whatever we can based on the information. If it is a very new study, then of course you may have to predict. So answer is still need to calculate.
So, Prof. Sai, can we use the PS Power software to do this purpose?
You mean for feasibility?
Yes, or we have to use another software.
I think still the same. So any software you can use, still the same. Still also you need to consider about possible withdrawal, possible dropout, possible loss to follow up. Still need to consider. So it is something like you still need to look for the information and still need to calculate, even though not a big scale, right?
Thank you, Prof. Sai.
Okay. I wish I can explain more detail, but later you can get my phone number from Dr. Ziva. I can explain more.
Prof, in the future, do you have another workshop?
We will let you know.
Okay. Thank you.
I mean, you can also go to the UNISA university website, as Prof. Sai Hatim was saying. He does conduct workshops on and off, and you may find the news from the respective university website.
Okay, thank you, Doctor.
Yeah.
Actually, not only UNISA, Prof. Chen, Prof. Chu. Actually, I'm invited by every year by many CRCs CRCs and the Ministry of Health, also universities. So if you look around in many CRCs, I think regularly advertisement is there with my name. Also universities, right? I recently did a number of universities, and also under UNISA. Just move, see around. If information you need it, I can send it to Dr. Azifa also can.
Yeah, then we can post it on our Facebook, and just follow on our Facebook. You'll be having all the news about research-related activities and workshop and trainings. Okay. Right, I think we shall come to the end of it. I would like to give another 1 minute for each speaker to give a last gist, important essence or sample size determination from your perspective. If that's okay. Yeah. So we start from Dr. Adam.
Thank you, Dr. Chiu. So perhaps previously, sample size determination is a major issue for most of researchers, but nowadays the software is available, the published papers available, consultants edition is available. So I think hopefully all these facilities can help the researchers. So I'm happy to help everyone. I have posted my email address in this chat room. So if you need any help, I'm happy to help you. So thank you so much for the invitation, Dr. Chiu.
Thank you.
Yeah.
Thank you. Prof. Sahatim.
Okay.
Final words on sample size.
Okay. And like Dr. Adam mentioned, exactly. When I started as a junior lecturer, right, very junior lecturer, 29 years ago, right? At the time, this sample size issue was something like very new to many people, right? And in the literature, also very difficult to find. Software were actually at the time very, almost none actually. The PS software, first time I learned was when I started study in Newcastle University. That was in 1998. At the time was the DOS version. You can imagine, no? Right? I started learning SPS version 1, starter version 2. Now SPS is version, what was it? 26. And also starter version 16 or 17. Now is at the time I learned about it version 2. No sample size, no nothing, right? So at the time was we had to read many things. Software not available. I started writing papers on the sample size calculation. If you see in the internet, you can see that some of my old publication many years ago. So these days are actually quite easy, right? Sample size calculation was actually many people, including clinicians, right, including postgraduate students, lecturers, very afraid of it, right? Sample size, talk about sample size, no, do not understand. So I explained to lecturers, run away. Lecturers said that you do it last year, then I don't want to do, I don't understand, and so on. These days, actually, all are very user friendly. Softwares are available, right? The literature is there, training courses are there, online software a lot, online consultation. I have online consultation a lot for the sample size calculation throughout the world, but my students are around the world. Some are in US, some are in UK, some are Australia, some are in even in China. So they contact me regularly. So we have a number of the collaboration, including recently with Japanese universities. So what I mean is these days no need to worry, no need to be afraid, right? And the last word I want to say is that be an independent researcher, right? How to be an independent researcher? Learn something, started like this today. Basics you start, slowly you go up. So at the end, you don't need to rely on statistician. That is the aim that I always train people, right? I have been conducting workshops, more than 400 workshops already to my 400 workshops and intensive courses in and out of Malaysia. So whenever I go, my point I mentioned is you must be an independent researcher, because if you every time you have to look for a statistician for sample size calculation, statistical analysis, so and so, right? Like I noticed that like Prof. Chiu, many things he's very knowledgeable. He's a clinician. Am I right? You're a clinician, right?
Yeah.
So the clinician like this understand about research methodology and statistics is actually very, very valuable. Very valuable. You can be an independent researcher. You are a clinician. You are a researcher. you can understand about methodology and statistics. That's why I mentioned I have few friends in universities, also in Ministry of Health. Some of my friends are actually really knowledgeable, like Prof. Chu, really knowledgeable. They discuss with me, and whenever they read book something, they call me. Say, I finished this book. Can I discuss with you? Something like that. So what I mean is, my seniority and my career, I'm still reading every day. To be honest with you, right? Nearly every day. Only the day that I'm very tired, I don't read, right? Nearly every day, because I want to update and upgrade. Same thing, your younger generation, right? You'll be the future leaders of this profession. So you need to what you call the learning. So my word to you is, be an independent researcher. Independent researcher, I mean, you are good at your own field. Like, for example, like Prof. Chu, he's good in clinical. He must be good in also in the research, where the research methodology, biostatistics, and so, including scientific writing. Then, of course, it cannot get within, I mean, just within a few years, you cannot get it. You accumulate slowly, right? So by this way, you can accumulate, and later you can teach back. My principle is that teaching is the best learning. If you know something, you teach. Something I knew already at the dinner table, I taught my wife, as she's also a medical citizen. So by teaching, you will learn, right? Teaching is the best learning, because if you want to teach somebody else, you must digest yourself. Without understanding it, you cannot teach others, right? So please learn. Teaching and learning must be continuous process. Then you will be a very good researcher, very good lecturer, and so on. That's my advice to all the younger generation. Right? Only the Prof. Chu. Thank you.
Thank you very much.
Thank you for invitation. Yeah.
Yeah, thank you very much for the wise advice. So I think the take-home message from me also is be very humble. If you need help, get the expert in your team early. Better to be early than late. Yeah, and read widely. Only stop reading if you're tired. Once you have read it, speak and teach someone else. Yeah, maybe get someone in kindergarten. Talk to them about sample size. If they can understand you, then you're very good. Okay, so lastly, I would like to thank Prof. Syed Hakim and Dr. Adam for willing to take up our invitations and provide this very informative. I think it's very much appreciated. Very concise and very packed. I think all of us learned something very important. So it opened up to further workshop and trainings and webinars, possibly. Yeah. So last but not the least, I would like to thank CRU officer Dr. Azifa, Farizatul Suhada, and Intan Basila, and two of my RO are also here. Yeah. So we learned a lot today. Yeah. So thank you very much, and thank you everyone for being a very kind, nice participants. Hope you don't stop here. Yeah, you continue on to learn. Yes. And you have any queries, and the speakers have provided their contact. You are free to contact them. Yeah, to consult them. Okay, and anything more you would like to actually follow us on the Facebook and contact us. If you would like to have any more specific workshop or trainings or that, we would actually consider, and look out for good expert speakers to help you. Okay, right. So that's all. Thank you very much. Nice evening to everyone.
Yeah.
Okay, see you again.
Hey, Prof.
Okay, thank you. Bye.
Bye.
Okay, bye.
Thank you.
Okay, now we go.
Prof, can we just take some pictures?
Sure.
Can everybody open their face, their video?
If you are willing, I don't mind.
Any of my ex-students around? Yeah.
Me is one of them actually.
But you graduated from USM?
Yeah, undergrad.
I see. Which year?
1999.
Oh, I joined 94. Oh, you okay? Are you same batch as Kamrul Imran?
Sorry, I couldn't remember everyone.
Okay, very good.
Getting old already.
Well, no, you are still young. You are still young. Dr. Adam has improved. I mean, he does very well. Dr. Adam, I saw him many years ago, very young chap. Now very good already. Congratulations, Dr. Adam.
Thank you so much, Prof. I follow your footsteps.
Thank you.
Okay, Azifah, just now.
Okay, 1, 2, 3, smile. Okay, done.
Okay.
Okay, thank you everyone.
Thank you.
Yeah.
Bye.
Bye.
See
Thank
you.
you,
Assalamualaikum.
Prof.
Bye. Bye.